Hello guys, so how are you all? After a long time, we are meeting again. Hi Osama, hi Gaurish, Muskan Kapoor, good evening Muskan. Hello Dr. Benedict, good evening Osama. Lav Kumar, good evening Lav Kumar. Surendra, good evening. Yes, Deepak will also provide the PDF also. Yeah. Abhay, good evening Abhay. Hi Atira. Shahi, hello. Neelamegam, good evening. Right guys, so good evening Uncle. Good evening Glory Angel. Good evening, all of you. Really happy to see. Yes, Dr. Surya, the PDF is this one, so I cannot send you the empty PDF, right? So once it is full, then I can send you the PDF. And how will I send you the PDF is that I'll provide a link here down, okay? So in that link, I mean the Telegram link, there immediately after the class, within half an hour, you'll get the PDF, okay? Fine. So guys, hi Aruba. Hi Vishnu, hello. So all of you guys, I know most of you here are preparing for your FMGE, maybe all of them, right? So you basically have very less time, right? So you can count it on your fingers how much time you have. But I know how much pressure you might be right now under, okay? So you are under intense pressure because you have to cover up all the 19 subjects, and I'm telling you need not to study all the 19 subjects. You can leave 3 or 4 subjects and that would be fine. But important thing what I'm telling you guys, we have got, all of you listen carefully now, all of you listen carefully, we have got clinical subjects, we have got non-clinical subjects, right? Now how many questions can we anticipate from the previous years or the previous topics? I mean, how many questions will be repeated from the previous years? See, as far as clinical is concerned, there is no guarantee. I'm not telling you that you won't get repeated questions from the clinical, you will get, but very few, because clinical is completely conceptual, right? So no matter how many times you give the paper, no matter how many times you study the subject, every time there is going to be a new clinical question. But when it comes to a non-clinical subjects like anat, let us say micro, biochemistry, physiology and all, in these subjects, you can anticipate the questions. See, for example, definitely there will be question on nerve injuries. All of you know, even you know and I know, everyone know, right? But they cannot change it, they cannot twist it, right? Now, no one is going to ask you, who is the father of Ulnar now? No one will ask you those questions, right? So whatever is there, whatever material is there, whatever little amount of material is there, let us say on ulnar now there are 3 or 4 points. So only those will be asked again and again. So what I'm telling you is that preclinical subjects, whatever are there, they are the scoring subjects for you. So if you get a good grasp of these preclinical subjects, then definitely in the clinical, even if you get, 50, 60 marks, then you'll definitely pass. That's what I'm telling you. Did you all understand? Yeah. So today I'll be teaching you anatomy, and after that I'll be teaching you the microbiology on 17th. What I can guarantee you that guys is that, I mean, first thing is that I'm not going to teach you everything because I've cut down all the junk, and whatever material is important for you, whatever material has been asked again and again and again, so that material I'm teaching you now. So after this class guys, I'm telling you definitely 80%, I mean around 70 to 20 questions will come to your exam. 80% of the questions you will see in the exam. Okay, definitely I'm telling you, because all the important materials, all the important points, whatever are there, so I've included all of them, and I can guarantee you definitely you will get 80% from the material which I have taught. Okay, right? So what I want you to do is that guys, what I want you to, I'm not lying guys, there is no need of lying. What I want you to do is that guys, just be with me till the end of the session. Okay, and after the end of the session, definitely you will feel that you have learned something, you have gained some knowledge. After that, you go and do MCQs if you want. Okay, right? So shall we start guys, shall we start? See, the session might be 4 or 4.5 or 5 hours, whatever it might be, but I want complete attention from you guys. Whatever I'm asking, please answer me. Okay, and second thing is that don't go anywhere. Thank you Abhay. So let's get started. So blindly follow whatever I'm teaching you and write down, jot down all the points. Okay, And don't worry regarding the PDF. Everyone is asking about the PDF. Definitely, immediately after the lecture, I will share this PDF onto the Telegram group within half an hour. And whoever is not on Telegram group, I'll provide the link immediately first, and then I'll share the notes. Okay, right, guys. So let's start, guys. Let's start these 5 precious hours of your time. So look here. First important thing is that I'm not going in detail now. First important thing is that let us discuss about the upper limb. Now, before we enter into the upper limb, what questions can be asked from the upper limb? Okay. So, what questions can be asked from the upper limb is that first question that can be asked from the upper limb is regarding the introductory, the embryology part. What is that? Look here. All of you know we have got germ layers, right? So, let us say this is one germ layer, this is another germ layer. Okay. For example, this germ layer is called as ectoderm. This germ layer is called as endoderm. Okay, one is called ectoderm and the other one is called as endoderm. Then what is in between? In the between you have got mesoderm. Okay, so this is called mesoderm. Yes, Shivani, it covers the whole topic. Don't worry. Dr. Surya, don't panic. I'll be teaching you at the end. You can figure it out. Okay, very good, guys. Now, in the center, you have got this neural tube. In the center, whatever is there, that is called as neural tube. Just below the neural tube, this one is called as notochord. What is this called as? Notochord. Okay. Now, on either sides of the neural tube, these red color things, whatever I'm writing here, these are called as neural crest cells. Now you should know what are neural crest cells, because later on we also have got repeated questions from these neural crest cells. So these are called as neural crest cells. Okay. Next important thing. Yeah. So next important thing is that here we have got some part of mesoderm. Okay. It is not rounded. Entire thing is a mesoderm. In the mesoderm, on the complete edge region, we have got some parts. This is called as lateral mesoderm. What is this called? Lateral mesoderm. Obviously, this is also called as lateral mesoderm. Okay. Next important thing is that you have got another part of mesoderm. Here. What is this called as? This is called as paraaxial, means on either sides. Okay. This is called as paraaxial mesoderm. All of you guys, please be attentive, because after this topic, I'll be even going with the questions also. I have already kept the questions for you. So this is paraaxial mesoderm. Now, in between lateral mesoderm and paraaxial mesoderm, whatever mesoderm you will have, that is called as intermediate mesoderm, right? Whatever mesoderm you have in the center, this is called as intermediate mesoderm. This is called as intermediate mesoderm. Okay. So what are you trying to tell me? What am I trying to tell you is that in mesoderm we have got 3 parts: lateral mesoderm, paraaxial mesoderm, and intermediate mesoderm. So lateral mesoderm in the future, what is it is gonna give you? See here, lateral mesoderm in the future, what will it form, guys? Anyone? Yes, Abhishek Verma, it will stay on YouTube, but I want you to stay till the end of the session, because whatever doubt you ask, I'm going to clarify it, okay? So, can anyone tell what does lateral mesoderm form? Very good, Muskan. Excellent. Lateral mesoderm will form upper limb. Listen, guys, this is an anticipated question. Very, very, very important question. If they are going to ask you regarding the embryology of upper limb. Upper limb as well as lower limb. So lateral plate mesoderm will form upper and lower limb. Okay. Then we discuss paraaxial mesoderm on both the sides. So paraaxial mesoderm will form your skeletal muscles. Okay. Next, we have got intermediate mesoderm in between both of them. So intermediate mesoderm is gonna form anyone, any answer? Jesli, very good. Osama Sheikh, excellent. Very good, Abhay. Cheniara, perfect. Ankit Pandey, you're right. Intermediate is going to form genito-urinary system. Okay. Now, there was a question that was repeated. Now look at this question, guys. Look at this question now. Let me zoom it out. Right. Now answer me this question. What will be the answer? Lateral plate mesoderm and paraxial mesoderm are the derivatives of, yeah. So what are you gonna derive from lateral plate mesoderm and paraxial mesoderm? Yes. I'm waiting for your answers. Very good. Very good. Excellent. Excellent. And excellent. So they are answering upper limb as well as skeletal muscles. So lateral plate mesoderm is upper limb and paraxial mesoderm is skeletal muscles. Very good. Now this is a little bit simple question, guys, but they can directly they can give you name of some muscle, or in the upper limb some structure they'll give you and they'll ask you this question. Okay, right. Anyways, all of you should know one thing, that our upper limb, right, the development of our upper limb will start at the end of 4 week. Okay, at the end of the 4th week the upper limb development starts. And when does the lower limb development starts? It starts in the starting of the 5th week. Okay, so let me make these two sentences clear. Upper limb development starts at the end of 4 weeks, whereas the lower limb development starts at the beginning or the beginning of 5th week. Okay, so these 2 points are also important because there was already a question that has been asked. Okay, Atira, is it blurred? Still it is it blurred? Am I audible and visible to everyone, guys? And the note here, everything is, yes, Prahlad Patel, you're right. Right, can you see this, everyone? Okay, fine. So Atira, maybe the internet connection might be a little weak for you, so please watch about that. So true or false statements, guys. Development of upper limb starts at the end of 3rd week. But anyways, you tell me the answer. What will be the second one? Development of upper limb starts at the end of 3 weeks. This is wrong. Development of upper limb starts at the end of 4th week. Yeah. Yes, this is right. And development of lower limb starts at the end of 5th week. No, in the beginning of 5th week. Development of lower limb starts at the beginning of 5th week. Yes. So answer B and E, both of them are true. Remaining all are false. Okay. Right. Next important thing. Next important thing is that I have already told you, on either sides of the neural tube, we have got something called as neural crest cells. Neural crest cells. Okay. Neural crest cells. Now, what are the derivatives of these neural crest cells? What are the derivatives of neural crest cells? Now, how do you remember this is? Remember by a mnemonic, N-O-P-E, nope. Remember by a mnemonic, N-O-P-E, no. Okay. What does NO stands for? Nocytes. What nocytes? Melanocytes, right? Melanocytes. And what does N also stands for? Schwann cells. All of you know what are Schwann cells, right? Next important thing, what does O stands for? Odontoblast. It means melanocytes, Schwann cells, odontoblast, all of them are coming from the neural crest cells. Odontoblast. Odontoblast cells. Okay. Next, what does NO, I think P, right? What does P stands for? See, how many structures do we have on P, guys? In the brain, we have something called P that is covering the brain. What is that? Yes, pia matter. Not only that, even arachnoid matter. Pia and arachnoid matter. Okay. Not only that, we also have parafollicular cells. Parafollicular cells of your thyroid gland. Parafollicular cells of your thyroid gland. Not only that, the last P stands for the parasympathetic ganglia of your gut. Parasympathetic ganglia of which region? Of the gut region. And finally, E stands for endocardial cushions. endocardial cushions. So if someone asks you what are the derivatives of the neural crest cells, so these will be the derivatives of neural crest cells, guys. N means nocytes. Nocytes are what nocytes? Melanocytes. Okay. And N repeats in squamous cells. Okay. Next O, that is odontoblast cells. P means parafollicular and parasympathetic. Right? Para. What is two paras? Parafollicular, parasympathetic. Okay. And finally E stands for endocardial cushions. Okay. Why did I tell you this? Because there was a question repeated in 2017. Namaskar Rishi Raj. 2017. What is that question? Chromaffin cells. Right? Chromaffin cells are derived from. From where are these chromaffin cells derived? Let me also put one more N. Chromaffin. Okay, chromaffin cells. Now, very good. The answer is neural crest. Answer is neural crest. But can anyone tell me where are these chromaffin cells located? Anyone tell me where are these chromaffin cells located? Yes, guys, answer fast. Where are these chromaffin cells located? Any idea? Excellent. Ayesha Fidros, perfect. Adil Mobin, excellent. So they are located in adrenal medulla. They are located in adrenal medulla. Perfect, guys. So far you have learned what are the different parts of mesoderm and also about the neural crest cells. Okay. Now let us start. Regarding the clavicle. So what questions can be asked from the clavicle? They won't ask you what is the shape of the clavicle, right? They will ask you where is the most common site for the fracture of clavicle. Okay, this is the most anticipated question, guys. So what is the most common sites? I put a line over here. Yeah. So it is medial 2/3 as well as lateral 1/3. So where is the fracture site of the clavicle? Yes, Zainab Aryan is also is telling that wherever both the junctions meet together, yes. So there is a concavity, there is a convexity. So where is this concavity and convexity meeting together? So that point is the fracture line. That point is the most common line which is prone to clavicular fracture. Okay. But one very important thing other than this I want to tell you. Okay. One question is covered, guys. Another important thing I want to tell you is that question examiners can also ask you like this, because examiners know that all of you know where is the fracture site. So examiners will ask you like this, that what will, after the fracture, what will happen to the medial 2/3? Will it be displaced upwards or will it be displaced downwards? This is the clavicle fractured. So will the medial part go up or will it go down? The same way with the left one also, will it go up or will it go down? Adil Mobin is telling, sir, ये last year का question है. Yes, yes. Very good. Osama, Ayesha Fidros, perfect. All of you look here, guys. All of you look here. Near the medial 2/3, above here, we have got a muscle, right? So this muscle is called as sternocleidomastoid muscle. So obviously when the fracture fragment breaks down, the muscle will contract and the medial 1/3 is lifted up. In the same way, Lalit Moria, good evening. In the same way, coming to the lateral 1/3, look here very carefully. Here, let us say we have got our scapula. Okay. We have got our humerus bone like this. Okay. And here we have got a muscle. Now, what is this muscle, guys? This muscle is called as teres major as well as pectoralis major. I will tell you about teres major and pectoralis major later, but just for now, trust me that there are two muscles, teres major and pectoralis major. So they are attached to the lateral 1/3. So obviously they are pulled downward, right? So the weight is impended like this from the humerus to the scapula, from the scapula to the lateral 1/3. Now, where does the lateral 1/3 fragment go is downward as well as medially. Okay, downward as well as medially. So the medial 2/3 displaces upward and the lateral 1/3, it displaces downward and medially. Why? Because of teres major as well as pectoralis major. So these are the things, guys. These are the things. You might also think maybe they can ask you questions from the primary center, secondary centers. They are not that much needed. They're not that much needed. If you want, just remember that in the center we have got two red dots, right? These are called as two primary centers. On either side we have got blue dots. They are called as secondary centers. Okay, it's not that important anyways. These are the important things which I told you. Right? Now, let us go on to the scapula. Let us go on to the scapula. All of you look here. In the scapula, obviously there are not much questions that are asked, but only one important thing you need to know is that how many primary centers are located, how many secondary centers are located. There is only one primary center. Where is that? In the center of the scapula, like this. And how many secondary centers are located? There are 7. Okay. So as far as scapula is concerned, so these are the questions that can be framed. Is it blurred? Is it blurred, guys? Muskan Kapoor is telling it is blurred. Or clear? Everything okay? Bivish, many of them are telling it is blurred. Right, right. So all of you guys, please increase the resolution so that it would be fine. Right. So let us start now. Now regarding, yeah, it is clear. Regarding the scapula, all of you now look here. Regarding the scapula, only one question. If they want to ask you, they'll ask you that one clinical question, guys, but that is not that important. What is that clinical question is that, guys? Basically, during 9 to 12 weeks, scapulas, they develop in the cervical region. Okay. From the cervical region, both the scapulas, they descend down. From the cervical, they descend down onto the back. So when are they descending down? During 9 to 12 weeks of gestation. But if one scapula doesn't descend down, one descended down and one scapula remains there only, that condition you call it as springal deformity. So this condition you call it as springal deformity. Okay. Anyways, if they ask you in anatomy, that is well and fine. But if they ask you in ortho, we have cleared it here itself. Okay. Lalit Moria, not winging of scapula. Winging of scapula is different. Okay. So this is springal deformity. Now the question is which week, all of you look here. The question is which week does the scapula descend from the cervical region? Which week? During 9 to 12 weeks. During 9 to 12 weeks, the scapula descends down from the cervical region. Very, very important. Very good. Appikatla Ganesh. Excellent. Now, let us enter into the major part. What is that major part? We have got, very good, Priyadarshini, Lalit Moria, look here now. We have got something called as humerus. Okay. If you look on the humerus, one very important, these two things. On the humerus, we have got two lips. One is called as medial lip, another one is called as a lateral lip. Okay. So there are two muscles that are attached to these two lips. And in between these two lips, whatever this empty space is there, right, that is called as the groove. You call it as what groove? Bicipital groove. Okay. Now look here. Let us say this is the lateral lip. This is the medial lip. All of you will be confused in the exam because under such high pressure cooker time, you will be confused, guys. So let me solve this. Look here now. Lady. Who is a lady? LA stands for latissimus dorsi. So latissimus dorsi is inserted onto the bicipital groove. Bicipital groove. Okay. Second important thing, you will be confused between which is on the lateral side, which is on the medial side. So for that thing, I'm telling you one thing, that on medial and lateral, there are majors. There are majors. You know that. Now, What does ME stand for? ME stands for medial side. On the medial side, there is a major with a name T. T means teres major. So on the medial side or a medial lip, we have got teres major. But whereas on the lateral lip, we have got the other major that is called as pectoralis major. Pectoralis major. So we have got two majors. One is called teres major, pectoralis major. Guys, because when I was a student writing this exam, I was so much confused between where to put teres major, where to put pectoralis major. So did you understand this, guys? Yeah. Understood, everyone? Right. Next important thing. Next important question. So this is one question. Next important question is that if you look at the humerus, see, this is called as the, what is this called? This is called as the surgical neck of the humerus, right? So near the surgical neck of the humerus, you have got a nerve. Now, what is the nerve that is completely covering the surgical neck of the humerus? That is called as axillary nerve. That is called as axillary nerve. Okay. So where is axillary nerve? In the surgical neck. Surgical neck. And this is one MCQ. Another important thing you need to know is that axillary nerve basically supplies two important groups of muscles. It supplies two important groups of muscles. One is called deltoid. Another one is called as teres minor. Teres minor. Okay. Now, what is the function of deltoid? If deltoid is getting contracted, my arm is abducting. So, it is also responsible for abduction of arm. And teres minor is responsible for lateral rotation of my arm. Lateral rotation of my arm. Now, why did I tell you this? Because in the paper, they will be telling you that a patient got a fracture of humerus and there was no abduction and there was no lateral rotation. So, which nerve might be damaged? So, obviously, it will be axillary nerve, right? So, if you look at an X-ray of this, if you look at an X-ray of this, you can see the fracture of, you can see very clearly the fracture of the surgical neck of the humerus. Now, look at the question here. A 48-year-old male returns to your office 8 months after sustaining a proximal humerus fracture. See, proximal humerus fracture that was successfully treated. However, he is still having persistent anterior shoulder arm pain that worsens with most activities. He has not done any physical therapy, not received a corticosteroid. What nerve passes along the surgical neck? What nerve passes along the surgical neck? All of you answer down. I'm looking at your comments. Very good. Very good. The answer will be axillary nerve. Let us move on to the next thing, that is the radius and ulna. Now regarding the humerus, only this question can be asked, guys. Later on, I'll tell you all the nerve injuries and the fractures as well. So as we are going through, regarding the radius and ulna, only one thing you need to know is the fractures. Okay. So as you can see here, there are fractures here. Now, what is this fracture? All of you keep in mind. There are two types of fractures. One is called as Colles fracture. Okay. There is another type of fracture that is called as Smith fracture. One is called Colles, another one is Smith. Very good. Very good. Now, how to identify Colles and how to identify Smith? Colles fracture in the sense, look here, this is called as the radial head. This is the head of the radius. Always remember, in Colles, the head of the radius projects downwards. It is displaced downwards. But if the head of the radius is displaced upwards, that is called Smith fracture. Right? In the next X-ray, you can see the head of the radius is displaced upwards. So it is called as Smith fracture. Okay? So this will be radial head displaced downward. Smith fracture in the sense, radial head displaced upwards. Clear? Very good, Lalit. Yes, in it will be different there. So now you will tell me what is this fracture and what is this fracture, guys? Very fast. See, the fragment is displaced upwards here. Very good. The fragment is displaced upwards, so it is called colis. Here the fragment is displaced. Is it colis? The fragment is displaced upwards, so it is Smith. And here the fragment is displaced downwards, so it is colis. Okay. Second is colis. Very good. Excellent, guys. So these are the mostly two common questions that will be asked. Other than this, you need not to know anything, right? And next, very important question, very important question, highly anticipated question, guys. That is nursemaid elbow, right? As you can see here, this is your humerus, right? And next thing is that this is your radius and this is your ulna. On the head of the radius, there is a ligament. This is the head of the radius. There is a ligament completely binding the head of the radius. This ligament is called as annular ligament. What is this called? Annular ligament. Okay. Now, this problem, whatever I'm going to tell you, this basically is seen in 1 to 4 years, children of age group 1 to 4 years. So what you do is that if you are lifting the hand of the child and suddenly lifting him up, right, so that the entire weight is impended upon the elbow here. So when you are suddenly lifting him up, what will happen is that this ligament will undergo subluxation. It means there will be displacement of this annular ligament. Okay. So in this, what will happen? Subluxation of annular ligament. So this is the only thing you need to know. And what is the name of the ligament? That is annular ligament. Which age group do you see? 1 to 4 years. Clear, everyone? Right. Very good. Now look here. Next important question that can be asked is that if you look at the arm of this child over here, you can see it is completely disfigured like this. If you look at the x-ray of that, see here, it is completely making a curve like this, right? So there is bowing. What is there? There is bowing of, yes, it is important, guys. All of you look here, it is important. Okay, right. So there is bowing of the radius bone. This bowing of the radius bone is called as Maid-Lung deformity. Maid-Lung deformity. Okay, Maid-Lung deformity. So they can give you an X-ray and they can ask you what is this condition. Very good, Dr. Benedict. Perfect. Now let us discuss some of the important points, guys. Let us discuss some of the important points here. All of you now concentrate. Now you will be answering here, most common fractured bone in the body. What is the most commonly fractured bone in the body? Very good. Excellent. Clavicle is the most common fractured bone in the body. Most common site of the clavicular fracture, obviously, you know, that is in between medial 2/3 as well as lateral 1/3. Okay. Now, another important question is, what is the strongest ligament of upper limb? What is the strongest ligament of upper limb? Very good. Very good. Excellent. Strongest ligament of upper limb is coracoclavicular ligament. Okay. Most common fractured carpal bone, guys. What is the most common fractured carpal bone? That would be very good, scaphoid. That would be scaphoid. And most common dislocated carpal bone, that is lunate. Lunate is the most common dislocated carpal bone. Very good. I'm looking at your answers, guys. All of you are right. Okay. Now, what is the largest carpal bone, guys? What is the largest thing in your body, right? What is that? through which you think, you talk and everything, that is a head. Head in the sense capitate. Very good. Capitate. Okay. What is the first carpal bone to ossify? The first carpal bone to ossify is also capitate. Very good. Can anyone tell what is the second most common fracture of the carpal bone? Yes. First most common, that will be scaphoid. Second most common, anyone? Lunate. Second most common will be not pisiform, abhay, it is lunate. Now, carpal bone which has a hook. Hook is present for hamate. Hamate has a hook. Hamate, H for hedge. Hamate has a hook. Okay. Very good. Now let us directly enter into the muscles, guys. I'm not going to draw each and every muscle. I'm just going to write down the names because that is more than enough. Okay. Now, coming to the muscles, we have muscles in the pectoral region. We have muscles in the scapular region, right? We have muscles on the back. We have muscles on the arm, forearm, as well as hand. We shall discuss the names of the muscles only, and nerve innervations are very important, and what will happen if the nerve has been injured. Okay. Now coming to the pectoral region muscles. First of all, let us start about the pectoral region muscles. Coming to the pectoral region muscles, simple mnemonic you have to remember is 2P, 2S. 2P, 2S. When I tell pectoral, there will be a muscle by name pectoralis. So what are the two P's? One is called as pectoralis major. Okay. Another one is pectoralis minor. Pectoralis minor. When I tell pectoralis major, there will also be pectoralis minor. And what are the two S? One is subclavius. Another one is serratus anterior. Now, out of all these, question can be asked from which muscle? Question can be asked from serratus anterior muscle. Why? The first question which they can ask you from serratus anterior is, it is also called as boxer's muscle. Also called as boxer's muscle. Okay. As you can see this boxer here, you can look at the muscle here, right? So these muscles, these three muscles, what you can see here on the side of the ribs like this, these are called as your serratus anterior muscle. They are also called as the boxer's muscle. Okay. Now, what is the important clinical point I want to tell you is that serratus anterior muscle is supplied by which nerve, guys? Serratus anterior is supplied by which nerve? Very good. Very good. It is supplied by long thoracic nerve. Long thoracic nerve, which is a nerve from your brachial plexus, right? So, long thoracic nerve. It is supplied by long thoracic nerve. Now, what will happen is that while you are boxing, if someone gives a sudden blow to your lateral side of the chest here near the ribs, what will happen is that this nerve might be damaged. When this nerve will be damaged, then what will happen is that patient's scapula will be winging down. This is called as winging of scapula. Winging of scapula. Right, guys, all of you look, I'm telling you, this is the most anticipated question. Very, very, very important question. And you know, not only winging of scapula, they can also ask you one more question. You know what is that? In case of Erb's palsy, all of you know what is Erb's palsy, right? C5, C6 injury. All of you look here, C5, C6 injury is called Erb's palsy. We'll discuss that. In Erb's palsy, which nerve is not damaged? Actually, from C5, C6 and C7 also, this long thoracic nerve will come out. I'll show you how. But in Erb's palsy, long thoracic nerve is not disturbed. It is not injured. Okay. So, which nerve is spared in Erb's palsy? Which nerve is spared in Erb's palsy? That will be your long thoracic nerve. Which nerve will be spared in your Erb's palsy is long thoracic nerve. Okay. This is the only thing you need to remember. So, we are done with the discussion of serratus anterior. Let us discuss about pectoralis major. You need not to remember origins and insertions because no one is going to ask you origins and insertions. Okay, but for just for the teaching sake, I have just drawn a muscle with the origins and insertions. If you want to remember, you remember, or else no. This is just like an extra edge. But one thing you have to remember is that this muscle which you are seeing right now, this is pectoralis major. And where is this pectoralis major attached, guys? Anyone? We have already discussed. Lateral lip of bicipital groove. Lateral lip of bicipital groove. So this is only one important thing you need to know. Okay. Now another important thing is that what is the action of this muscle? And all of you remember pectoralis major is the main chest muscle, right? So it is a very famous muscle. So it is a very famous muscle. What does famous stand for? F stands for flexion. F stands for flexion. A stands for adduction. And M stands for medial rotation. M stands for medial rotation. Okay. So these are the three important things which you need to know. Okay. Flexion, adduction, as well as medial rotation. Okay. So these are the three important things which you need to know. How do you remember? By a mnemonic famous, FAM. Okay. Second important thing is that lateral lip of bicipital groove. That is the second important thing. That's it. Okay. Are you all understanding, guys? Let me know. Are you all understanding? Yeah. Okay, fine. So let us continue, guys. Let us continue. Pankaj Yadav, yes, I understand that it is little fast, but we have a lot of portion to cover up. So that is why I'm going a little bit fast. Okay, because we have got only 4 to 5 hours of time. Right. Now, another important thing, what is the function of pectoralis minor? What is the function of pectoralis minor? Look here, protraction of scapula. Protraction of scapula. Okay. What is the function of subclavius? Where is subclavius? Subclavius is below your clavicle, right? Clavicle is attached to scapula. So if I'm pulling the muscle down, even scapula will be pulled down. So can I tell it as depression of scapula? Depression of scapula. Okay. Depression of scapula. Very good, Pankaj. Excellent. Very good. So this is the serratus anterior muscle, guys. Just have a look at it. Just have a look at it. That's it. Need not to remember origins and insertions because no one is going to ask you. Just look at it. This condition here, you call it as, yes, they won't ask you what is this condition called as. They will directly ask you which nerve is involved here. So obviously it is long thoracic nerve. Long thoracic nerve, and this condition is called as winging of scapula. Scapular winging. Okay. So look here, there was already a question that is asked. I've just put a screenshot of that. Which nerve is involved in this presentation? The answer, direct answer is long thoracic nerve. Okay, long thoracic nerve. Now, the similar questions were asked again and again. Winging of scapula is due to the damage of which nerve? Long thoracic nerve. Again they asked this question. Winging of scapula is due to the paralysis of which muscle? Serratus anterior muscle. So only it means this can be a highly anticipated question, guys. So don't confuse it. Don't confuse this. Okay, it is long thoracic, winging of scapula, serratus anterior. 3 words to remember. That's it. Okay. So guys, now next we shall go on to the scapular region. In the scapular region also you have got a lot of muscles here, but before discussing all those muscles, let me finish up this. There are 2 functions. One is called as protraction, another one is retraction. When I'm doing like this, this is called protraction. When I'm doing like this, this is called as retraction. So all of you remember the major subject PSM, right? which is very difficult and very hectic to remember. What does P stands for? P stands for protraction. What does S stands for? S stands for serratus anterior. Then what does M stands for? Major. What major? P means pectoralis. Pectoralis major. Pectoralis major. Okay. Yusuf Barki, don't worry. I'll be taking the microbiology session on 17th. Right? So because of this schedule, I was not able to take that session, but I'll take it on 17th. Okay. And after that, we shall continue regular classes. Now coming to retraction, how to remember these muscles? How to remember the action? Look here. Retraction R and TRA. Remember these two things. R stands for rhomboid muscle. R stands for rhomboid muscle. Whenever I tell rhomboid, there are two types of rhomboid. Rhomboid minor, rhomboid major, you know that. Next, traction, TRA. What is a muscle that is named with TRA? That is trapezius. Okay, that is your trapezius. So protraction of scapula, retraction of scapula, they are very, very important. They can just ask you a simple question like that, right? So protraction, PSM, retraction, R, and traction. Okay, so these are the important things you need to remember. Okay, so you told me the muscles of the pectoral region. Now can you tell me what is the nerve supply here? Simple thing, guys. All of you now concentrate whatever I'm teaching. Nerve supply is very easy. All of you know alphabets A, B, C, D, E, F, G. You also know L, M, N, O, P, right? You also know L, M, N, O, P. L, M, N, O, and so on. What does L stands for? L stands for lateral and medial pectoral nerve. Lateral and medial pectoral nerve, because it is supplying your pectoralis muscle. What does M stands for? M stands for medial pectoral nerve. Medial pectoral nerve. Pectoral is common. Subclavius, right? N stands for nerve to subclavius. Nerve to subclavius. And no need to tell you what is O. What is O? O means long. What is that long? That is your long thoracic nerve. Long thoracic nerve. So you are even done with the supply, I mean the nerve innervation as well. So have you understood this thing, guys? Yeah? Right. The next important thing and highly anticipated question, very important question is regarding your axilla. Regarding your axilla. Okay? I'm not telling you something new here because you already know axilla is how important, and contents of axilla are very important, and even the boundaries. Okay? Now, how to remember this axilla? So in this axilla, you have got the humerus, you have got the ribs, you have got the scapula. Okay, this down one is the anterior, posterior, lateral, and medial. Where is the axilla? See, this region is called as the axilla. Okay, this region is called as the axilla. Now let us look at the boundaries. Don't worry. Okay, look here now. All of you, look here. Now, what is this muscle over here, guys? This muscle over here is called as pectoralis major muscle. When I tell pectoralis major, the small one will be pectoralis minor. Okay, pectoralis major and pectoralis minor. Next important thing is that you have got another muscle here. This is called as subscapularis. Okay, and this is called as serratus. Thank you, Monish. Thank you so much. Serratus anterior. This is called as a serratus anterior. Okay, and finally, this muscle is called as your latissimus dorsi. Latissimus dorsi. Now, look here. What are the axillary boundaries? Now, what are the axillary boundaries is that, first of all, let us discuss about the anterior boundary. Anterior boundary. This is the axilla. Look here, all of you. This is the axilla. This will be anterior. Back will be posterior. This will be medial. This will be lateral, right? Anterior, posterior, medial, lateral. Anterior, what muscles I have? Pectoralis major, pectoralis minor. So anterior border of axilla is formed by pectoralis major as well as pectoralis minor. Okay. Next, let us discuss about the posterior border. On the posterior side, what do I have? Scapula, right? So what are the muscles? Subscapularis is one muscle. Okay. Next is latissimus dorsi. And next one is teres major. Teres major. Okay. Sir, it is very difficult. Anterior was easy, but posterior is very difficult to remember. If it is difficult to remember, then remember the mnemonic Tesla. All of you know what is Tesla, right? TSLA. T stands for teres major, S stands for subscapularis, LA stands for latissimus dorsi. Sir, what if I put teres minor? You will not put teres minor because Tesla is a big company, so always the muscle has to be major, teres major, right? So you understood this. Next, let us look at the medial border. Medial border. Okay, medial border. What did I tell you? Anterior, posterior. This will be medial. Now here, what muscle do I have? What is this muscle? Come on, all of you. Okay, I'll put this box for you. Very good, Pankaj Yadav, perfect. This is serratus anterior. Very good, very good. Serratus anterior. And next we have got lateral border. Lateral border. So this will be lateral. Sir, lateral, I think there is only one bone in the center that is called humerus. Yes, but exactly what part of humerus is? Intertubercular sulcus, which you also called as bicipital groove. Bicipital groove. Okay, bicipital groove. Right. Clean. So I think the axilla borders are very, very easy for you right now, right? All the axilla borders are easy now. Very easy. Don't look at the picture, guys. Just have drawn it for your understanding sake, but the way I explained you the axilla borders, it must be easy for you by now. But what are the contents? What are the contents of axilla? So what are the contents of axilla is that, so when I'm discussing about axilla, there will be axillary artery, isn't it? There will be axillary artery. When I axillary artery, along with axillary artery, axillary vein also will be there. Axillary vein. So this is the first content. What is the second content? All of you know. Brachial plexus, how will it come? It will come all the way like this, right? So even the brachial plexus is also present in the axilla. Third thing, sir, you told me about axillary artery, axillary vein. Then will axillary nodes also will be there? Yes. Even axillary lymph nodes also will be there. Okay. And finally, guys, fourth important thing is that, remember like this, guys. I know it is very tricky to remember, but remember in this way. For example, look here. If someone wants to kill you, so let us say they directly stabbed here, right? A lot of infection has entered, a lot of mud has entered. You'll go to the hospital. What is the first test? Whatever disease you might have, whatever you might have, the first test in the hospital, what they do is that complete blood count, CBP, right? Complete blood profile. So remember that way. CBP. CBP. What does C stands for? Coracobrachialis. And what does B stands for? Biceps brachii. And P stands for pectoralis minor. Okay. So these are the three muscles which are also present in the axilla, contents of the axilla. So these are all the contents. Excellent, Zainab. I'm looking at your answers as well, Dr. Bendik. Perfect. Everyone is perfect. Very good. Very, very, very good. Okay. So these are the contents. So guys, if you have understood whatever I told you from axilla, definitely there is a chance, that you gonna get about, either they can ask you the contents, mostly they'll ask you the contents. If not, they will ask you about the borders. Okay, from these two things only regarding the axilla, the questions will be framed. Nothing more than this. Okay, now let us go on to the muscles of the back. Now, when we go into the muscles of the back, I'm not going to explain much detail. I will write down anyways. I will write down the muscles, and it is not that tricky also. You know what is this red color muscle which you can see? That is called as trapezius. And what is this pink color muscle which you can see? That is called as latissimus dorsi. Every one of you know. But what is important and what are they going to ask you in the exam is that not about the muscles. They will ask you the triangles. If you can look closely here, can you find a triangle here? This yellow color shade, whatever I've done, you can see a triangle here, right? What is this triangle called as? This triangle is called as triangle of auscultation. What is this called? Triangle of auscultation. This is called as triangle of auscultation. So, what are the borders of triangles of auscultation? Superiorly, if you see, you will have trapezius muscle. But what trapezius muscle? Inferior border of trapezius muscle. Superiorly, you will have inferior border of trapezius. Okay. Next, inferiorly you will have latissimus dorsi, but the top surface of latissimus dorsi. So, superior border of latissimus dorsi. Superior border of latissimus. Next, base. Base is formed by what? The scapula. Base is formed by scapula. So, this is called as the triangle of auscultation. Why you call it as triangle of auscultation is that this is the perfect place to auscultate for the lower lobes of the lung, okay? Because there is nothing overlapping there. The muscles are overlapped, making a triangle like this. So here if you put a stethoscope and listen very clearly, you can listen to lung sounds, okay? The lower lobe sounds. Apart from this, there is also one more triangle. Can anyone guess? Very good, Zainab. Very good. Can anyone guess what is that triangle, guys? Look here, all of you. You know that this is latissimus dorsi, and this is, what is this? Come on. Anterior side, you have got external oblique muscle. So from the back, if I see, I can see a little bit of external oblique muscle. Okay. So here also, I have got a triangle. Okay, what is this triangle? This triangle is called as Petit's triangle. Petit's triangle. Okay, this is called as Petit's triangle. What are the borders of Petit's triangle? I'm not writing it because by looking at the picture, you know, superiorly you have got inferior border of latissimus dorsi. Inferiorly you have got superior border of external oblique, and even you have got the base is, what is the base made up of? Iliac crest. Okay, three of them form the Petit's triangle. Why did you tell us? Why did I tell you is that Petit's triangle is the main portion for lumbar hernia. Very important. For lumbar hernia. That is why you also call it as lumbar triangle. You can also call this as lumbar triangle. So this is also only two important questions from the back region right now in this slide. What is triangle of auscultation and what is Petit's triangle? These are the two important things that will be asked, guys. Now, look at these questions which are already asked. Triangle of auscultation is associated with all of the following except. What will be your answer, guys? Very good, very good, very good. Except. Come on. Very good. Teres major. Okay, because rhomboid is also located back, right? So it is also associated with the rhomboid. Very good. All of you right. Teres major is completely different. It is not even related with that. Which among Gaurish? It is B. Which among the following is not a border of triangle of auscultation? Which is not at all a border? which is not at all a border? Very good. Nagashri has answered right. It is D. Serratus anterior is on the lateral side here, right? On the medially. Medially you have got serratus. Okay, I'm zooming it. Serratus anterior is here. Okay, here. Fine. Let us go for the nerve supply. Regarding the nerve supply of the back, regarding the nerve supply of the pectoral region, I told you LMNOP. Regarding the nerve supply of the back, you have to remember only one mnemonic, TAN. TAN, TAN. What does T stands for? T stands for trapezius. And what does A and N stands for? A and N stands for accessory nerve. Accessory nerve. Then what about the remaining? Where is latissimus dorsi? It is located on the dorsal side. In which region? In the lumbar and the thoracic region, right? So can I call it as thoracodorsal nerve? Thoracodorsal nerve. Next, rhomboid major and minor, both of them, where are they located? On the back here, near the scapular region, right? So can I call it as dorsal scapular nerve? Dorsal scapular nerve. And where is levator scapulae located? Levator scapula is attached to scapula on the back. So dorsal scapular nerve again. Dorsal scapular nerve again. Yeah. Right. So all of you are clear so far, guys. Before we go to the scapular region, all of you are clear with this? Yeah. Let me have a green signal so that I can further start. All of you are clear with this, guys? Yes or no? Everyone? Zainab, Gaurish, Praveen. Okay. Athar, you're clear, Athar? Yeah. So look here now. Scapular region. Now in the scapular region, we have got 4 to 5 muscles. Okay, 1, 2, 3, 4, 5. We have got 5 muscles. Now what are these 5 muscles? What are these 5 muscles are? You can remember by a mnemonic. D sits, right? So whenever you visit a hospital or whenever you visit anyone, so obviously they'll show a region and doctor come on sit. So that's what you're doing. Doctor sits. What does D stand for? Deltoid. Screen. Can you all see? Screen. Just a second. Just a second. Yeah. Can you all see now? Yes. Now fine. Right. So D stands for deltoid. Next, another important thing. Look here, guys. All of you look here. It is very easy. I don't want you to use your memory a lot. Look here. Above, this is called as a spine of the scapula. Above the spine, we have got muscle. You call it as supraspinatus. Below the spine, I have got muscle. This is called infraspinatus, right? Beneath the spine, back of the spine there, I also have got a muscle that is called, what is that called? That is called as subscapularis. So, two muscles are very easy right now. One is called as supraspinatus. Okay. Another one is called as infraspinatus. Okay. Next one we have discussed is subscapularis, right? Then what about T? What about T is that T stands for teres major as well as teres minor. Teres major as well as teres minor. Now, what is the important question will they ask me? They can either ask you muscles, but more important than muscles, the question they can ask you is, what are rotator cuff muscles? Rotator cuff muscles. So what are rotator cuff here? Yes, tell me. Supraspinatus is a rotator cuff. Infraspinatus is a rotator cuff. Teres minor is a rotator cuff and subscapularis is a rotator cuff, not teres major. It is not teres major, it is always minor. Supraspinatus, infraspinatus, teres minor and subscapularis, all of them are called as rotator cuff muscles. Okay, very, very, very important question. Very important question. Second question they can ask you is, out of all these rotator cuff muscles, which rotator cuff muscle is most commonly injured? That will be your supraspinatus. How to remember that? How to remember that is, whoever is on the top is always under trouble, right? So supraspinatus is on the top, so it is always under trouble. This is the nerve that is most commonly injured. Next, third important question. Third important question is that, look here very carefully now. Look here. Where does supraspinatus insert? Supraspinatus will insert to greater trochanter, right? So this is called as your greater trochanter. Supraspinatus will insert to greater trochanter. Infraspinatus also will insert to greater trochanter. And two more muscles I told you, right? One is teres minor like this. Another one is teres major. Okay. Where will teres minor insert? Teres minor also will insert to supraspinatus. Okay. So how many muscles are inserting to the greater trochanter? Supraspinatus, infraspinatus, teres minor. So greater trochanter, guys, that is the most common one which is prone to injury. Okay, that is the most common one which is prone to injury. And on top of that, supraspinatus is more superior. So that is most commonly injured. Okay. So supra, infra, teres minor, all of them are attached to greater trochanter. There was a question that was asked actually. Okay, very good. So I hope all of you understood this. Yeah. Okay. And one last question you have to know regarding this is that, what is that question is, what is the action of supraspinatus? So supraspinatus is initial abduction of shoulder. Okay, supraspinatus is initial abduction of shoulder. It means supraspinatus will be attached like this. When I'm pulling it, my arm is raising up. Initial abduction of shoulder. Okay. Now coming to the muscles. What are the muscles which we can see here? What is the nerve supply of these muscles? Yes, anyone? Supraspinatus is supplied by suprascapular nerve. Supraspinatus is supplied by suprascapular nerve. Why? Because it is on the top of the scapula. Infraspinatus is also on the top of the scapula. So that is also supplied by suprascapular nerve. Suprascapular nerve. Okay. Now teres minor is supplied by axillary nerve. And subscapularis is supplied by upper subscapular nerve. And another muscle which we missed, that would be teres major. Teres major is supplied by, when I tell upper subscapularis, there will also be lower subscapularis. So it is supplied by lower subscapular nerve. Right? So this is, I think this is very, very easy to remember, guys. Right? Very, very easy to remember. Supraspinatus, infraspinatus on the top of the scapula. So suprascapular nerve. Okay. Subscapularis, teres major. One is upper subscapularis, one is lower subscapularis. That's it. Teres minor, I told you in the starting only. In the starting itself, I told you teres minor is supplied by axillary nerve. Okay. Now, answer me this question. Who will answer me this question, guys, here? 53-year-old man presents to a clinic with a 6-month history of shoulder pain. He is having shoulder pain. Over the time weekend, he strained his shoulder due to a pickup basketball game and reports acute exacerbation of his pain symptoms. On examination, he complains pain to palpation just below the acromion. You suspect he has torn his supraspinatus. So when someone will tear his supraspinatus, what will be the problem? Anyone answer here? If there is a tear of supraspinatus, what will be the problem? Very good, very good, excellent. So the answer, there will be problem with initiation of abduction. Okay, and one more thing I'm telling you, that what causes supraspinatus injury is overuse of your shoulder. If you are overly using, playing basketball again and again, when you are overly using it, that causes supraspinatus tear, rotator cuff injury. Okay, right. So next question, when a 25-year-old patient comes to your practice with the following complaints, he is telling pain overhead muscles. Okay, pain usually gets worse after the activities at night. Okay, shoulder has been dislocated 1 year ago. During the assessment, you notice that the patient has pain when abducting. While abducting, he is having pain. And also the patient's shoulder is clicking and popping during assessment. So when you are lifting the hand, there is a popping sound, there is a clicking sound. Why? Because all the rotator cuff muscles are not properly attached. Why they are not attached? No, guys, it is not pathology. Pathology is different. It is not pathology. It is shoulder instability. It is shoulder instability. Why shoulder instability? Because of weakening of, or because of loose attachment of rotator cuff muscles. Okay, not pathology. Okay, very good, guys. Let us continue now. Let us continue. We are entering into arm. So far, guys, so far whatever I've told you, were you able to memorize it? Is it easy for you? Yeah. Yes, Praveen. Above question is related to abduction. Yeah, Praveen is telling why abduction. Yes, Praveen, you are right. I'm sorry. It is initiation of abduction. Okay. Thank you, Praveen. Apikatla Ganesh, yes, it is Ganesh. It is because of weakening of rotator cuff muscles. Okay. Now we are entering into the arm region, guys. Okay. See, guys, let me tell you one simple thing very fastly. Look here. Upper limb is opposite of lower limb. Keep that thing in mind. When I'm sleeping like this is my anatomical position. Whatever muscles you can see, either in the arm or either in the forearm, these are called as flexors. And whatever muscles you can see on the back here, either in the arm or in the forearm, these are called as extensors. Clear? Okay. Whatever muscle I will tell you from anterior compartment and ask you the function, that will be flexion. Okay. Now, in the arm, we have got anterior compartment, we have got posterior compartment. Now, what are the muscles of anterior compartment? How do you remember it? First of all, write it as flexors. These are extensors. Okay. Remember the mnemonic BBC. BBC stands for British Broadcasting Corporation, right? BBC. What does B stands for? Biceps brachii. Biceps brachii. Okay. Biceps brachii has got two heads. That is why it's called biceps. Short head, long head. All of you know. Next we have got, very good. You guys are already answering me. Brachialis. Zainab, it is supraspinatus, Zainab. We discussed that initiation of abduction is done by supraspinatus. Okay. After biceps brachii, next we have got brachialis. After that we have got C for coracobrachialis. Coracobrachialis. In the same way, in the posterior compartment, we have got triceps muscle. When I tell triceps, you must already know by then that it has got 3 heads. Okay. How do you remember it? Remember it as LML. LML. L stands for long head. M stands for medial head. And another L stands for lateral head. Lateral head. LML. Clear? Now, what is the nerve of anterior compartment? Musculocutaneous nerve. What is the nerve of posterior compartment? Radial nerve. Okay. So, all these muscles are supplied by musculocutaneous nerve. MCQ. What are all these muscles supplied by? Radial nerve. This is also an MCQ. Clear, everyone? Yeah. Another important question that they will definitely ask you is that, guys, root values are very, very important. I'm telling you, just by heart the root values. Okay. I will be telling you all the root values anyways, but I'm telling you by heart the root values before you go to the exam. Biceps. What is the root value of biceps? C5, C6. Biceps jerk root value is C5, C6. Triceps, C6. You know how to remember this? How to remember this? Look here. Biceps means only 2. So, C5, C6. Triceps means 3. 5, what are these 3? 6, 7, 8. C6, C7, C8. Okay. Then what is the radial nerve? That is C7, C8. Not adduction, it is abduction. Okay, JK? It is abduction. Okay. Now, you need not to know all the origins and insertions as I've been telling you again and again. But there will be some particular muscles that they will definitely ask you in the exam that you should know, like biceps, for example, triceps. Okay. So, when it comes to biceps, you have got short head, you have got long head. Now, where does short head start? Short head is attached to coracoid process. Coracoid process. And where is this long head attached to? Long head is attached to supraglenoid tubercle. This is a very, very, very important MCQ. Attachments of biceps and triceps are very important, guys. Very important. Keep a red box if you are writing it. Okay. Look here. This is your coracoid process. And the pink one on the top, this is called as your supraglenoid tubercle. Supraglenoid tubercle, and the lower one pink, this is called as infraglenoid tubercle. Okay. So from here the muscle will come all the way, and this is your biceps muscle. Okay. This is your biceps muscle. So you are clear. Now there was a question that was asked in 2018-19 FMGE that which of the following insertion is shown. All of you know that biceps short head long head is here. It will come all the way and insert to radial tuberosity. It will insert to radial tuberosity. Okay. Now the answer which was, what is the question here? They gave an image. You see, you look at this image, guys. Short head is attached to coracoid process here, and another one is attached to where? Supraglenoid tubercle. And where is it inserting? It is inserting to the radial tuberosity. Very good, Praveen. Excellent, all of you. Very good, Praveen. Osama Sheikh. Perfect, Osama. It is radial tuberosity. Okay. Now, coming to the next one. Long head, medial head, lateral head. Now look here. Triceps long head, where it is attached. Where it is attached, previously we discussed about supraglenoid tubercle. Now we are discussing about infraglenoid tubercle. So infraglenoid tubercle. Okay. Infraglenoid tubercle. Next, where is medial and lateral head attached? Medial and lateral head attached. You know this blue color line over here? You can see. This is called as the sulcus. Intertubercular sulcus. Above the sulcus, medial head. Below the sulcus, lateral head. Above the sulcus, medial head. Below the sulcus, lateral head. So, here medial head is attached, and here lateral head is attached. Clear? Above the sulcus, below the sulcus. Right, guys. Now let us go on to the next important point. Next important point is that, guys, keep this thing in mind. Keep this thing in mind. This is the proximal part. This is the distal part. Okay. For example, all of you look here. For example, if the proximal side, the short head and long head of biceps muscle, right? Short head of and long head of biceps muscle. If that there is a tear in the tendon, then what will happen? The entire muscle is pulled downward. When the entire muscle is pulled downward, there will be a bumpy elevation like this. As you can see in the picture, this muscle is called as biceps, and it is showing what? Popoids muscle. This is called as Popoids deformity. This kind of deformity is called as Popoids deformity. Popoids deformity. Right. Now moving on to very good Sutar, Deep Sutar, perfect. Deep Sutar already told the answer. Very good, Osama, perfect. Another important thing is that regarding the safety triangle, where is your safety triangle present? If you wanted to drain the pus from the chest, okay, if you wanted to drain any kind of fluid from the chest, you will put a chest tube, right? So where is the better position for putting a chest tube? So that triangle which we select here is called a safety triangle. Okay. Now what are the borders of safety triangle? Look here very carefully. This muscle which you have here, this is called as pectoralis major. Okay. So this will be your lateral head of the pectoralis major. Lateral border of pectoralis major. Okay. Next important thing. Here you have got fifth intercostal space. I mean the lower part is fifth intercostal space. Fifth intercostal space. Okay. And back here, what is this muscle? Latissimus dorsi. Okay. So let us say here on the back, a little bit muscle you have got. This is called as latissimus dorsi. And what is this here? This is called as the base of the axilla. You know, this is axilla. This is the base of the axilla. So this is base of axilla. Okay. So all these four of them together, lateral border of pectoralis major, base of the axilla, latissimus dorsi, and fifth intercostal space, exactly in the center, you're gonna put a chest tube and drain the pus. Okay. Whatever pyogenic material is there, you're gonna drain. So this is called as safety triangle. Very, very, very important. Okay. Very, very important. Right. Now let us do a couple of questions, guys. Let us do a couple of questions and then we shall go to the next part. Okay. Which of the following are the borders of safety triangle except, look here, axilla, latissimus dorsi, pectoralis major, pectoralis minor. Pectoralis minor is not a border. Pectoralis major is a border. Latissimus dorsi is a border. Axilla is a border. Perfect. All of you are right. Very good. All of the following muscles are innervated by musculocutaneous nerve except, this was a repeated question. Question's not visible. I'm sorry. Yeah. All of the following muscles are innervated by musculocutaneous nerve except musculocutaneous nerve innervates BBC muscles. B for biceps brachii, B for brachialis, C for coracobrachialis. It does not innervate your brachioradialis. Very good, Zainab. Adil Hussain, perfect. Adil. Jaggi Chaudhary, excellent. Medical Gopal, perfect. All of you are perfect. Okay. Right. During a fight, look here very carefully. During a fight, a man is stabbed in the lateral chest beneath his right arm. Exactly here he was stabbed. Okay. The wound does not enter the chest cavity. Physical examination reveals that the vertebral border of patient's scapula projects and it is closer to the midline. On visit, the patient complains that he cannot reach far forward. Okay, very good, Dr. Benedict. Excellent. The answer will be long thoracic nerve. When you give a sudden blow here, there will be winging of scapula. Okay, winging of scapula. Right. All of you now. Next important thing. Let us go on to the next important thing here. Right. So, can anyone tell me what are the three functions of the musculocutaneous nerve, guys? Yes. What is the first function of musculocutaneous nerve? Biceps reflex. Biceps reflex. Right. It also supplies your flexor muscles. It also supplies your flexor muscles and it also gives sensory supply, sensations to anterolateral side of forearm, anterolateral side of your forearm. Okay, not forearm, the arm region, the arm. Okay, so you know biceps muscle is there, so biceps reflex. You beat here, there will be a reflex, biceps reflex. Next, flexor muscles are here, so obviously musculocutaneous nerve will supply the flexors. Next, it will also give a sensory input to the lateral surface of the arm, the sensations on the lateral surface of the arm. Okay, now tell me the answers here. Now tell me the answer. A man suffers from a penetrating wound through the anterior axillary fold. So this one is here anterior axillary fold. On the back here is a posterior axillary fold, resulting in damage of one of the main terminal branches of brachial plexus. So among the effects, there is a significant weakening of flexion of elbow. Patient cannot flex. Patient cannot flex. So when the patient cannot flex, it means what muscles are damaged? What nerve is damaged? Musculocutaneous nerve. What is the function of musculocutaneous nerve? Look here, guys. What will be the answer here? What will be the answer? See, he is telling that there will be only loss of cutaneous sensation on the anterolateral surface of the forearm. Wrong. Only weakening of flexion at the shoulder. Not only. Look here. Weakening of flexion at the shoulder. Okay. Weakening of flexion at the shoulder. Right. Loss of cutaneous sensation on the anterior surface of the arm. Right. If he also gives that there is no biceps jerk reflex, that will also be right. Clear? Yeah? Dr. Benedict, not C. Not C, not C. It is D. Two functions, flexion and loss of cutaneous sensation on the anterolateral surface of the arm. Okay? Right. So let us study the muscles of the forearm. Yes, Dr. Benedict. Let us study the muscles of the forearm now. All of you, concentrate now. Don't comment down. Don't comment down. Just look at the muscles, because forearm muscles are really tricky and very important. Okay. So in the forearm, I told you all these muscles are flexors. All these muscles are extensors. Their response, these are called as anterior compartment. This is called as posterior compartment. Okay. So that's what I have written here. Anterior compartment, posterior compartment. So in the anterior compartment also, I have got superficial group. When I cut down and remove the superficial, I have got deep group. Superficial as well as deep. Now, I just want you to remember PF. Okay, remember this mnemonic: PF, 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 PF. Okay, what does P stands for? P stands for pronator teres. All of you concentrate here. P stands for pronator teres. What does F stands for? Flexor carpi radialis. Flexor carpi radialis. After PF, again P. P stands for palmaris longus. Okay, palmaris longus. And again, what does F stands for? Flexor carpi ulnaris. Because I have got flexor carpi radialis, so I will have flexor carpi ulnaris. Okay, and there is also one more muscle. I am not discussing it right now. Even in the deep group also, I'll discuss later on. So PF, PF, and again, what is P? P is pronator quadratus. Pronator quadratus. And what is F? Flexor pollicis longus. Flexor pollicis longus. So all of you guys now stop enjoying on the live here, Osama and all. Right? Please concentrate on the class. This is very, very important. So look here, guys. PF, PF, PF is done. Right? Then what are these two boxes? What are these two boxes are? One is called flexor digitorum superficialis. When I tell superficialis, there will also be profundus. So flexor digitorum profundus. So we are done with the muscles of the anterior compartment. Okay, muscles of the anterior compartment. Okay, now all of you look here. All the muscles, all of these muscles, I'm telling you one thing, keep in mind, all of these muscles of the anterior compartment, all of them are supplied by which nerve? All muscles of, this is a statement, very, very, very important statement, guys, because all the entire topic will be discussed on this. All the muscles of anterior compartment of forearm are supplied by median nerve. Median nerve. Except 1.5 muscle. What is that 1.5 muscle? That is flexor carpi ulnaris. That is on the ulnar side here. So that is supplied by ulnar nerve. Flexor carpi ulnaris supplied by ulnar nerve. Okay. Next, what is that half muscle? What is that half muscle is? Flexor digitorum profundus. Flexor digitorum profundus. All of you look here. This is flexor digitorum profundus. Flexor digitorum profundus has got two sides. All of you look. This is called as the radial end, and these two are called as the ulnar end. Okay, ulnar end and radial end. So ulnar end is supplied by ulnar nerve. Okay. Medial half of FDP is supplied by ulnar nerve. Remaining all muscles are supplied by median nerve. What are the nerve injuries? I will discuss in a minute. But before that, I want you to be sure that all the muscles of anterior compartment are supplied by median nerve except 1.5 muscle. That one muscle is flexor carpi ulnaris supplied by ulnar nerve. Half muscle is medial half of FDP supplied by ulnar nerve. Okay. Very, very, very important statement. Very, very important statement. And I'm guaranteeing you guys, if you understood till here, at least 4 questions will be repeated from this part which I have discussed. Okay, at least 2, 3 or 4 questions definitely it will be repeated. The rest from the remaining parts like abdomen, pelvis and all. But from here, at least these questions will be repeated. Okay, so this is the important point. What is the next important point? What is a clinical point which you can tell me about pronator teres? Okay, I'm not lying, guys. I'm guaranteeing you that definitely it will be repeated. After the exam, I'll put all the screenshots. Don't worry. From the lecture which I've taught today, I will put all the screenshots after the exam. Okay. Now, coming to pronator teres. So this muscle here is pronator teres. But why did you draw? Why did I draw is that this nerve which is coming down, this is called as median nerve. Median nerve. You know, pronator teres is like this. Okay. Median nerve is passing all the way through pronator teres. By chance, if pronator teres constricted like this, or if there is over contraction of pronator teres, the median nerve will be compressed, and that condition you call it as pronator teres syndrome. Pronator teres syndrome. Very, very important. Pronator teres syndrome. Which nerve will be compressed? Median nerve. Very good. Very good. Because median nerve passes between this muscle. Another MCQ, right? Now, another MCQ regarding palmaris longus. Where was palmaris longus? This here it was palmaris longus. Another MCQ about palmaris longus is that the tendons of palmaris longus are so long that they can be used for grafting. They can be used for grafting. In the same way, a homologous muscle of palmaris longus. Can anyone tell what is the homologous muscle of palmaris longus in the lower limb we have, which is also used for grafting? Yes, that would be plantaris. Okay, what is that? Homologous muscle of palmaris longus would be plantaris. You know, even plantaris is having some short belly and a long tendon that you can use for grafting surgeries, guys. Don't just overlook it. Plantaris and palmaris longus, very important, guys. Very, very important. Okay, very important. Okay, fine. Now, another highly important thing I'm discussing. All of you pay attention now. Look here. These two muscles which you can see, one is called flexor digitorum superficialis, another one is called as flexor digitorum profundus. Okay, what did I tell you previously? If you divide this flexor digitorum profundus into two halves, this will be the lateral half, this will be the medial half. So what did I tell you? What is that half muscle? In the nerve supply, that half muscle is the median half of flexor digitorum profundus, which is supplied by ulnar nerve. And what is the lateral half supplied by? Lateral half supplied by a branch of median nerve. I will tell you at the end, that is anterior interosseous nerve. I will tell you at the end about complete anterior interosseous nerve. But for now, what you need to remember is median nerve. Okay. So this is FDS, this is FDP. Next important thing. Look, nerve supply, we have discussed it, right? All of them are supplied by median nerve except 1.5 muscle. I discussed it. Now, what is the clinical point? Now, who will tell me this? What is this thing which I have drawn here? What is this X-ray about? Very good. Excellent. You are perfectly wrong. This is not mallet finger. All of you know, all of you keep an attention here. You know that this is distal phalanx. This is DP, distal phalanx. Okay, distal phalanx. Okay, look here. There is a tendon that is coming down all the way like this. If it is coming down, this is the flexor region, right? So there is a flexor tendon that is coming down all the way and attaching the distal phalanx. If I'm pulling the tendon a lot, what will happen? The tendon is attached to distal phalanx, so the tendon will pull the part of the bone. This is called as, what is this called? Flexor evolution fraction. Okay, flexor evolution fracture. This is called as flexor evolution fracture. The other name, very good, Adil has already told, the other name is called as Jersey fracture. Jersey fracture or Jersey finger. Okay, this is called Jersey finger. Okay, now this is one question, and the second question that can be asked for you in the exam is that Jersey finger is because of the over traction of which tendon? Yeah, that is FDP, flexor digitorum profundus. Okay, flexor digitorum profundus. Clear? Flexor digitorum profundus tendon over pulling will cause Jersey finger. Clear? Next important thing, exactly opposite of that. Look opposite of that. What is this picture? The fracture is on the top here. The fracture is on the top. You can see very clearly that a tendon is been broken down, right? There is a cut on the tendon. right? So there is a tear in the tendon. And not only that, you can also see this tendon has pulled away a part of the bone. These are flexors. These are what? Extensors. So what is that tendon? That is an extensor digitorum tendon. Extensor digitorum tendon is causing evolution fracture. Okay. In the previous picture we discussed, flexor tendon is causing evolution fracture. Here it will be extensor tendon. Extensor tendon causing evolution fracture. Evolution fracture. Okay, this is called as mallet finger. This is called mallet finger. Very important for you in anatomy as well as for your orthopedics also. I'm discussing right now, right? So even for your ortho also, this will be very important. Mallet finger and jersey finger. Jersey finger FDP. Mallet finger extensor digitorum. Okay, jersey finger below, mallet finger above. Understood? All of you understood? Be fast. We are about to finish upper limb. Right. Very good. Very good. Very good. Zainab is also telling that mallet finger is also called baseball finger. Yes, Zainab. Mallet finger is also called as baseball because whenever you are playing baseball, you might fracture this finger. Baseball finger. Very good. Now, how to remember this is that what is jersey? Jersey means cow, Jersey cow. Now, how do you take the milk of Jersey cow? You don't sit on the cow and take the milk. You go below the cow and pull it, right? You pull the nippies. You pull the nippies and take the milk. So, below is always Jersey. Above is the opposite of that, mallet, right? So, if you want to remember like this, you can remember it. Formal way of remembering it, okay? Right. So, this will be your mallet finger. So in anatomy, what question can be asked is that in mallet finger, there will be flexion of distal interphalangeal joint. This is distal interphalangeal joint. This is proximal interphalangeal joint. So there will be flexion. There will be flexion of this distal like this. There will be flexion of this distal interphalangeal joint. So this is also called as swan neck deformity. Swan neck deformity. So these are all the questions, guys, which are asked from this part, right? So these are all the questions which are asked from this part. After this, I'll be taking the abdominal part, guys. Right. The next important thing, Yogesh, fine. The next important thing is that if you look at your arm like this is the humerus bone, okay? Now, this will be your medial epicondyle, this will be your lateral epicondyle. Inflammation of medial epicondyle is called as golfer's elbow. Golfer's elbow. This is an MCQ. Inflammation of lateral epicondyle is called as tennis elbow. Tennis elbow. This is also another important MCQ. One is golfer's elbow, another one is tennis elbow. Not ulnar nerve damage, Zainab, not fracture. I told you that is just inflammation. Okay, right. Next important question. What is the next important question? This tendon which you can see in the hand, this is a palmaris longus tendon. And in between the tendons, this blue color thing, whatever you can see, this is called as palmar aponeurosis. Palmar aponeurosis. Sometimes what will happen is that on the medial side of palmar aponeurosis, there will be excess amount of fibrous tissue that will be deposited like this. On the medial side, there will be excess amount of fibrous tissue that will be deposited. So when it will be deposited like that, what will happen to the patient is, look here in the next picture, this is how the finger becomes. This is how the palmar surface becomes. What is this condition called as? This is called as Dupuytren's contracture. Dupuytren's contracture. Okay, this is called Dupuytren's contracture. Very important. Dupuytren's contracture is because of Because of what? Because of which involvement? Medial aponeurosis. Medial aponeurosis fibrosis will lead to Dupuytren's contracture. Very, very important, guys. Remember this. Very important. Okay, right. So there was a question that is asked here. What is this? Carpal tunnel or trigger finger or mallet finger or Dupuytren's contracture? Yes. What is this type here? Yes, Novo Martin is telling, right? Fibrotic changes of medial aspect. You're right, Novo Martin. So the answer will be Dupuytren's contracture. Clear? Right. Now let us discuss about the extensors of the forearm. All of you look. Now we shall be discussing about the extensors of the forearm. Now regarding the extensors of forearm, very good, Gaurish, Afreen, Zainab, perfect. Harish Reddy, you are right. Anjana Paul, you are right. All of you are right. Now regarding the extensors, very simple thing. If they ask you what is the common flexor origin, medial epicondyle. What is the common extensor origin, lateral epicondyle. So now we are discussing about Jaggi Chaudhary about lumbricals and intraossei. After this, immediately I will discuss. Okay. Now look here. There is a muscle that is attached from the common extensor point, and it is going on to the radial side. So from the brachium, it is going to the radial side. Brachioradialis. The first muscle is brachioradialis. Okay. Next, another muscle starting from the extensor point, that is the lateral epicondyle. From the extensor point, this muscle is going all the way like this, entering into the carpal bones onto the radial side, and it is inserting there. So what is this muscle should be called as? Obviously all these muscles are extensor muscles. So it is extensor. Okay. Yes. Very good. Extensor. It is going towards the carpal bones onto the radial side. So carpi radialis. It has got a long tendon, so longus. Okay. The same muscle, extensor carpi radialis brevis. Clear? Next, from the extensor point, the muscle is coming all the way like this, and it is inserting to all the digits. So extensor to digits, extensor digitorum. Extensor digitorum. Okay. Next, from the extensor point, the muscle is coming all the way like this, and it is attaching to your little finger. Little finger in Latin you call it as digiti minimi. So extensor digiti minimi. Extensor digiti minimi. And finally, from the extensor point, it is taking a turn like this, coming onto the ulnar side, crossing the carpal bones on the ulnar side, and it is inserting there. So it is called extensor carpi ulnaris. And finally, you have got a small screwing muscle that is called as anconeus. So anconeus is what? Anconeus is very important. This is asked in the exam and again. That is, what is a screwing muscle? Anconeus is a screwing muscle. Then what is the nerve supply of all of them? All of them are supplied by radial nerve. I told you in the arm also, backside, pura radial nerve supply kiya tha. Even in the forearm also, here also, pura radial nerve supply karega. Fine? Right. Now, look here now. We are entering into the main topic now, guys. That is the nerve injuries. All of you concentrate now. Don't write anything. Just listen to whatever I'm telling you. Okay? Look here. This is the humerus. Now, in this humerus, we have got lateral epicondyle. We have got medial epicondyle. Okay? The nerve that is passing behind the medial epicondyle is called as ulnar nerve. And I'm telling you, right now I'm telling you guys, that from these nerve injuries, 2 questions will definitely come from these nerve injuries. Either it might be orthopedics or anatomy. Two questions will definitely 100% two questions will come from nerve injuries. Two questions are right now in your pocket, guys. Right now, if you understood this, two questions are in your pocket. Okay. Ulnar nerve passes behind medial epicondyle. अगर medial epicondyle fracture हुआ, then ulnar nerve will be damaged. Same thing. Again, the next nerve. This nerve is called as the radial nerve. Radial nerve. What is radial nerve? Radial nerve is making a turn like this. Okay, from the mid shaft of the humerus, radial nerve is taking a turn from the radial groove. Agar if there is a fracture of the middle part of the humerus, mid shaft fracture we call it. Okay, radial nerve gaya, so damage to radial nerve. Right. Next important thing. This nerve is called as median nerve. Where is median nerve passing? Just above the condyles. Just above the condyles. That is, this region is called supracondylar region. Supracondylar region. Just above the condyle, if there is a fracture, median nerve will be damaged. Okay. So these are the very, very important questions. Very, very, very important. They can give you X-ray and ask you. Okay. So very good, guys. And one more important thing I want to tell you is that out of all these three, look here, the most common fracture of the humerus is supracondylar fracture of the humerus. Okay. So the most common fracture is supracondylar fracture. Okay. Mostly, how do you get this fracture? If you are falling on the outstretched hand, you will have this fracture. Outstretched hand fracture. Okay. This is a very, very important MCQ. As you can see in the last picture here, I told you that the median nerve is coming. Supracondylar is one hurdle. Fracture ho gaya. Median nerve damage. And when it come down, it passes in between the pronator teres. Agar pronator teres compress hua, nahi to bahut contract hua, then median nerve is also gone. Right? Now, you will tell me, this is the first X-ray. In this X-ray, which nerve will be damaged? Very fast, guys. Very fast you have to answer me. Which, just type single letter. That is enough. Very good. Very good. Very good. A radial nerve. And here, second X-ray. Second X-ray. Perfect. You see, there is a medial epicondyle fracture. So, ulnar nerve. Very good, guys. And what is this X-ray? Supracondylar fracture. Very good. Here I will have median nerve damage. And again, this is the same X-ray, mid shaft fracture, radial nerve. Okay. So again, the question is repeated, supracondylar fracture, that is the median nerve. Right. So most common fracture of humerus is supracondylar fracture. Supracondylar fracture. Very good, all of you. All of you are very, very good. Perfect, guys. So we are done with the discussion. Right? Later, I will tell you all these tests, guys. All these tests I will tell you. The nerve injuries are not yet over. But before that, let me also tell you the muscles of hand. Okay? Now, all of you sit straight. Sit straight. Look here now. Muscles of hand are divided into 5 groups. Muscles of hand are divided into 5 groups here. Look here. When I'm putting my hand like this elevated part, whatever you can see, this is called as the thenar region. And this is called as the hypothenar region. Now, first we will discuss about the thenar region. This big chunk of muscles are called as thenar region. Very easily, I'll teach you the muscles. But don't write it now, concentrate here. Okay. So, what is the first thing I'm doing here? I am flexing my thumb finger. When I'm flexing my thumb finger, the name of the muscle is flexor. This is the thumb. In Latin, you call it as pollicis. Flexor pollicis brevis. Why brevis? Because this is a short muscle. Because it is located here, intrinsic muscle, short muscle. Flexor pollicis brevis. Okay. Now, what I can do is that I can even pull my thumb finger aside like this. Pulling a thumb finger aside is called as abduction. See, I'm abducting, right? So, abductor, thumb you in Latin you call it as pollicis. And all these muscles here are short, brevis, brevis. Okay? Next. I can count my fingers. See, I am counting my fingers. I am going opposite of each finger and I am counting my finger. So this function is called as opponents pollicis. Opponents pollicis. And finally, I can bring my finger back and attach it to my with my index finger like this. See, I can attach it like this. I can attach it towards the body. So this is called as abduction, not abduction, adduction. So adductor pollicis. This is called as adductor pollicis, right? So abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, and abductor pollicis. Clear? Now, what are these hypothenar muscles? Hypothenar muscles are located just below your digiti minimi. What are these hypothenar muscles? Yes. When I tell abductor pollicis brevis, there will also be abductor digiti minimi. Abductor digiti minimi. Sir, why are you calling it as digiti minimi? Because little finger is called digiti minimi. If there is flexor pollicis brevis, there will also be flexor digiti minimi. If there is opponens pollicis, there will also be opponens digiti minimi. Opponens digiti minimi. And finally, there will also be palmaris brevis. Palmaris brevis. Short muscle is called palmaris brevis. So these are the muscles of your thenar as well as hypothenar, guys. Rest all the muscles like lumbricals, PI, they are dead easy, right? Dead and dead easy, right? So these are the only two tricky ones. So by the actions you can tell it. Flexion, lateral movement is abduction, this is adduction, right? And counting the fingers is opposition. That's it. Nerve supply I will tell you at the end. Okay. Coming to lumbricals. So from today onwards, guys, how many lumbricals do you have? You have got one, you have got one, you have got two, you have got three, you have got four. I have got four lumbricals, right? Why do you call it as lumbricals? Because they are ascaris lumbricoid like muscles, snake like muscles, worm like muscles. So you call it as lumbricals. Four lumbricals I have. If I ask you what is the function of lumbricals, which is very, very important and highly repeated question, whenever I tell action of lumbricals, put your hands like this. Okay, put your hands like this. What is the action? Flexion of metacarpophalangeal joint, extension of interphalangeal joints. Extension of interphalangeal, flexion of metacarpophalangeal. Okay. So write it down here. The function of lumbricals. Rahman Mondal, you did not understand what I am telling you is, whenever I tell lumbricals, put it like this, okay? This is called flexion of metacarpophalangeal joints, extension of interphalangeal joints, okay? Flexion of MCP and extension of interphalangeal joints, interphalangeal joints. Clear? Next important thing. Then what is the function of palmar interossei? Simple mnemonic, guys. Whenever you hear a term palmar interossei, write it as pad. Whenever you hear dorsal interossei, write it as dab. Okay. What is pad and what is dab? All of you know. Very good. Tell me what is pad and what is dab? Yes, Jaggi, you're right. Pad. P for palmar interossei. They are located on the palmar side. Adduction. Adduction means all the fingers come close to each other. This is called adduction. So if I'm able to do this function over here, this is because of palmar interossei. And if I'm able to open up my fingers like this, it is all because of dorsal interossei. So adduction, palmar interossei, abduction, dorsal interossei. Palmar interossei, adduction, Dorsal interossei abduction. Abduction. Did you understood whatever I've taught here, guys? We are done with the muscles of the hand. I'll tell you the nerve supply, but till here you understood? Coming to the nerve supply, now look at this table very carefully. I am separating, look here guys, I am separating two muscles. I'm separating few muscles over here. The first three muscles I'm separating the first three muscles here. Okay. And also I'm separating the first two muscles here. The first three as well as the first two lumbricals. Okay. These first three which I have highlighted with yellow marker and the first two lumbricals which I have highlighted with yellow marker, both of them are supplied by median nerve. Remaining all the muscles are supplied by ulnar nerve. Easy peasy. Yeah. So these are supplied by median nerve. Okay. This is also by median nerve. Remaining all are supplied by ulnar nerve. Okay, remaining all of them are supplied by ulnar nerve. But the question is that there is one very important question that has been asked again and again, that why this adductor pollicis? I mean, why adductor pollicis basically called as graveyard of ulnar nerve? It is called graveyard of ulnar nerve. Very important and anticipatory question. Which muscle is the graveyard of ulnar nerve? Abductor pollicis. Where is this abductor pollicis present? In the thenar region. Where is ulnar nerve? Ulnar nerve is coming like this all the way. It is coming, it is making a U-turn, and finally it is ending here into one muscle, and that muscle is called adductor. So ulnar nerve is dying into one muscle. At the end journey of ulnar nerve is onto adductor pollicis. That is why you call it as graveyard of ulnar nerve, because further it won't progress. So that is the graveyard of ulnar nerve. Right? So these are the important questions that are asked from the muscles of hand. If you understood this, I will go for the nerve injuries in detail, guys. You understood this? Very good, guys. So we have covered a lot of MCQs so far. Okay. Now we shall be going, very good, Harish Reddy. Now we shall be going on to the ulnar nerve, radial nerve, as well as the medial nerve. The first question every examiner will ask is, what is the root value of ulnar nerve? The root value of ulnar nerve is C8T1. Okay, C8T1. Now, what are the important things can you tell me about ulnar nerve? The first question which is asked about ulnar nerve is that ulnar nerve is called as musician's nerve. Musician's nerve. Why? Because ulnar nerve is responsible for the fine movements. You can play piano, you can play guitar, right? So for the fine tuning, for all these things, right, you need this nerve. That is why it is called as a musician's nerve. Fine, clear, claro? Now, next important thing, if ulnar nerve is damaged, then what all tests will you do? What all tests will I do is that, so whatever sign which you can see here, this is called as ulnar claw. Ulnar claw. Okay, so in ulnar claw or partial claw, the hand will be in this way. The hand will be in this way. Okay, so this is called as ulnar claw, because I told you ulnar nerve passes like this. So both the ulnar nerve supplies these two fingers. So ulnar nerve is like this, right? Partial claw, ulnar claw. First question is musician's nerve. Second question is this one. Third question is root value. Now look at the fourth question. What are the different tests which you can do for ulnar nerve? What are the different tests are? This first test, whatever you can see, this is called as book test or paper test. You can use a book or you can use a paper, whatever it is. if you are giving a paper to me, how will I take the paper normally? I will take it like this, right? I will take it like this. But this patient, how will he take the paper? He will take the paper in this way. You know, he's pinching it and taking the paper in this way. You see, there is a flexion here at the distal interphalangeal joint. There is a flexion. He's pinching it and taking it like this. So this sign, if they are showing this sign here, this is called as Foreman sign. So this is a normal patient and this is a Foreman sign positive patient. Okay. What is this test called? What is this sign called? Foreman sign. Foreman sign. Or you can also call it as book test. You can also call it as book test. But examiners, you know, nowadays what they are asking you, they're not putting up a picture and asking you what is this test. They are asking you, by doing this test, which muscle are you testing for? I am testing for adductor pollicis palsi. I am testing for what? I am testing for adductor pollicis palsi. Now don't confuse what is adductor pollicis palsi, guys. Adductor pollicis in the thenar group I have discussed. Look here, in the thenar group I discussed adductor pollicis, which you also called as graveyard of ulnar nerve. So you are testing that nerve with the help of book test. Next important thing, what is this test called as? This test is called as card test. What is card test is that, I told you, palmar interossea responsible for bringing the fingers towards each other, right? Closing the fingers, or you can also call it as adduction of fingers, right? Adduction and abduction of fingers. For adduction of fingers, I need palmar interossea. So how strong this adduction is, how strong the grip is, to test that, we do this test. Now, what is this test? What is this test is that, for example, look here. What I'll do is that, I'm a patient, doctor is putting the paper into both of my fingers. Now, what doctor will do is that he will try pulling this. He will try pulling this. Now, if my palmar interossea were working good, then all my fingers are so tightly closed. Then even if he is pulling, it won't come out, right? If my palmar interossea were not working well because of ulnar nerve damage, then slowly the paper will be easily displaced. Okay, so this test is called as card test. What is this test called? Card test. This test is called as card test. To test what? To test palmar interossea. Palmar interossea. This is another MCQ, guys. Another MCQ. The previous one, Foreman test, is also another MCQ. Okay. Next important thing. You have another test called as pen test. Pen test, which you do for adductor pollicis longus. Adductor pollicis longus. Okay. So normally this is called adduction, right? Adduction is important. I will put a pen here. When I put a pen here, against the resistance of pen, you have to try to close this. If you are not able to close this, then the pen test is positive. And finally, I have got a test called as Igawa's test. Igawa test. Igawa test is useful to look at the dorsal interossei muscles. Okay, it is responsible for dorsal interossei muscles. What will I do? I will take a cardboard. I will tell the patient to put a hand on his cardboard, and I will tell him to move your middle finger. So he will be moving like this. He will move his middle finger in this way. If he is able to move his middle finger like this, it means his dorsal interossei are working well. If he is not able to move, it means the Igawa's test is positive. So these are all the tests which you do for your ulnar nerve. Sir, it is very difficult to remember. Now, how do you remember this is? Remember by mnemonic B, C, D, E. You know alphabets, right? We won't delete this video, Deep Sundar, but I want you to pay attention here, because if you ask any doubt, I'll answer it. Okay. I want you to be till the end of the session. B, C, D, E. What does B stand for? B stands for book test, Foreman sign. What does C stand for? Card test. What does D stand for? DD, adductor pollicis test. What does E stands for? Igawa's test. if you really understood whatever I have taught in ulnar nerve, you won't even miss a single mark. Any question they might ask you on ulnar nerve, I'm promising right now openly, you won't even miss a single question. Okay? I have gathered the material from everywhere. Whatever our questions have been asked, all of the material I have gathered and just put it at one place, guys. Okay? You won't miss a single question. So, how do you remember it? B, C, D, E. All the tests you remember by B, C, D, E. Okay. What about the radial nerve? First of all, the question which is asked is, what is the root value of radial nerve? Root value of radial nerve is C5T1. Root value of radial nerve is C5T1. If radial nerve is damaged, then patient will have this type of drooping of his wrist. This is called as wrist drop. Wrist drop. Second important question which they can ask you is, whenever a person is sleeping like this on his arm, right? His arm onto the chair in this way, right? So his radial nerve will be compressed. So that is called as Saturday night palsy. Very good, Deep Sundar, excellent. Saturday night palsy. Saturday night palsy. Okay, so these are the two important things which you need to know. Coming to the median nerve, there are actually a lot of things, guys. The root value of median nerve. Anyone will tell me the root value of median nerve? Yes, Rahul Tiwari. Immediately half an hour after this lecture, I'll provide the notes as well. Okay. Anyone tell me? Yes. Very good. Very good. Very good. C5, C6, C7, C8. Right? C5 to 8. Now look here. If median nerve is damaged, how it will be damaged? You know it. I showed you the X-ray also. But if median nerve is damaged, then patient will have one, carpal tunnel. Not damage of medial nerve causes carpal tunnel. Compression of medial nerve will cause carpal tunnel. Second, ape thumb deformity. Third, pointing finger syndrome. Okay, so this particular thing is called as ape thumb deformity. Okay, ape thumb deformity in this way. Okay, pointing finger syndrome means you'll be pointing like this, pointing finger syndrome. Okay, next important thing is that I have always been telling you that ulnar claw. All of you know ulnar claw is caused by ulnar nerve, I told you, right? Now I'm telling you ulnar claw is also caused by ulnar nerve plus median nerve. Very, very, very important. Don't confuse this. Definitely they can ask you this question. Okay? Definitely they can ask you this question. Clear, everyone? Very good. Very good, all of you, very good. So we are done with all the nerve injuries, guys. All the nerve injuries of upper limb, we are done with them. Okay, so question won't go away from this. I promise you that. I promise you that question won't go away from this. Okay. Now let us go to another important concept, important repeated question, that is carpal tunnel syndrome. Now, when I will be discussing carpal tunnel syndrome, one very important thing you need to know is that all the way from the hamate bone till the scaphoid bone, you have got a ligament like this. This is going transversely, so you call it as transverse carpal ligament. Transverse carpal ligament. This ligament is called as transverse carpal ligament. Okay. Now, inside here, I have got a nerve called as median nerve. This is called as median nerve. So if median nerve is compressed, then obviously, that will lead to carpal tunnel syndrome. But what are the questions that are asked? What are the questions that are asked is that, look here. What are the contents of carpal tunnel? What are the contents of carpal tunnel? Yes, tell me. First is median nerve. Second thing is that, guys, don't use your memory. Just look here. I told you that there were flexor digitorum superficialis, all the tendons going like this. Flexor digitorum profundus, all the tendons are going like this. They are crossing the carpal tunnel and going. Okay. So flexor digitorum superficialis, flexor digitorum profundus, clear? Median nerve, and last one to remember is flexor pollicis longus. So these are the four contents. These are the four contents of your carpal tunnel. Okay. But the question which they again ask you is that what are the structures going above the transverse carpal ligament or flexor retinaculum? This is also called as flexor retinaculum. They are going to ask you structures going above, superficial to flexor retinaculum. It means in this red structure, what are the structures that are going superficial to retinaculum, guys? Very, very easy. SUP. What does SUP stand for? S stands for superficial, U stands for ulnar nerve, and P stands for palmaris longus. Palmaris longus. So structures going superficial to retinaculum, SUP. S stands for superficial, U stands for ulnar nerve, and P stands for palmaris longus. Very, very easy. Is it difficult, guys, here? Is it difficult? Is it difficult to learn? It might be difficult, guys, because at a time you are taking up a lot of things, right? So it might be difficult, but once you revise it 2 times or 3 times, it would be very easy. Okay. Right. Now look at the question here. Look at the question. In a patient with fracture of upper radius and ulna at the insertion of pronator teres. So here is telling that upper part is damaged where the pronator teres was inserted here. You know, pronator teres, what is the function of pronator teres? Pronator means pronation. Pronation. And they asked in 2018-19, very, very recently, that which movement is restricted? Obviously pronation. Very easy. Very easy. Which nerve is passing through medial epicondyle? Yes, this is a test now. Very good. Ulnar nerve. Excellent, excellent, very good. Which among the muscles receive dual nerve supply? Which muscles receive double nerve supply? Double nerve supply, guys. Excellent. Flexor digitorum profundus, right? Flexor digitorum profundus, medial half by ulnar nerve, other half by the median nerve. Very good. All of the following structures are passing deeper to flexor retinaculum except, what are the structures deeper to flexor retinaculum except? We discussed flexor digitorum profundus, flexor digitorum superficialis, flexor pollicis longus, not palmaris longus, right? Palmaris longus is not the answer. Very good. Roy, welcome back. Which structure passes superficial to flexor retinaculum? Above the flexor retinaculum, what is that? Superficial, SUP. U stands for ulnar, P stands for palmaris longus. So what will be the answer here? Very, 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 very good. Ulnar nerve, ulnar nerve. Okay. These are the questions, all these questions, I did not prepare it by myself. These are the questions which were previously asked. Okay. Pointing finger, you know the answer. Claw hand, you know the answer. What is the answer? Claw hand. Claw hand, what will be the answer? Median as well as ulnar both. Very good. Median ulnar, very good. Ape thumb deformity, you know the answer. You know the answer, ape thumb deformity. Compression of which of the following nerves leads to carpal tunnel syndrome? This also you know the answer. Which nerve compression will lead to carpal tunnel syndrome? All the muscles of rotator cuff except, you know the rotator cuff muscles. What is not a rotator cuff muscle? Teres major muscle. Teres major is not a rotator cuff muscle. And most commonly injured muscle in the rotator cuff is? Very good, very good, very good. Excellent, guys. Excellent. Very good, very good. So this is how the questions are asked, guys. You need not to worry. These questions are every year they are repeated, guys. Don't worry at all. Okay. Don't think anatomy is really hectic subject. Only few things you need to study. Okay. Few things you need to study. Not many of these things. Okay. Only few things you need to study. Only those will be repeated every year. Don't panic by looking at anatomy. Right. Next important thing. The root value of axillary nerve is C5, C6. I already told you what is the muscles that will be deltoid muscle and teres minor. In the starting only I told you this: deltoid, abduction, teres minor, lateral rotation, right? Musculocutaneous, C5, C6, C7. It supplies anterior compartment of your arm. Anterior compartment of your arm. Next, radial nerve, C5, C6, C7, C8 and T1. C5, C6, C1, C8 and T1. It is easy to remember, right? 5, 6, 5, 6, 7, 5, 6, 7, 8, T1. Okay. It supplies all your extensor muscles. So this is a very, very important box to remember. Very, very important box. Now let us discuss the arteries of the upper limb, guys. Arteries of the upper limb. Coming to the arteries of the upper limb, look here. This artery, whichever is coming, this is called as subclavian artery. Subclavian artery continues as axillary artery. Okay. Axillary artery continues as brachial artery. And brachial artery divides into two: radial artery and ulnar artery. This is the basic thing. Now, first let us study about the axillary artery. What are the branches? Okay. This is axillary artery. Now, if you look at this axillary artery, what are the few things you can remember? That this is called as the first rib. This is called as the first rib. Okay. What is this part called as? This is called as pectoralis minor muscle. Not major, it is minor muscle. And this muscle is called as teres major. Now, when I'm telling teres major, in the bracket you should fill this lacunae telling what lip is it attached to. Okay. Very good, very good and very good. It is attached to the medial lip. I told you to remember the mnemonic MET, MET. Okay, very good. Axillary artery is of three parts. So, look here all the way. Axillary artery, subclavian artery is coming down all the way till the lower border of the first rib. Till the lower border of the first rib, it is subclavian artery. Now, the question, important question. Axillary artery starts from where? It starts from the lower border of first rib. Lower border of first rib. Axillary artery starts from the lower border of the first rib. Okay. Second important thing. Axillary artery comes down all the way. It passes behind pectoralis major and it passes above teres major. In this way, axillary artery is divided into three parts. This is called as the first part. Behind is called as the second part. Down it is called as the third part. Okay. So now, what are the branches of the first part, second part and the third part? Very, very easy. Very, very easy. First part has got one branch. Second part has got two branches. Third part has got three branches. Okay. Now, what are these branches? 16s, love, songs and poems. Okay. 16s, love, songs and poems. S stands for superior thoracic artery. S stands for superior thoracic artery. From the second part, there are two branches here. What are those two arteries? T stands for thoracoacromion artery. L stands for lateral thoracic artery. Lateral thoracic artery. S stands for, in the third part, S stands for subscapular artery, and A and P stands for anterior, what is this? Anterior circumflex humerus, posterior circumflex humeral. Anterior circumflex humeral and posterior circumflex humeral. Right? Ankit Pandey is telling the mnemonic salt pass. Even that is also right. Anything you can use, guys. But don't use too many. Okay? Right. All of you. Important thing is that this lateral thoracic artery, whatever is there, it basically supplies the breast. Okay? That is the reason why lateral thoracic artery is more developed in females than the males. It is much more developed in the females. Okay? That thing you remember. We are done with the branches of axillary artery. So these are the branches of axillary artery. What are the questions again? It starts from which border? Okay. How does it pass? It passes below and next above. Below pectoralis minor, above teres major, and branches. That's it. Nothing more than that. Look at the question here. All of the following, all are true regarding axillary artery except this was a question which was asked previously. What is the answer? It is a continuation of subclavian artery, right? It is crossed by pectoralis minor muscle. Yes, it is crossed by that. It extends from outer border of second rib to the lower border of teres minor. Is it right? Is it right, guys? No. No, it is right. Yes, answer C is the right answer. Okay. It does not pass from the lower border of second rib. It passes from the lower border of the first rib. Very good, Gaurish. Gaurish, excellent. Jagish Chaudhary, Jayesh Kotari, perfect, perfect. Yes. Let us discuss about subclavian artery. Now, this is subclavian artery. Subclavian artery is also having three parts. First of all, what is this muscle here? This is called as anterior scalene muscle. Anterior scalene muscle. Okay. Anterior scalene muscle is dividing the subclavian artery into three parts. First part before scalene, second part behind, third part after that. Now, what are the branches from the first part, second part, as well as the third part? Look here. First part branches. Easy way to remember. Easy way to remember. Look here. First part artery is going down into the thoracic cavity. From first part artery is going down into the thoracic cavity. So it is called internal thoracic artery. Internal thoracic artery. Next. From the first part only, arteries are going up like this into the vertebral foramina. This is called as vertebral artery. Vertebral artery. Third thing from the first part is this artery supplies thyroid, cervical region, thyrocervical trunk. Thyrocervical trunk. Second part, look here. Second part is costocervical trunk. Costocervical trunk. And third part gives one branch that is called as dorsal scapular artery. So if you remember these branches, these are more than enough. First part, second part, and third part. Don't put any mnemonics, guys. Very easy to remember. Going inside internal thoracic, going up vertebral artery, going to the thyroid, thyrocervical trunk, costocervical, dorsal scapular. Very easy to remember. Right? You know why it is called subclavian artery? Because it passes just below the clavicle. If I have fracture of the clavicle, then what will happen? This artery might be compressed. Right? So, look at the next question. In a victim of road accident, the doctor found a fracture of left clavicle. There is fracture of left clavicle and impaired circulation in the extremity. What is the cause of impaired circulation in the extremity? The answer is compression of subclavian artery. Straightforward question. Very, very straightforward question. right? Now, let us enter into another important topic of lower limb, that is your brachial plexus. Okay. Now, I'm not discussing brachial plexus completely. It is not that important to discuss, to draw the brachial plexus, but the lesions of brachial plexus are very important. All of you know C5, C6, C7, C8, and T1. Okay. I'm highlighting a point here. Look here. Here I have got two nerves, one going up, one going down. Okay. One going up, this is called as suprascapular nerve. One going down, this is nerve to subclavius. Right? Question. What is the question that is asked? What is the question that is asked? Look here. Where is Erb's point located? Erb's point is located near the trunks of C5, C6. So this is the place where the Erb's point is located. This is the place where the Erb's point is located. Where is the Erb's point located? At C5 and C6. Right? So this is the place C5, C6. Now in the question they will ask you that how many nerves are involved in this Erb's point? First question, Erb's point. C5, C6. How many nerves are involved? Anyone tell me? See, C5 root, C6 root. Now coming to the trunk, suprascapular nerve, nerve to subclavius, anterior division, posterior division. So completely 6 nerves are involved. How many nerves are involved? 6 nerves are involved. Okay. Next important thing. I told you in the starting that if there is injury to Erb's point, right? All the nerves after the injury will be damaged, but the nerves before the injury, before the point, are not damaged. They are not disturbed. That's what I told you in the starting. Which nerve is spared in case of Erb's palsy? Long thoracic nerve, because long thoracic nerve comes all the way down like this. Okay, so it is before the Erb's point, so it is not disturbed, it is not damaged. So that was the question I discussed there. Clear? Right. So C5, C6 is Erb's point. C8, T1 is Klumpke's paralysis. C8, T1 injury causes Klumpke's paralysis. So nerves involved in Erb's point, these are the 6 nerves. Remember this thing. So Erb's palsy is C5, C6. Can I also call it as upper trunk palsy? And Klumpke's palsy is C8, T1. I can also call it as lower trunk palsy. Okay, right. Very good. Now, what are the branches of lateral cord, medial cord, and posterior cord? This is very, very important and very easy. L stands for LML. Keep this thing in mind. M stands for M4U. And posterior cord, that stands for mnemonic ulnar. Okay. Now, what is LML? What does L stands for? L stands for lateral pectoral nerve. The branch of lateral cord is lateral pectoral nerve. M stands for musculocutaneous nerve. Musculocutaneous nerve. L stands for lateral root of median nerve. Lateral root of median nerve. Very good, Ankit. Very good. Coming to the medial cord, I told you M4U. What does this M4U stands for? Medial pectoral nerve. When I tell lateral, there should be medial pectoral nerve. Next, median nerve of arm. When there is median nerve of arm, there will also be median nerve of forearm. Median nerve of forearm. Okay. What is the last M here? When there is a lateral root of median nerve, there will be medial root of median nerve. And the final U is, all of you know, that will be ulnar nerve. So this is very, very, very easy to remember such branches. Okay, very easy to remember the branches. Now coming to the posterior cord, you have got a mnemonic ulnar. U stands for upper subscapularis. L stands for lower subscapularis. N stands for nerve to lats. Nerve to lats means your latissimus dorsi. A and R. What does A stands for? Axillary nerve. And R stands for radial nerve. So if you remember these mnemonics like LML, M4U and ulnar, with the help of these mnemonics, you can write down the branches very easily, guys. Okay? Very, very easily. Right. So if a patient has got Erb's palsy, the hand will be, look here, the hand will be adducted to the body like this. Okay, the hand will be adducted and the hand will be rotated backward in this way. Adduction and medial rotation. Okay, adduction as well as medial rotation. Adduction, medial rotation. So that is the reason why, yes, Adil Hussain, internally rotated or pronated. Okay, you call it as waiter tip deformity. You call it as policeman tip, waiter tip. Okay, so these are the important things which you see. So look at this baby here. The hand is towards the body and rotated inside like this. Okay, as the waiter is asking the tip, as the policeman is asking the tip, it is rotated like that. So next important thing, these are enough, guys. These are more than enough. And what will happen when there is Klumpke's paralysis? Klumpke's paralysis will lead to what? Anyone? Klumpke's paralysis will lead to claw hand. Claw hand, very good. Claw hand will lead, what is the nerve involved? Ulnar plus median nerve. Ulnar nerve plus median nerve, both of them are involved in case of Klumpke's paralysis. Clear? Now, what about the cubital fossa? Pratik is telling Singham hand, yes. Coming to the cubital fossa. So this is cubital fossa, guys. Now in this cubital fossa, very important, look here, all of you concentrate. In this cubital fossa, I have got this muscle here, this is called as brachioradialis, and here I have got this muscle, this is called as pronator teres. Okay, so I have got this brachioradialis, here I have got pronator teres. So what are the borders of cubital fossa? Laterally brachioradialis, medially pronator teres, and in the base an imaginary line is drawn between medial and lateral epicondyle. So that forms the base. So we have got a triangle here. This is called as cubital fossa. Now what are the structures that are located in the cubital fossa? Remember by a mnemonic R tan. What do you mean by R tan, guys? What do you mean by R tan? R stands for a nerve here. What is that nerve? Yeah, obviously from lateral to medial. I am going from lateral direction to medial direction. R stands for radial nerve. So that will be radial nerve. And after that, T stands for tendon of biceps brachii. The tendon of biceps, if you palpate it, you can find. T stands for tendon of biceps brachii. So radial nerve. T stands for tendon of biceps. Okay. And next, TA. What does A stand for? A stands for artery. What is that artery? Brachial artery. Okay. Brachial artery, which is bifurcating into two. One is called as radial artery, another one is called as ulnar artery. Radial and ulnar artery. And finally, you have got N. What does N stands for? N is also a nerve, and that nerve is, yeah, what is that nerve at the end? Very good, Prince Davis. Median nerve. Perfect. That is median nerve. Okay. Now there is a question that is called as cubital tunnel syndrome. If there is in the cubital fossa, if there is compression of the structures which are located, all the neurovascular bundles, so that is called as cubital tunnel syndrome. In cubital tunnel syndrome, which nerve is compressed? That is the median nerve. Median nerve is compressed in cubital tunnel syndrome. Okay. All of you are clear? Now, coming to the hybrid muscles. This is a very, very important question. Cubital tunnel syndrome, I mean the cubital fossa. This is also very important. There is no need to tell, I think, guys, right? Because you already know what are important, what are not important, right? So look here. Hybrid muscles. What are the hybrid muscles? Hybrid muscles are adductor magnus. You have to just remember it. Biceps femoris, pectineus, and flexor digitorum profundus. Now, why adductor magnus is called as hybrid muscle? Because this muscle is innervated by two nerves. That is why it is called hybrid muscle. What nerves? Obturator nerve plus sciatic nerve. Adductor magnus is supplied by obturator nerve and sciatic nerve. So that is the reason why you call it as hybrid muscle. Next, coming to biceps femoris. Biceps femoris is also supplied by two nerves. Can anyone tell biceps femoris is supplied by which two nerves? Very good. It is supplied by sciatic nerve plus common peroneal nerve. It is supplied by sciatic and common peroneal nerve. Next, coming to the pectineus, pectineus is supplied by obturator nerve plus femoral nerve. So pectineus. And finally, flexor digitorum profundus. I'm not writing it because you already know flexor digitorum profundus is supplied by two nerves. You know that thing already. So I'm not writing it again. Okay. So this is a very, 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 very important box. Okay. Right, guys. Now, coming to anterior interosseous nerve. I hope all of you know what is median nerve, right? So one of the branch of this median nerve is anterior interosseous nerve, AIN, anterior interosseous nerve. So anterior interosseous nerve innervates three muscles. What are those three muscles are? Remember like this, P, P, okay? And if I invert this P, what it will become? Q, P, P, Q, okay? P, P, and if I invert it like this, it will become Q. So what are those P, P, Q? One is profundus. What profundus? Flexor digitorum profundus. Another one is flexor pollicis longus. Another one is pronator quadratus. Pronator quadratus. So all these three muscles are innervated. All these three muscles, if it is not sufficient, then we'll extend the session, but definitely I'll complete it today, Ramya. Don't worry about that. Right. So all these three muscles together, they are coming under anterior interosseous nerve. Anterior interosseous nerve supplies all of this. So for example, if this anterior interosseous nerve is not working, if it is damaged, then what will happen is that patient cannot do this sign. This is called as OK sign. Okay. Patient will not be able to do OK sign. He will be able to do like this. Remember like this. OK sign is not possible in anterior interosseous nerve injury. So patient will be doing in this way. Okay, keep that thing in mind. So patient cannot do no OK sign. No OK sign. So the last thing which we shall be discussing, and by closing this topic, is your carpal tunnels. So not carpal tunnel, anatomical snuff box. Okay, anatomical. Sure, Osama, definitely. I'll complete it anyhow. Don't worry about that. Right, anatomical snuff box. Now in this anatomical snuff box, what are the structures present? So they will ask you the borders, they will ask you the contents. Contents, you know, radial artery is present. What are the borders are important? What are the borders are? Here, when you do the finger like this, you can see a tendon like this, right? When I'm pulling this tendon, my finger is extending in this way. So can I call it as extensor pollicis longus tendon, right? So posterior medially, okay, posterior medially, I have got a tendon that is called extensor pollicis tendon. It means this one, this green color one. Okay. Next, Anterior-laterally, I have got two tendons. I have got two tendons. What are those two tendons? Extensor pollicis brevis and abductor pollicis longus. Okay. So one here I have got tendon. I'm pulling it. My finger is abducting. Abductor pollicis longus and extensor pollicis brevis tendon. It means the large green one here and the large blue one and the small blue one. And obviously proximally I have got the head of the proximally I have got the styloid process. Proximally I have got the styloid process. So these are some of the important things, guys. These are some of the important things which you definitely need to know from the chapter of lower limb, guys. Okay. So till here we are completing the topic on the upper limb. I'm sorry. We are completing the topic on upper limb. Okay. Right. So everyone understood whatever I've taught today? Yeah. Are you all clear, guys? Whatever I've taught today, are you all clear? Before I before I proceed to head and neck, are you all clear with all these things? Yes, Ankit. Yes, I can guarantee you that most of the topics we have covered, this should be enough for you. And overall, when I discuss all the topics together, then that must be enough. It would definitely cover most of the MCQs as I already promised you. Okay. Right. Clear, everyone? Shall we proceed, guys? It is just 7:28. You are all worrying why all are not completed. Yesterday there was a class till 12 o'clock. Right. I have an energy to teach you, but you should have an energy to just sit and listen. Okay. Now we shall be proceeding to head and neck. Now in the head and neck region, I'll be discussing only the most important concepts which are repeated all the time. Okay. So these concepts must be mostly it would be enough for you. Okay. Right. Look here now. Coming to the head and neck. First of all, we shall discuss the most important topic, that is pharyngeal arches. I know how difficult this topic is and how important this topic is. Pharyngeal arches. Pharyngeal arches are very important and very, very difficult. Okay. Now, regarding this pharyngeal arches, I just want to tell you here that these blue color things which I have drawn here, actually pharyngeal arches are like this. On both the sides of your mouth, on the pharynx here, on both the sides, you have got this pharyngeal arches. Okay. Now, how many pharyngeal arches do we have? We have got 1, we have got 2, we have got 3, we have got 4, and we have got 6. Okay. 1, 2, 3, 4, 6. Where is the fifth pharyngeal arch? Fifth pharyngeal arch is rudimentary. Question. Fifth pharyngeal arch is rudimentary. Rudimentary. Next important question they're going to ask you is that if you look at the pharyngeal arches, so these are the pharyngeal arches here. I'm cutting down these pharyngeal arch. I'm cutting down these pharyngeal arch. In the center, there is a mouth. The same picture I've kept there. Center, I have the mouth. On either side, pharyngeal arches are there. Okay. Now, the outer side of the pharyngeal arches are pink in color. The inner side of the pharyngeal arches are red in color. What is this outer made up of? Outer is made up of ectoderm. The inner is made up of endoderm. Okay, endoderm. Because there was a question that was asked here, which is the correct about embryogenesis in 2017. They asked this question. I'll tell you anyways. Next, one pharyngeal arch, second, third, and fourth. See, all these pharyngeal arches are attached to each other from outside, from inside. So this outside attachment is called as cleft. The inside attachment is called as pouch. Outside is called cleft, inside is called pouch. Okay. So this is the first cleft, this is the second cleft, this is the third cleft, fourth cleft. Pouches also, there are 4 pouches. Clear? Look at this question now. Which is correct about embryogenesis? Which will be the answer? What will be the answer here? Very good. Branchial pouch is endoderm. Very good. Branchial pouch is endoderm. Sir, then what about mesoderm? The center part is the mesoderm. So this blue one is the mesoderm where the arches are present. Okay. Now let us proceed. Look here. So these are the arches, right? So first of all, let us discuss about the cleft. So from first cleft, what are the structures we are getting? That is very, very important. Look here now. All of you just pay attention. The first cleft will undergo invagination in this way. Here also the first cleft is undergoing invagination in this way. Okay. How are they looking, guys? How are they looking? These invaginations later on, they will be converted in this way. So this is called as ear pinna. This is called as ear pinna. And this tube is called as external auditory meatus. So can I tell the first cleft forms external auditory meatus as well as ear pinna. Next. Now let us discuss about the first pouch. Pouch means inside one. What will happen to these pouches is that the pouches also will take an invagination all the way like this inside. Here also it will take an invagination all the way like this inside. Now the septum that is present between external auditory meatus, the black one and the red one, the septum in between, that will form the tympanic membrane. Okay. All this red one will form the middle ear cavity. Clear? So now coming to first pouch will form middle ear cavity, tympanic membrane, as well as eustachian tube. Okay. So these are 2 things and 3 things which you need to remember. First pouch, first cleft are very, very important. Okay. So this is a question here. Second important question is clinical one. What is this clinical one? Is that this is second, third and fourth cleft. How are they in future? How are they progressing into? Is that, look here very carefully. The second, third and fourth, they invaginate in this way. Second, third and fourth, they invaginate in this way. Okay. So this is your second, this is your third, this is your fourth. They are invaginating inside and they are opening onto outside through a single sinus. So this is called as cervical sinus. Okay. So second, third and fourth clefts are producing cervical sinus. They are invaginating and forming cervical sinus. So cervical sinus has got a single opening. What will happen in you and me is that this cervical sinus will close. Look here. This cervical sinus will close like this, second, third and fourth. It will close and it will form a cyst here. This cyst is called as cervical cyst or also called as branchial cyst. So in you and me, branchial cyst will disappear. But in some kids, what will happen is that the branchial cyst will remain there for a long time. So when the branchial cyst will remain there for a long time, this is how the cyst looks. You see, this is the branchial cyst. Clear? So where is branchial cyst developed from? Branchial cyst is developed from the non-close or failure for this cyst to disappear will lead to branchial cyst. Okay. So it is developed from the cervical sinus. Cervical sinus is developed from second, third and fourth cleft. Clear so far? Yeah. Now coming to, we are done with first cleft, first pouch. We are done with second, third, fourth cleft. Now we are left only with the pouches. Now what is the important thing about pouches? Right? So if I'm doing like this, these are arches. In the center I have got my thyroid gland. Okay. So let us say in the center I have got my thyroid gland here. Clear? Now look here. What is going to happen is that the second pouch will take an invagination like this on both the sides. Okay. Within these invaginations, small red color nodes are formed. These small red color nodes are called as tonsils. These are called as tonsils. So can I write it as second pouch will develop into tonsils? Then what about pouch 3 and 4? What about pouch 3 and 4? Look here. Pouch 3 and 4 will take an invagination in this way. It will take an invagination in this way. 4 also it will take an invagination in this way. Here also it will take an invagination in this way. Okay. Now, what is happening here? The upper one is called as dorsal wing. The lower one is called as ventral wing. Upper one is called as dorsal wing and the lower one is called as ventral wing. Clear? Yes, thymus is there. In the dorsal wing, I have got inferior thyroid gland, inferior parathyroid gland. On the dorsal wing, I have got inferior parathyroid gland. So this is inferior parathyroid gland, like this. Okay. On the ventral wing, I have got thymus gland. I have got what? Thymus gland. In the same way, coming to the last pouch, that is the fourth pouch, on the dorsal wing, I have got superior parathyroid gland. This is called what? Superior parathyroid gland. Okay. So far what you have learned, guys, you have learned that in the second pouch, dorsal wing is there, ventral wing is there. Dorsal wing, inferior parathyroid gland. Ventral wing, thymus. Coming to the third pouch, dorsal wing, ventral wing is there. Dorsal wing, superior parathyroid gland. Ventral wing, nothing. Okay. Let us write down the things now. So, third pouch has inferior parathyroid gland and thymus. Parathyroid gland on the dorsal wing. This is on the ventral wing. Fourth pouch, superior parathyroid gland only on the dorsal wing. Clear? If this third pouch and fourth pouch, during the development of this third and fourth pouch, if there are any abnormalities, then dorsal wing, ventral wing is not produced. If dorsal wing, ventral wing are not there, then thymus, parathyroid gland, they are also not developed. So if there is no proper development of thyroid gland, I mean the parathyroid gland and the thymus gland, that syndrome you call it as Dye-George syndrome. That syndrome you call it as Dye-George syndrome. So if today onwards someone asks you Dye-George syndrome is due to defect in the development of pouch 3 and pouch 4. Pouch 3, pouch 4, pouch 3, pouch 4, Dye-George syndrome. Very good. Prince Davis has already told me that it is 22q11 deletion. Very good. Very good. Excellent. So now we have discussed all the discussion of all the pouches as well as all the clefts. Now we shall be concentrating on the mesoderm, that is the arches. Now look here. This is the first arch. Okay. And this is the second arch. This is the third arch. This is the fourth arch and this is the sixth arch. 6 arches are there. Now first arch will develop into, all of you look at the picture whatever I'm drawing. First arch will develop into, this is called as, what is this called? Meckel's cartilage. Meckel's cartilage, in future it will develop into mandible. Okay. So I am also writing mandible. Mandible. Okay. And what is this bone here? This is called as malleus. And what is the next one? This is called as incus. Then where is stapes? Stapes is located in the second arch. Okay. So what are the structures from first arch? Meckel's cartilage, mandible, malleus, incus. If you remember these 4 things, done. Second important thing. Second arch. What are the structures developed from the second arch? Look here. This is incus. Not incus. This is stapes, right? This is stapes. Okay. Next, after that, you have got, this is as the styloid process. Styloid process. Next, this is called as stylohyoid ligament. Stylohyoid ligament. Okay. So these are the structures that are developed from the second arch. Along with this, remember 3 more things. 3 more things. Very easy. Stapes. Then what is the muscle? Stapes is a bone. Then what is the muscle? Stapedius. Okay. Styloid process is also a bone. Then what is the muscle? Stylohyoid. Stylohyoid. Next we have got facial muscles. So these three completely 6 structures are developed from the second arch. All these 3 structures, 6 structures are developed from the second arch. Coming to the third arch. Coming to the third arch, what are the important things? What you can see in the third arch, guys? You tell me. What can you see in the third arch? Yeah. In the third arch, the yellow color one, I can see hyoid bone. Yes, but not complete hyoid bone, Praveen. It is greater horn of hyoid bone. You see this long one, this is called greater horn of hyoid bone. Greater horn of hyoid bone. And the muscle is stylopharyngeus. Stylopharyngeus muscle. And finally, guys, fourth and sixth together will form cartilages. Fourth and sixth together will form cartilages. Now, how do you remember those cartilages? Remember by a mnemonic CATE. CATE stands for CATE. What does C stand for? Cricoid cartilage. C stands for uniform cartilage. Another C stands for corniculate. Okay. A stands for arytenoids. T stands for thyroid. And E stands for epiglottis. Okay. So all the cartilages are formed by the fourth as well as the sixth. Fourth as well as the sixth. So these are the structures which you need to remember, guys. If you look at this picture, it would be very, very easy. Just twice or thrice go through this. That would be very easy. Now, another important thing is that in the first arch, what is the artery of the first arch? The artery of the first arch is maxillary artery. Okay. Artery of the second arch, that is stapedial artery. Artery of the third arch is common carotid artery as well as first part of internal carotid artery. Common carotid artery and first part of internal carotid artery is for the third arch. Okay. Coming to the innervation. Innervation is very, very easy, guys. Innervation is very easy. First arch is supplied by fifth pair of cranial nerve. That is trigeminal. In trigeminal, you have got 3 branches, V1, V2, V3. So, trigeminal V3. Okay. That is trigeminal V3. Clear? Trigeminal is what? Fifth. After fifth, you have got sixth. After sixth, you have got seventh. After seventh, you have got eighth. After eighth, you have got ninth. Okay. So, remember in this way. All of you are clear with this? Yeah. Arch of aorta. Arch of aorta is derived from. This was a question. Arch of aorta is derived from fourth arc. Fourth pharyngeal arc. Superior vena cava is derived from. Superior vena cava is derived from cardinal veins. It is derived from cardinal vein. And first organ to attain functional maturity. So during the embryonic development, what is the first organ to attain the functional maturity? That will be cardiovascular system. Okay, that will be your cardiovascular system. Clear, all of you? Now let us do the questions here. Stylohyoid ligament. Look here, stylohyoid ligament is derived from. Yes. Stylohyoid ligament is derived from. This was asked in 2017. Very good, all of you. Very good, excellent. Spinomandibular ligament, even this was also asked in 2017. Spinomandibular ligament is derived from. Yes, come on, answer first. Not second, it is derived from the first. Very good. It is derived from the first arch. The auricle develops from where does the auricle develop from? the first important thing we discussed here, the auricle will develop from the first cleft, right? So it will be first branchial cleft. Inferior parathyroid glands develop from, inferior is top, superior is bottom, okay? Inferior is top. In the top, which one? Pouch. Which pouch? Third branchial pouch. Very good. Third branchial pouch. Tonsils are derived from, again, that also the first pouch. Very good. Tonsils are derived from the first pouch. First pouch? No, they are derived from the second pouch. I'm sorry. Tonsils are derived from the second pouch. Okay. Which of the following is not derived from the first pharyngeal pouch? Which of the following is not derived from first pharyngeal pouch? Tonsils. Tonsils are not derived from the first pharyngeal pouch, right? Because tonsils are derived from the second pharyngeal pouch. All of you understood, guys? Right. So this is the discussion which you need to know regarding, the pharyngeal arches. Okay, I hope you understood it. Let us enter into one of the most important topic, that is your circle of Willis. Okay, so the first question which they're gonna ask you in this circle of Willis is that which artery is not a branch of circle of Willis? All of you should know the artery which is not a branch of circle of Willis is, yes, anyone? Very good. Dr. Benedict has already answered. It is middle cerebral artery. Middle cerebral artery is not a branch of circle of Willis. Okay. So all of you know, this is circle of Willis. I'm not writing the names of the arteries, guys, because I hope you are very perfect with this topic already. You might know all the branches and all. There is no point of discussing it and wasting our time. So let us discuss only the important things. So arteries, you already know these branches and all. So middle cerebral artery. Now, if you look here, guys, if you look here, you have got two arteries here. See, this artery is called as pica. Pica means posterior inferior cerebellar artery. And this artery is called as ica. Ica means anterior, what? Anterior inferior cerebellar artery. Pica and ica. Now, important thing you need to know is that sometimes the pica, very good, Dr. Benedict, excellent. Pica will get obstructed, or exactly to tell, there will be occlusion of pica. Occlusion of pica. Whenever there is occlusion of pica, patient will have a syndrome that is called as lateral medullary syndrome. Very, very, very high yield, guys. Very, very high yield. Lateral medullary syndrome, or you also call as Wallenberg syndrome. Wallenberg syndrome. Okay. Now, if someone asks you, sir, which occlusion is most common, then the vertebral artery occlusion is most common than pica occlusion. Okay. Vertebral artery occlusion is most common than pica occlusion. Keep this thing in mind. Clear? Sir, you told me about lateral medullary syndrome, telling that it is pica. Then what about medial medullary syndrome? Yeah. What about medial medullary syndrome? Tell me. Medial medullary syndrome. Medial medullary syndrome is because of spinal artery occlusion. Spinal artery occlusion. Spinal artery occlusion will lead to medial medullary syndrome. Okay. Clear? Anterior spinal arteries are there, posterior spinal arteries are there, you know, right? So anterior spinal artery occlusion will lead to medial medullary syndrome. Then pica occlusion will lead to lateral medullary syndrome. So these are the two questions. You have to be so perfect on this, because you will definitely get a question, one question from circle of Willis, and that can be expected as this one, because last year they did not ask this question. They might ask you this question. Okay. Keep this thing in mind. So, pica occlusion leads to lateral medullary syndrome. Occlusion of anterior spinal artery leads to medial medullary syndrome. Now, posterior communicating artery berry aneurysm leads to. Look here now. Where is posterior communicating artery? Where is this posterior communicating artery? This is posterior communicating artery. This one is your posterior communicating artery. If this along with this posterior communicating artery, if you look guys, if you look the real picture, along with this posterior communicating artery, there is also one more nerve that is going very close to this, that is your oculomotor nerve. So if posterior communicating artery berry aneurysm means like berries, there will be aneurysm, right? So when there is swelling of that, then oculomotor nerve will be compressed. So oculomotor nerve damage will happen. Oculomotor nerve damage will happen. Clear all of you? So which artery is not a part of circle of Willis? Middle cerebral, pica occlusion, lateral, anterior spinal artery, medial medullary syndrome, right? So berry aneurysm of posterior communicating artery will lead to oculomotor nerve damage. Oculomotor nerve damage. All of you are clear with this? Now, another important question, which I think I personally feel that this question is going to come this year, guys. I personally feel this, that blood supply of internal capsule. This is called as internal capsule. Internal capsule has got three parts. This is called as anterior limb of internal capsule. This is called posterior limb of internal capsule. And this is called as genu of internal capsule. Okay, genu of internal capsule. Now look here. From anterior cerebral artery, there is a branch. See, this is anterior cerebral artery. There is a branch that is going all the way and supplying anterior limb of internal capsule. And the name of this branch is recurrent branch of Huber. What is this called? Recurrent branch of Huber. Keep this thing in mind. Recurrent branch of Huber. Next. From where the blood is getting supplied to the genu of the internal capsule, the artery that is coming is directly from the internal carotid artery. This is your internal carotid artery. This is your internal carotid artery. A direct branch of internal carotid artery supplies your genu. Next, who is supplying the posterior limb? Here also, there is an artery that is directly coming from the internal carotid artery. Look here. This is an artery that is directly coming from internal carotid artery supplying your posterior limb. This is called as anterior choroidal artery. Anterior choroidal artery. So, three blood supplies, recurrent branch of Huber coming from anterior cerebral artery, direct branch from internal carotid artery, and posterior limb is supplied by anterior choroidal artery. These are the three arteries I'm telling you. Remember it. Just fix it in your mind, guys. Fix these things in your mind. Clear? Right? Fine. How many arteries supplies medulla oblongata? How many arteries supply medulla oblongata? Any idea? Let us go back to the picture here. How many arteries are supplying medulla oblongata? Yes, this is your pons. This is your midbrain. This is your midbrain. This is your pons. This is your medulla oblongata. Dr. Bendick, no, it is not 6 anymore. Any idea? Look here, not 5 Prince Davis. No. How many picas are there? How many picas are there? 2 picas. 2 pica. Okay. How many ica are there? 2 ica. Clear? How many vertebral arteries are running through? How many vertebral arteries? See, these green color arteries which are running up, these are called vertebral arteries. How many vertebral arteries are running into the medulla oblongata? 2 vertebral arteries. Next, from these vertebral arteries, 2 anterior spinal arteries are coming. 2 anterior spinal arteries are coming. See, this is one anterior spinal artery. This is the next anterior spinal artery. Back, posterior spinal arteries will be there. Two posterior spinal arteries. So how many? 2, 3, 4, 5, 6, 7, 8, 9, 10. And one more artery is that both these vertebral arteries join together to form basilar artery. See, basilar artery little part is in the medulla oblongata. So even basilar artery. So how many arteries are supplying medulla oblongata? 11. Okay. How many arteries are supplying your medulla oblongata? 11. So this is the entire discussion which you need to know regarding what? Regarding the arterial supply, the circle of Willis, right? Now let us enter into another important topic, that is hemorrhage. That is hemorrhage. Clear? That is hemorrhage. Now look here. This is your brain cavity. This is your brain cavity. Now, what is this layer here? This is your dura mater. Dura mater is double layered like this. This is dura mater, which is double layered. After dura mater, you have got another layer, that is arachnoid matter. After that, you have got a closely attached layer that is called as pia mater. Okay. Now below this is dura. This is arachnoid. And this is pia. Okay. Just below the arachnoid, I have got a lot of CSF here. I have got a lot of CSF. So this is called as subarachnoid space where CSF is located. And by the way, your circle of Willis, yes, Robin Singh, it would be covered after this. Your circle of Willis is located in this space. Okay, where is your circle of Willis located? Circle of Willis is located within this. It is floating in the subarachnoid space. It is floating in the CSF. Now look here. There are veins like this outside the dura mater. There are veins that are outside the dura mater. This is called as middle meningeal artery, MMA. There are vessels outside the dura mater. This is called as middle meningeal artery. If there is a rupture of middle meningeal artery, this you call it as epidural hemorrhage. Not veins. This is an artery. I'm sorry, I spelled it as veins. It is epidural hemorrhage outside the dura mater. Now, below the dura mater, you have got veins. These veins are called as bridging veins. Here also we have got veins. These veins are called as bridging veins. Where are they located? In the subdural space. In the subdural space. So if there is rupture of these bridging veins, this will lead to subdural hemorrhage. Subdural hemorrhage. So extradural hemorrhage, middle meningeal artery. Subdural hemorrhage, bridging veins. Clear? All of you clear? So subdural hemorrhage. Sub, S can be converted into C. S can be converted into C, right? So if you look in the CT scan, you will find a C-shaped lesion. So look here. You can very clearly see a C-shaped lesion like this. So it means this is subdural hemorrhage. Okay. Next, if it is two sides, it is convex. This is called as extradural hemorrhage. If you look here, it is convex on both the sides like this. So this is called as EDH, extradural hemorrhage. Okay. Below, this is C-shaped in this way, right? C-shaped is called as subdural hemorrhage. S can be converted to C. So subdural hemorrhage. Sir, okay, fine. Then what about subarachnoid hemorrhage? You told me circle of Willis is located here. Then in subarachnoid hemorrhage, how will I look? Simple thing, if there is rupture of circle of Willis in the subarachnoid hemorrhage, there will be blood all over the CSF. So when you take a lumbar puncture, you can very clearly see the blood in the CSF. Usually there is no blood. If there is blood in the CSF, patient has got subarachnoid hemorrhage. Okay. Right. Next important concept which you need to know is regarding the cavernous sinus. Okay. Now where is this cavernous sinus located? Exactly in the center. Exactly in the center, your cavernous sinus is located. So in the center, this is the place where your pituitary gland is located, isn't it? On the sides here, this sinus, whatever you can see, this is your cavernous sinus. Center pituitary gland, on either sides you have got cavernous sinus. Clear? Keep that same picture in your mind. Now look here. Center I have got pituitary gland like this, right? Pituitary gland, and on either sides, I have got cavernous sinus in this way. Cavernous sinus in this way. Now, what are the questions that are asked? What are the questions that are asked are, what are the layers that are surrounding cavernous sinus? See, one side there is a layer called as meningeal layer, and on the other side you have got a layer that is called as endosteal layer. So what are the layers? Two layers, meningeal layer, endosteal layer. So this is the question. Second important question is, what are the contents of cavernous sinus? All of you know the numericals 1, 2, 3, 4, 5, 6, right? So start from 3. What will be the numerical? There will be 3, there will be 4, there will be 5, 1, there will be 5, 2, and there will be 6. So what are the cranial nerves that are located within the cavernous sinus? Third, fourth, right? And a trigeminal first nerve, trigeminal second nerve. And where is the sixth nerve located? In the center of the cavernous sinus. These are the contents of cavernous sinus, which they will ask you in the exam for sure. Contents. Okay. Second important thing. Not only that, even there is an artery here in the cavernous sinus. This artery is called as internal carotid artery. So what are the contents? One more content, internal carotid artery. 3, 4, 5, 1, 5, 2, 6, and internal carotid artery. Surrounding this internal carotid artery, you have got a plexus. This plexus is called as sympathetic plexus. This is called as sympathetic plexus. So sympathetic plexus is also a component, a content of cavernous sinus. Very good, Jaggi Chaudhary. Very good. Now, why am I telling you about sympathetic plexus is that if sympathetic plexus is damaged, for example, if sympathetic plexus is damaged, then patient will have meiosis. Meiosis, what is meiosis? Anyone? Constriction of pupil or dilation of pupil? Meiosis is constriction of pupil. Next, patient will also have ptosis. Ptosis means drooping of the eyelid is called ptosis. Okay. And next, patient will also have half side of the face. Patient will not have any sweating. So there will be anhidrosis. Where will be the anhidrosis? Half of the face. So in this patient, meiosis, ptosis, and anhidrosis on one side of the face is seen in case of sympathetic plexus damage, and that is what is called as your Horner syndrome. That is what is called as your Horner syndrome. Are you all clear about Horner syndrome now? Yeah? So, right. Which of the following is a direct content of cavernous sinus? Which of the following is a direct content? Direct content means exactly that is passing directly from the center. That would be your sixth pair of cranial nerve. That would be your abducent nerve. Okay. Right. Now let us look at another important topic, that is Brodmann areas. Brodmann areas are also very, very important, guys. You have to know it. Okay. Now coming to this Brodmann areas, what are the important things to discuss? This center black line, whatever I have drawn here, this is called as central sulcus. In front of the central sulcus, I call it as primary motor area. Back of the central sulcus, I call it as primary sensory area. Okay. So this is called as primary motor area, and this is called as primary somatosensory area. So in primary somatosensory area, I will have Brodmann area 1, 2 and 3. And in the primary motor, I will have 4 and 6. Okay. Next, the area that is responsible for my vision is located on the occipital side here. That will be 17, 18, 19. On the back side, it is 17, 18, 19. This is the visual area. What is the important area in this Brodmann's? What is the important area is that all of you look here. Here we have got area 44, 45. Just below that we have got 41, 42. Where is Wernicke's area? Wernicke's area is located behind. Okay. So this is the Wernicke's area in the superior temporal lobe here. Superior part of the temporal region, you have got this area, and this area is called as Wernicke's area. Wernicke's area. Okay. All of you are clear? And what are these 44, 45 called as? Anyone, any idea? 44, 45 is called as? Yeah. Very good, Prince. 44 and 45 is called as Broca's area. Broca's area. Okay. Now, whenever patient will have any damage of Broca's area, you call it as Broca's aphasia. Whenever patient will have any damage of the superior temporal lobe, patient will have Wernicke's aphasia. Okay. So the problem with Broca's aphasia is speech production. Here the problem is speech comprehension. Speech comprehension. So if you tell, hey, how are you doing? Now, if you ask a patient of Broca's aphasia, so he will tell you, yes, I'm fine, I'm not bad. In this way, he's gonna tell you. What is this called as? Broca's aphasia. Problem with speech production. Okay. Now, you can't understand his speech. Wernicke's area. In Wernicke's area, patient will talk to you nice, right? But what is the problem is speech articulation. If you ask him, how did you come to the hospital? He'll be telling you, I first took a bus, then locked my house door, wore chappal, I went to the bathroom, then I paid money to the bus driver. So whatever is telling, it is not in the form of a story, right? So the way he has comprehended his speech inside his brain is completely zigzag. That is called as speech comprehension, right? So these are the important things so far to know. Okay. Sorry. This is not visual. I mean, this is Wernicke's. Thank you so much, Ajani Singh. Yeah. Now let us move on to this thing. What is the important thing is that primary motor area, that is area number 4, right? Primary motor area is area number 4. Yes. Now that is supplied by which artery he is asking. Primary motor area or area number 4 is supplied by two arteries. One is called as anterior cerebral artery. Another one is called as middle cerebral artery. Keep this thing in mind. Very, very important. Anterior and middle cerebral artery. Okay. Anterior and middle cerebral artery. It supplies your primary motor area. That is area number 4. One supplies laterally, another one supplies medially. Okay. Right. Now, if anterior cerebral artery, if it is occluded, or if there is rupture of anterior cerebral artery, then what will the patient have? Symptomatically, what will he have? Every year one question is asked from these guys. Every year they will ask you one question. Anterior cerebral artery injury will lead to bladder dysfunction. Middle cerebral artery will lead to aphasia. Posterior cerebral artery problem will lead to hemianopia. Hemianopia in the sense, this is your eyeball, this is your eyeball. The medial side on one eyeball and the lateral side of the other eyeball, the vision is lost. Okay. Hemianopia. Very good, Dr. Benedict. So every year one question is asked from this. Every year one question is asked. Clear, all of you? Now let us discuss the muscles of mastication. Highly important. Highly important. Muscles of mastication are all the time important. Okay. Now look here. All the muscles of mastication are supplied by mandibular nerve. Keep that thing. All of them are supplied by mandibular nerve. So that is fixed. Okay. Now, what are the muscles we have? Exactly here, we have got this muscle. This muscle is called as masseter muscle. This is called as masseter muscle. Inside the mouth, there I have got this muscle. This is called as medial pterygoid muscle. Medial pterygoid muscle. Okay, medial pterygoid muscle. Just below the mandible here, just below the mandible, I have a muscle. This is called as mylohyoid muscle. Mylohyoid. So it is attached to the hyoid bone like this. Mylohyoid muscle. Okay. Next, there is another muscle that is coming all the way like this. This is called anterior belly of digastric, which is attached to hyoid. Here there is posterior belly of digastric. Anterior belly and posterior belly of digastric. Okay. Next, we have got another muscle going up like a fan. Going up like a fan here like this. This is called as temporalis muscle. What is this called? Temporalis muscle. And at the end, I'll give you a very nice shortcut of how to remember all these muscles. Okay. So when I have medial pterygoid, I will also have lateral pterygoid, right? So all these are the muscles of mastication. All these are the muscles of mastication. Now, how do you remember this? How do you remember this is that you went to Maldives, okay? You went to Maldives and you met someone who looks exactly like you. So obviously you will be tensed, isn't it? So the mnemonic also goes that way. I went to Maldives and someone met me who looks exactly like me. That is why I developed tension. Now, what does D here? D means depressors. What are the depressors of your mandible? What are the depressors? That is MAL. What does MAL stand for? Mylohyoid, anterior belly of digastric, and L stands for lateral pterygoid. L stands for lateral pterygoid. Okay, very, very easy. Mylohyoid, anterior digastric, and lateral pterygoid. Mylohyoid, why it is down? When I contract it, the jaw will be opened. Anterior digastric, why it is also down the mandible. When I contract it, again the jaw will open. So these are the depressors. Now, when I discuss about depressors, I should also discuss about elevators. Now, what are the elevators? Elevators are met me. What is met me? M stands for masseter. T stands for temporalis. And ME stands for medial pterygoid. When there is lateral pterygoid, there will be medial pterygoid. And finally, there are tensors. So tell me all the names of the muscles which are starting with tensors. Yeah, there are two muscles which are starting with tensor. Tensor tympani, tensor palatii. Tensor tympani and tensor palatii. So these are the two muscles, tensor tympani, tensor palatii. Right? All of you understood, guys? All of you understood? And all of them are supplied by the mandibular nerve. All of them are supplied by the mandibular nerve. Now, regarding spinal cord, what are the important things you need to know? Now, spinal cord in adults. Important questions from spinal cord. Spinal cord in adults starts all the way from C1 and it goes to the lower border of L1. L1 lower border. L1 lower border till here spinal cord will extend. Next, in neonates, the spinal cord will start from C1 and it will go till L3. But not lower border of L3, upper border of L3. Upper border of L3. Okay. Now, where do you do lumbar puncture? Where do you do lumbar puncture? Yes, lumbar puncture is done between L1 as well as S2. In between L1 and S2, that is the safest place for you to do the lumbar puncture. That is the safest place for you to do the lumbar puncture. L1 and S2, in between L1 and S2, wherever you want, you can do. Because after that, you won't have spinal cord, because I told you L1 lower border is the last point for the spinal cord, and after that, all the meninges only you will have. Clear? So these are some of the important points you need to know regarding the thing, spinal cord. Next important thing, muscles of tongue. Muscles of tongue are highly important. Muscles of tongue are very important, guys. What are the muscles of tongue? We have got two groups of the muscles of tongue. Some are called as extrinsic muscles, some are called as intrinsic muscles. How do you remember intrinsic muscles? Very easy. Very easy. You see an arrow pointing upwards. So what is this arrow pointing upwards? It is superior. Superior. You see an arrow pointing downwards. It is inferior. How is the arrow, straight or vertical? It is straight. Straight or horizontal? It is straight. So it is called longitudinal. Superior longitudinal muscle, inferior longitudinal muscle. Okay. Next, you can see a red line transversely. So transverse muscle. And you can see a green line straight. That is called vertical muscle. So what are the intrinsic muscles? Superior longitudinal, inferior longitudinal, transverse as well as vertical. So these are the four intrinsic muscles. When it comes to extrinsic muscles, right, tongue is a very powerful weapon. You know, you do a lot of gossips. You do a lot of gossip with the help of the tongue. So what are the basic gossips you do, guys? You do genoglossus, S for styloglossus, P for palatoglossus, and finally there is one more muscle, H, that is for hyoglossus. So how many we have? Genoglossus, styloglossus, palatoglossus as well as hyoglossus. So these are the extrinsic as well as the intrinsic muscles of the tongue. Clear? Right. So I mean, I'm not sure if they ask you question from this, but if they ask you, they might ask you the name of the muscle. But definitely more than this, important thing is that the nerve supply, they will ask you this definitely, guys. If they want to ask you regarding the tongue, they definitely will ask you from this point which I'm telling now. There are basically two types of sensations in the tongue. Okay, motor and sensory. I'm talking about sensory. In sensory also there are two types of sensations. One is called taste sensation. Another one is called as general sensation, like heat, temperature, right? The cold part, the pain part and all. So these are general sensations. Apart from general sensation, we also have taste sensation. So two sensations in sensory part. One is called general sensation. Another one is called as special sensation. So now look here, the posterior most of the tongue, in the posterior most of the tongue, which nerve carries the general sensation, which nerve carries the special sensation? General sensation is carried out by the 10th pair of cranial nerve. Special sensation is also carried out by the 10th pair of cranial nerve. Next, in the posterior 1/3 of the tongue, 9th pair of cranial nerve carries the general sensation, 9th pair of cranial nerve carries the special sensation. But whereas in the anterior 2/3 of the tongue or anterior 1/3 of the tongue, V3 nerve, what do you mean by V3 nerve? That is trigeminal nerve, right? So trigeminal nerve carries the general sensation and 7th pair of cranial nerve carries the special sensation. If you remember this, you can make wonders in the questions, guys. If you remember this table, then definitely most of the questions from here in this table will be easily solved, very easily solved. Okay, now look here. Few important questions just to just mug it up if you want. Sensory nerve supply to the angle of jaw. The angle of jaw sensory nerve supply is by greater auricular nerve. Greater auricular nerve. Okay. Cadaveric like position of vocal cords. Right. When will you see cadaveric position of vocal cords? Which nerve paralysis or palsy you will see cadaveric position of vocal cords? Any idea? Cadaveric, yes, Jaggi Reddy, you're right. Jaggi Chaudhary. Cadaveric like position of vocal cords is seen in which nerve palsy, guys? Recurrent laryngeal nerve palsy. Recurrent laryngeal nerve palsy. Next, nerve supply to the tip of the nose. Tip of the nose nerve supply is given by trigeminal nerve. In trigeminal nerve, the ophthalmic division of trigeminal nerve. Ophthalmic division of trigeminal nerve. Right? Very good, Roy. Dr. Benedict. Excellent. Now, guys, after this, I'm going to give you some 5 statements. Okay? 5 statements. Daily in the morning and while sleeping and when you're time passing. These statements, like mantras, they have to be on the tip of your tongue. Okay? These statements will help you a lot, I'm telling you. What are these statements? You just have to keep on chant these statements again and again. Okay? Now, what are these statements are? All the muscles of larynx, are supplied by recurrent laryngeal nerve except cricothyroid muscle. Except cricothyroid muscle. Why? Because cricothyroid is supplied by external laryngeal nerve. Because cricothyroid is supplied by external laryngeal nerve. All muscles of larynx by recurrent laryngeal nerve except cricothyroid, because cricothyroid is supplied by external laryngeal nerve. In the same way, very good. In the same way, another important thing is that all the muscles of the pharynx are supplied by vagoaccessory nerve except all muscles of pharynx are supplied by vagoaccessory complex except 2 muscles. One is cricopharyngeus, stylopharyngeus. What are those 2 muscles? Cricopharyngeus, stylopharyngeus. Cricopharyngeus and stylopharyngeus, they are also the muscles of pharynx, but they are not supplied by vagoaccessory complex. They are in turn supplied by, one is supplied by recurrent laryngeal nerve, another one is supplied by glossopharyngeal nerve. Glosso, I'm just writing it as glosso. Okay, glossopharyngeal nerve. Third important thing you already know, all the muscles of mastication without any exception, they are supplied by all muscles of mastication are supplied by, yes, which nerve, guys? Tell me. Very good, Jaggi Chaudhary. Perfect. Mandibular nerve. Mandibular nerve. And the last statement, guys, and the last statement, all the muscles of your palate, all muscles of palate are supplied by vagoaccessory complex except vagoaccessory complex except tensor veli palatini. Except tensor veli palatini, which is supplied by mandibular V3. Okay, very good. Gopal Godara, very good, very good. Osama Sheikh, excellent, Osama. So these are the 5 golden statements, guys. These are the 5 golden statements. You have to remember it at any cost. At any cost, please remember these golden statements. Very, very important. Okay. Clear, all of you? Right. Okay, now let us move on to the next very important part, that is your triangles of the neck. That is the triangles of neck. You know, triangles of neck is also very important. So in the triangles of neck, we have got two triangles. All these are the anterior triangles, which you can see from the anterior side. Back side, you have got the triangle here. This is called as a posterior triangle. Okay, so this is anterior, this is posterior triangle. Now let me name these triangles. Let me name these triangles. All of you know here that this triangle which you can see, I'm naming it as D. D means digastric triangle. What is this? Digastric triangle. Next, in the center you have got submandibular or submental triangle. Okay, just here you have got submental triangle. Okay, submental triangle. Right? Fine. Next important thing is that here you have got a triangle here. This is called as carotid triangle. C for carotid triangle. Here also carotid triangle. Next important thing is that in the center you have got a triangle. This is called as muscular triangle. This is called as what? Muscular triangle. And finally, you have got two triangles here. Actually, you can look it from the anterior side, but these are not considered as anterior triangle. This is a part of posterior triangle. Okay, this triangle is called as omoclavicular triangle. There are other names also. I will write it down. So look here. So what are the triangles we have got? Digastric triangle. We have got submental triangle. We have got carotid triangle. We have got muscular triangle. We have got omoclavicular triangle. So other name for this omoclavicular triangle is omoclavicular triangle is also called as, what is the other name? Supraclavicular triangle. Supraclavicular triangle or subclavian triangle. Subclavian triangle. All these are the same. Okay, supraclavicular or subclavian, all these are the same. Clear? Now, these are the triangles which I have drawn, guys. Okay, so what are the names of these muscles? So this muscle is called as anterior belly of digastric muscle, and this is called as posterior belly of digastric muscle. And this muscle, pink one, is called as sternocleidomastoid muscle. All of you know it is sternocleidomastoid muscle. And this is called as trapezius muscle on the back. Trapezius muscle. And this one is called as omohyoid muscle. Omohyoid muscle. So now I'm not going to tell you the borders, guys, because by looking at the names of these muscles, you by yourself you have to know the borders. And this is your mandible all the way. This is your mandible. Okay, by looking at that you can very easily tell digastric muscle border. What is the border? Anterior belly, posterior belly, and mandible. So in that way you can infer yourself. Okay, so you do that work by yourself. Boundaries are very easy. By looking at the names you can tell it. Now coming to anterior triangle, what are listed under anterior triangle? Carotid, digastric, muscular, and submental. All these four are listed under anterior triangle. Other than this, everything is a posterior triangle. Okay. Now, look here. Another important thing is that here is asking carotid artery bifurcation happens in. Carotid artery bifurcation means, look here very carefully. Common carotid artery dividing into two branches. One is called as external carotid, internal carotid. This is called as carotid artery bifurcation. It happens in which triangle? Carotid triangle. It happens in carotid triangle. Where is thyroid gland present? Thyroid gland is present exactly here in the muscular triangle. I told you that this is muscular triangle, guys. In the muscular triangle, you will have thyroid gland. In the muscular triangle, you have thyroid gland. Okay. Brachial plexus block is given in which triangle? So from where does this brachial plexus it passes, guys? It passes through this triangle. Which triangle? subclavian triangle or homoclavicular or supraclavicular triangle. So from here only the brachial plexus will pass all the way like this. Okay. So if I wanted to do some operation here, so I will give a block to brachial plexus. So where will I give? In the homoclavicular triangle here, I'll give an injection so that the brachial plexus will be blocked. In the subclavian triangle. Okay, subclavian triangle. Remember one more point also. Not only brachial plexus block, I will also give subclavian artery block in the subclavian triangle. Even subclavian artery block is also given in the subclavian triangle. Subclavian artery block, that is also given in the subclavian triangle only. Okay, next. What is the, they will ask you, they will tell you the course of nerve and ask you what is that nerve. A nerve passes through hypoglossal canal, then ascends up to carotid canal, then ascends into the digastric triangle. So from hypoglossal canal to carotid triangle, from carotid triangle to digastric triangle. So what is the name of this nerve, guys? Anyone? Yes. Very good. This is 12th pair of cranial nerve. This is 12th pair of cranial nerve which is passing through hypoglossal canal, next carotid triangle, then digastric triangle. Contents of carotid sheath. In the carotid triangle, we have got carotid sheath. What does this carotid sheath consisting of? Carotid sheath is consisting of all these things. What are these things? Internal jugular vein on one side, internal carotid artery on the other side, vagus nerve in the center. Vagus nerve is present in the center, internal carotid there, internal jugular vein here. So can I tell if there is aneurysm of internal carotid artery, vagus nerve will be compressed? Yeah. Next important thing is that external carotid artery is outside the carotid sheath. This is an important question. Is outside carotid sheath. It is outside the carotid sheath. Right? It is not inside, it is outside the carotid sheath. Now coming to the posterior triangles. Coming to the posterior one, you can see here very well. So this entire triangle which you can see, this is called as a posterior triangle. In the posterior triangle, there are two triangles. So whatever I'm shading it with the yellow marker, right? Whatever I'm shading it with the yellow marker, this is called as occipital triangle. Occipital triangle. And what is this triangle here? Anyone? What is this triangle? Come on. Very good, Prince Davis. Very good. Subclavian triangle. This is called as subclavian triangle. That is why I told you subclavian triangle is a posterior triangle. Okay. They asked once a question that which of the following triangles are not a part of anterior triangles. So they have given you all the options. In that option, they have given this option also, subclavian triangle. So subclavian triangle is not a part of anterior triangle. It is a posterior triangle. Okay. Now, what is the most important thing which you can, what is the most important thing which you can tell in case of triangles? One is, what are the contents of carotid sheath? That is very important. See, 3 questions. Carotid sheath contents. Second important question, what are the different types of blocks which you give here? I will tell you that. Third important, what are the contents of posterior triangle? These are the 3 questions so far which were asked, and these only will be asked in the upcoming exam also. Just trust me. Okay, these 3 questions only. Now, what are the contents of occipital triangle? We are discussing now contents of occipital triangle. Nothing difficult at all. Remember the mnemonic biceps. Remember the mnemonic biceps. B stands for brachial plexus. Instead of putting it as occipital triangle, I will put it as posterior triangle, because in posterior I will also get subclavian, right? So subclavian, occipital together I'm telling you. Brachial plexus, the trunks of brachial plexus especially, the trunks, okay? Next important thing is that C stands for cervical plexus. C stands for cervical plexus. Next, E stands for external jugular vein. External jugular vein. Fourth important one, P stands for phrenic nerve. Phrenic nerve. And fifth one, biceps. S stands for the spinal accessory nerve. Spinal accessory nerve. Spinal accessory nerve. Now, what are the branches of cervical plexus? So, very, very easy. What are the branches of cervical plexus are? Remember it as GST. Now, what are the branches of cervical plexus? G stands for greater auricular nerve. S stands for supraclavicular nerve. T stands for transverse nerve of neck. And L stands for lesser. Very good, Prince Davis. Lesser occipital. Now, these are the branches of cervical plexus, guys. I have provided mnemonics. I have provided mnemonics for everything, but for cervical plexus, there is no mnemonic. You just have to remember it, okay? Biceps is the mnemonic for the entire posterior triangle, okay? Now, look here. Very, very important thing. Very, very important thing is that brachial plexus block. Which triangle will you give? Brachial plexus is present in subclavian triangle. So, I will give a block in subclavian triangle. I will put an injection into the subclavian triangle. Stellate ganglion block. Where will you give? Where is stellate ganglion? Carotid sheath is there. Surrounding the carotid sheath, can you see a chain, a green color chain? This is called a stellate ganglion. This is called a stellate ganglion. Okay, it is behind the carotid sheath. So, where will I go? Into the carotid sheath here, in the carotid triangle. Okay, so carotid sheath, behind the carotid sheath. Subclavian artery block. Actually, subclavian artery has got three parts. I told you, first part, second part, third part. You are giving block in the third part because third part is little bit superficial here. Okay, so you will give block in the third part. Where is that located? Again the same answer. Again the same answer. Subclavian triangle. Cervical plexus block. Where is cervical plexus located? We just now discussed that in the posterior triangle, we have got something called cervical plexus. So, where will I find, where will I give an injection of cervical plexus? Exactly in the center of sternocleidomastoid. This is sternocleidomastoid, right? Exactly in the center, if you give an injection, you are blocking right now the cervical plexus. So, exactly in the mid of sternocleidomastoid. So, regarding the triangles, guys, names of the triangles, anterior posterior triangles you have to identify, blocks, carotid sheath. These are the four important questions which they will ask from triangles. Okay. Other than that, nothing will come, and don't panic at all. Okay. All of you are clear with this? And another question that will be asked is that what is the topography of thyroid gland? C5 to T1 is the topography of thyroid gland. C5 to T1 is the topography of thyroid gland. But thyroid gland is supplied by two arteries. One artery is coming from the top, that is called superior thyroid artery. Superior thyroid artery. One artery is coming from the bottom. This is called as inferior thyroid artery. Inferior thyroid artery. Superior thyroid, inferior thyroid. What are the, from where superior is coming, from where inferior is coming? Look here. External carotid artery branches superior thyroid artery, and that gives a supply like this. Okay, that gives a supply. Very good. Next, from where inferior thyroid artery is coming? One of the branch is subclavian artery. From the subclavian artery, a branch that goes up, and this is called as inferior thyroid artery. So, superior thyroid artery is a branch from external carotid artery. I am not telling direct branch. There is maxillary artery in between. I am not telling direct branch. Superior thyroid artery is coming from external carotid. Inferior thyroid artery is coming from subclavian. Keep this thing in mind. This should be clear for you. Okay. external carotid, subclavian artery. More specifically speaking, Roy is telling me thyrocervical trunk. Yes, more specifically speaking, from thyrocervical trunk, you have got inferior thyroid artery. More specifically, clear? Right? Right. So superior thyroid artery is a branch of Okay. In emergency tracheostomy, all the structures are damaged except thyroidema artery. All the structures while doing emergency tracheostomy, they are cut. Okay. So isthmus of thyroid gland is cut, inferior thyroid artery, inferior thyroid vein, all of them are ruptured except thyroidema artery. Okay. This thing you have to just keep it in mind. Another very important thing, that is Kisselback's plexus or Little's area. So don't you think this is important, guys? Kisselback's plexus or Little's area. Okay. How do I remember Kisselback's plexus? How do you remember is that you have to remember a mnemonic called as GASP. 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 If you remember GASP, then done. What does G stands for? G stands for greater palatine artery. Okay. So you have got an artery like this. Okay. This is called as greater palatine artery. This is called greater palatine artery. Then what does A stands for? Anterior ethmoidal artery. Always remember, wherever there is superior, there is inferior. Wherever there is anterior, there is posterior. So this is anterior ethmoidal artery. When I tell anterior ethmoidal artery, there will definitely be another artery. This is called as posterior ethmoidal artery. So this is called as posterior ethmoidal artery. Anterior ethmoidal, posterior ethmoidal. Next, G is finished, A is finished, S. S stands for, if you look here, S stands for sphenopalatine artery. Sphenopalatine artery. Okay. And another S stands for superior labial artery. I'm watching your comments, guys. You are doing good. This is really a good news that all of you know everything, superior labial artery. And finally, P stands for posterior ethmoidal artery discussed, right? So what are the branches, guys? Superior labial artery, sphenopalatine artery, greater palatine artery, posterior ethmoidal and anterior ethmoidal. Okay, these are the branches you have to know. So all of them together, they will form a plexus here. This is called as Kisselback's or this plexus. Now all of you know why this area is important, because there will be heavy nose bleeds from here. There will be heavy nose bleeds from here, right? That thing you call it as epistaxis. What is that thing you call it as? Jaggi Chaudhary is asking, sir, posterior ethmoid is a branch of. Jaggi Chaudhary, anterior ethmoid, posterior ethmoid, both of them are branches of internal carotid artery. Okay. I don't want you to go deep. Okay. So this is internal carotid artery, for example. Internal carotid artery will give a branch, and that branch is called as ophthalmic artery. Ophthalmic artery. A branch of ophthalmic artery is anterior ethmoidal. Another branch of ophthalmic artery is posterior ethmoidal. Okay. Clear, Jaggi? Right. So epistaxis. Now the question which they're going to ask you from here, the first question is that which of the following arteries are not a part of Kisselback's plexus? First thing. Second thing they will ask is that which artery is responsible for epistaxis? Which artery is mostly responsible for epistaxis? Out of all these arteries are responsible for epistaxis, but sphenopalatine artery is more contributing for epistaxis. Sphenopalatine artery is the most important artery because this is the one which is contributing more for the epistaxis. Okay, it is coming because it is directly coming from the maxillary artery. Okay, so clear, all of you? Clear of regarding this. Artery responsible, spinopalatal, hoye boldi. So I've already taught this, right? Coming to the next important and the major part, guys, that is the cranial nerves. That is the cranial nerves. Which foramen, which cranial nerve, that is very, very, very important for your exam. Okay, very, very, very important. Now, in the anterior part here, you can see this dotted perforated bone here. This is called as cribriform plate. Cribriform plate. Now, from this cribriform plate, this is in the anterior. Anterior, we have nose. Nose means olfactory. So, in this way, you remember, guys. Okay. Cribriform plate, olfactory nerve, olfactory nerve, olfactory nerve. Next important thing we have is that here we have got a small hole here, small hole which you can see. This is called as optic canal. There is no need to tell what is the use of optic canal, because from the optic canal, everything responsible for the eye will pass, right? What is optic nerve? Second pair of cranial nerve, right? Cranial nerve number 2. Next, unrelated what? Ophthalmic artery. Ophthalmic artery, right? Ophthalmic artery is done. So from optic canal, cranial nerve number 2, ophthalmic artery, right? After that, remember Ross. Remember Ross, right? Ross means, you know, Ronald Ross. You remember Ronald Ross? So what is this Ross? Here you see a round foramen. This is called as foramen rotundum. Okay. There below that you can see an oval foramen. This is called as foramen ovale. Okay. Next, below that you can see a small foramen, that is called as spinous foramen. Ross. R-O-S. Now what is coming from foramen rotundum, ovale and spinosum? Tell me. Foramen rotundum. We have got, very good. How do you remember? How do you remember is that, see, rotundum means round. I am making maximum rounds in the ground. Okay. When I'm going for a walk, I'll make maximum rounds. Maximum means maxillary nerve. In that way you can remember, right? So maxillary nerve, right? So maxillary nerve. That is phi 2. Ovale. Ovale is V3. What is V3? Mandibular. Very good. Mandibular. And spinous? Spinous, tell me. Spinous, remember it as MEN. Men. What does MEN stand for? You know, men's have spines. What does M stands for? Very good. Middle meningeal artery. E stands for, what does E stands for? Very good. Emissary veins. Emissary veins. And N stands for nerve. Which nerve? Spinous nerve. Spinous nerve. So spine, just remember like spines. Okay, men's have spines. What are the spines? MMA, right? Emissary veins as well as spinal nerve. Next, after that, we have got another important thing, that is this foramen over here. You can see this is called as internal acoustic meatus. Internal acoustic meatus. Okay. After internal acoustic meatus, we have got, I will tell you what is there. I mean, I will tell you easily what is there. Okay. I'll make a shortcut. Below internal, that you can see an L-shaped foramen there. That L-shaped foramen is called as, not L. It is looking like a J, right? J-shaped foramen, inverted J. So can I call it as jugular foramen? Yeah, this is called as jugular foramen. Jugular foramen. And exactly near to foramen magnum, I have got this one called as hypoglossal canal. Hypoglossal canal. And finally, this is your magnum, foramen magnum. Now, how do you remember internal acoustic meatus, jugular foramen, and hypoglossal canal? All of you know to count the numbers 7, 8, 9, 10, 11, 12, 13, 14. You know it, right? 7, 8, 9, 10, 11. So count it like this: seventh pair of cranial nerve, eighth pair of cranial nerve, next here 9, 10, and 11, and finally we have got 12. Easy. 7th, 8th, 9th, 10th, 11th, and 12th. Clear? So, I cannot tell you from where the question is asked in this, because every point is a important point. Right? So, this is how simplified you studied. This is how simplified you studied. But one thing that that was repeated in June exam, guys, I don't remember the year, maybe 2020 or 2021, I think, I don't know. In June exam, they asked what are the structures that pass through foramen ovale. I don't know if it is large foramen, that is the reason why they have asked it, I think. Foramen, where is foramen? Yeah, the small foramen, foramen ovale. What are the structures that pass through foramen ovale? Foramen ovale. Okay. So what are the structures that pass through foramen ovale? MALE, male. Yes, this is the famous mnemonic. Even I have not found any other than this. So what is MALE? M stands for mandibular nerve. Mandibular nerve. A stands for accessory meningeal artery. Right? L stands for lesser petrosal nerve. And E stands for emissary vein. The screen is blurry. Screen is blurry, guys. No. It is not blurry. Right. We are about to close these topics, guys. We are about to close. I think we are done with the foramens, right? Foramens are very important. Foramens are very important. Right. Coming to the next important question which has been asked is regarding parotid gland. Regarding parotid gland, I'm telling you, you can expect a question. And there is nothing learning about this parotid gland. Very, very easy, guys. Simple thing. All of you look at me. All of you look at me. This is my mandible, right? This is my mandible. Okay? This is my mandible. Here I will have parotid gland. And back of this I will have mastoid bone. Mastoid bone, parotid gland, mandible. So the same thing I have drawn. Mandible in the front, parotid gland in the center, and the mastoid bone back. Okay? On mastoid bone, two muscles are attached. What are those two muscles, guys? One is called as posterior belly of digastric. Another one is sternocleidomastoid muscle. Sternocleidomastoid muscle. And what is the muscle here? That is the, see, I want you to identify. That is the reason why where I was discussing muscles of mastication, I have drawn this muscle. So this muscle here is your masseter muscle. Masseter muscle. And this is your buccinator muscle. Buccinator muscle. Okay. So that side it is medial side, and wherever masseter and buccinator are present here, this is the lateral side. Now what is my main intention? Within the parotid gland, the facial nerve enters into the parotid gland. Facial nerve enters into the parotid gland but does not supply the parotid gland. It will just enter into the parotid gland, divide the parotid gland into two parts. One is called as the superficial, another one is called as the deep. Superficial part is having few lymph nodes, whereas the deep part is having many lymph nodes. It is having many lymph nodes. In the exam, what they'll ask you is, what are the contents of parotid gland? Contents of parotid gland are, the first important content is facial nerve. Facial nerve is a content. What is the second important content? you can see this artery, red color artery over here. This is called as external carotid artery. What is this? External carotid artery. External carotid artery. And what is this blue color thing? This blue color one is called as retromandibular vein. Very good, Prince Davis. Prince, you are perfect. Third one is retromandibular vein. Okay, retromandibular vein. And fourth important one is surrounding the external carotid artery. Can you see green color thing? This is called as sympathetic plexus. This is called as sympathetic plexus. So we have got facial nerve, external carotid artery, retromandibular vein, as well as sympathetic plexus. So all these are the structures that are located within the parotid gland. So this is a very, very highly classified question. Very, very important question, guys. Very important question. Okay. Now, the question which they were asked is, Stenson's duct passes lateral to which muscle? This was a repeated question. Look here. What is Stenson's duct? This is the duct of the parotid gland. See here, the Stenson's duct is coming like this, and it is passing lateral to masseter muscle. It is passing lateral to buccinator muscle. It is making a hole in the buccinator muscle, and it is entering into the mouth. Through the second molar, it will enter into the mouth. Okay, so it is passing lateral to which muscle? Masseter muscle. It is passing lateral to masseter muscle. So these are the important things which you need to know regarding this thing. Regarding this thing. Okay. Next important thing. Next important thing. Very, very important, guys. Keep this thing in mind. If there is, three golden points again. Look here. If there is unilateral, only one side, recurrent laryngeal nerve damage. If there is unilateral recurrent laryngeal nerve damage, patient will not lose this voice, but he will have just hoarseness of voice. He will have hoarseness of voice. But if there is bilateral recurrent laryngeal nerve damage, then patient will have stridor, because the vocal cords, the airway will be closed and the air cannot pass inside. It will very nearly pass inside. That will lead to a production of sound called as stridor. Stridor. Okay. Next, if there is bilateral damage to superior laryngeal nerve, this would lead to severe aspiration. Okay, so what you need to do in these two cases, you need to do emergency tracheostomy. What is the thing you do here? You do emergency tracheostomy. How do you do emergency tracheostomy? From the second and third tracheal ring, you do the emergency tracheostomy. Okay, clear, everyone? Yeah, very good, very good. So guys, question, definitely you're gonna get a question here. Keep this thing in mind, guys. Definitely you're gonna get a question. Now coming to ocular muscles. See, guys, in the entire discussion of anatomy, I have never discussed anything such that you have to put a lot of load on your memory. Everything I have discussed through the pictures and the mnemonics, right? If you revise this after the lecture 2 times or 3 times, definitely you'll not forget it. Okay. Right. Look here. Very good. Roy is already answering all these answers here. Very good, Roy. Ocular muscles, simple thing. Above the eyeball, we have got superior rectus. Below the eyeball, we have got inferior rectus. Here on the lateral side, we have got lateral rectus. On the medial side, we have got medial rectus. And what all they can ask you? Superior oblique, and here we have got inferior oblique. So these are 1, 2, 3, 4, 5, 6, 6 ocular muscles. What is the nerve innervation? That is highly, highly, highly important. You have to remember it like a chemical formula. SO4, LR6, R3. SO4 LR6 R3. Again, SO4 LR6 R3. So repeated, chanted day and night. SO4 LR6 and R3. SO4 means superior oblique is supplied by fourth pair of cranial nerve. LR6 means lateral rectus is supplied by sixth pair of cranial nerve. R3 means the rest all are supplied by the third pair of cranial nerve. Clear? So this is all they asked you. The last important thing regarding the eye region they ask you is superior orbital fissure. Very, very important. Very, very important. Superior orbital fissure. Superior orbital fissure. Okay. Superior orbital fissure in the sense. So if you look at this skeleton here, in the skeleton, we have got two important points. So in the eyeball here, you can see superior orbital fissure inside, and down we have got inferior orbital fissure. Here superior orbital, here inferior orbital fissure is there. Okay. So in superior orbital fissure, what are the contents they will ask you? Okay, look here. Superior rectus, lateral rectus, medial rectus, inferior rectus. Okay, so these are the muscles that form the eyeball, right? In the center, you will have a tendinous sheath. You will have a tendinous sheath in the center. This is called as, what is this called as? Yes, tendinous ring of Zinn. This is called as tendinous ring of Zinn. So, but what will they ask you? They will ask you what are the contents inside, what are the contents outside the ring. Look here. I hope you understood what is tendinous ring of Zinn, right? So what are the nerves left outside the ring? Outside the ring, what are the nerves you have left outside the ring? What are the nerves you have outside the ring? What are the nerves you have outside the ring, guys? Simple thing. Left outside the rings. Left, LFT, left outside the rings. L for lacrimal nerve, F for facial nerve, and T for trochlear nerve. Very, very, very easy, right? Very easy. Left outside is LFT. Next, what are the veins that are left outside the ring? What are the veins that are left outside the ring? Outside the ring. Okay. Two veins, superior ophthalmic vein, inferior ophthalmic vein. Sir, how to remember? We are discussing about eye. In eye only we discuss about veins of eyes. That is ophthalmic vein. So superior and inferior. Right? Next important thing. What are the nerves that pass inside the ring? What are the nerves that pass inside the ring? Alright. What are the nerves that pass inside the ring? Cranial nerve number 3, cranial nerve number 6, and nasociliary nerve. Nasociliary nerve. These are the three nerves that pass inside the ring. Okay. These are the three nerves that pass inside the ring. Prince Davis is telling Sonia is the mnemonic. If you can understand what is Sonia, then well and good, Prince. Yeah, if that suits you, then that would be great. All of you clear? Right? So guys, if you are hungry, bring your plate, sit in front of the live, and while eating you can watch it, but don't go away, because again and again I'm telling you, these topics are very, very, very important. Okay? These topics are very important. Let me have some water and then let us start. You want 5 minute break? Do you really all want 5 minute break? If I give 5 minute break, all of you will go away. You won't even come back again. You see, Roy is inspiring me with his words. Right, guys. So far, whatever we have discussed regarding the head and the neck, I know most of the topics might not be completed, but these are the highly expected topics, guys. Okay, and even we have to complete the remaining, the abdomen part, the pelvis part, as well as the lower limb. So we shall do it fastly now. Okay, so these are the highly anticipated topics, and from these topics which I've taught you, I'm guaranteeing you guys 3 questions will definitely come. 3 questions will definitely come, guys. Even I will put a screenshot. Okay, don't worry. Even I'll put a screenshot. 3 questions will definitely come. Okay, all of you go get your plates, guys. Just 2 minutes. We will have a break. Okay, just 2 minutes, 2 or 3 minutes maximum, and we shall start lower limb and abdomen. Okay. 3 minutes. Hello. Hello, guys. So, welcome back. Welcome back, guys. Welcome back, Osama. Deep Sutar. Welcome back, Deep. Right. So, shall we start, guys? Yeah. Right. So, regarding, hello, Riddhi. So, regarding the lower limb, guys, regarding the lower limb, we shall finish up the lower limb very fastly. Only few important things will be asked. Okay. You know, the lower limb, we shall be discussing the thigh region. Okay. All of you. Now, let's go fastly. All of you be intact. Right. So, in the lower limb, important things we need to discuss is that we have got three compartments, right? Anterior compartment. I hope all of you, am I audible to everyone, and is the screen clear to everyone, guys? Yeah. Right. So regarding the lower limb, guys, lower limb is basically divided into three compartments. One is called anterior compartment, medial compartment, and posterior compartment. Okay, there is no lateral compartment here. Now, the important thing to know is that what is the nerve of anterior compartment? Anterior compartment entirely is supplied by, is innervated by femoral nerve. Is innervated by femoral nerve. Okay, and what is the root value? L2, L3, L4. So this is the root value of the femoral nerve. So basically the posterior division of L2, L3, L4, they supply the anterior compartment. Now when it comes to the posterior compartment, I have already told you, posterior compartment is sciatic nerve. The nerve of the posterior compartment is sciatic nerve, and the nerve of the medial compartment is obturator nerve. Obturator nerve. Okay. So what is dividing it into compartments? The deep fascia. So deep fascia of the thigh is also called as fascia lata. Okay. It is also called as fascia lata. Fascia lata. Next important thing. Next important thing is that, so this is a question, nerve of anterior, medial, posterior. Why it is important is, in 2018 FMGE, they have asked you that medial compartment of thigh is supplied by which nerve? So the answer would be obturator nerve. Obturator nerve. Clear? Now, if you look at the actions of anterior, medial, and posterior compartment, always remember anterior is opposite of posterior. So anterior compartment is responsible for extension of knee, and flexion of hip, extension of knee and flexion of hip. Exactly the opposite will be posterior compartment. So it is extension of hip and flexion of knee. Extension of hip and flexion of knee. And when it comes to medial compartment is responsible for adduction. So all the adductors are coming under this medial compartment, right? So we are dividing the lower lobe into three parts. That is a thigh, leg, as well as a foot. Within the thigh, you have got anterior compartment, medial compartment, and posterior compartment. Okay. Now, what are the muscles of anterior compartment? All of you pay attention. What are the muscles of anterior compartment? All of you know that we have got a muscle called as sartorius. Sartorius is a muscle. And after that, we have got a straight muscle that is called as rectus femoris. Rectus femoris. And next we have got three large muscles that is called as vastus muscles. Three large. One vastus muscle is located laterally, so you call it as vastus lateralis. And one vastus muscle is located medially, so you call it as vastus medialis. And one vastus muscle is located in the center, you called as vastus intermedius. Vastus intermedius. You know this thing, right? Now, the important question which they're gonna ask you is that, what is quadriceps femoris? So, how many muscles form quadriceps femoris? The rectus femoris and the vastus muscles, all of them are like four heads. That is why you call it as quadriceps femoris. That is why you called as quadriceps femoris. 1, 2, 3, 4. Four heads. So you call it as quadriceps femoris. Clear? Next important thing regarding the sartorius, no one is going to ask you the shape, but just remember that sartorius is S shaped. And second important thing is that what are the other names that are given for this sartorius muscle? Can anyone tell? Sartorius is also called as Taylor's muscle. Sartorius is also called as, Dr. Benedict is so, yeah, very good, Dr. Benedict. Sartorius is also called as honeymoon muscle. Okay. Now, why sartorius is called as Taylor's muscle? Because while tailoring, this is the muscle which mostly comes into the action. Okay. Now, why sartorius is called as honeymoon muscle? Because the reason is that sartorius is responsible for the, if these are my thighs, it is responsible for the flexion, okay, abduction, as well as the lateral rotation of the thighs. And you know the rest of the story, right? So that is the reason why it is called as the honeymoon muscle. So it is responsible for the flexion, it is responsible for the abduction and the lateral rotation. Right? Now, in 2018, they have already asked you another question also, which is the longest muscle of the body? The longest muscle of the body is your sartorius. Okay, so this was a question which was asked. Now, anyways, origins and insertions, again I'm telling you, not important. So what you need to know is that I told you quadriceps muscles, 4 quadriceps muscles, right? One is on the lateral side, one is on the medial side, in the center there is one, and we have got rectus femoris. So all these 4 muscles together are called quadriceps muscles, right? So let us say these muscles which I have drawn here are quadriceps muscles. Quadriceps muscles. Okay. Now all these quadriceps muscles, they join together and form a tendon here. This tendon is called as quadriceps tendon. Quadriceps tendon. Okay. The moment quadriceps tendon passes over the patella, now you should call this as patellar ligament. Patellar ligament. And where is this patellar ligament attached? It is attached to your tibial tuberosity. Now, why am I telling you this? Why am I telling, yes, Bruno, it will be uploaded. Why am I telling you this is that whenever you are kneeling down, whenever the floor is in contact with the tibial tuberosity, there is a chance that this tibial tuberosity might be inflamed. Okay, so inflammation of tibial tuberosity, what will happen? The inflammation will be ascending upward to patellar ligament. From there, it will ascend upward to quadriceps tendon. From there, it will ascend upward all the way to your quadriceps muscles. So this inflammation of tibial tuberosity is called as Osgood-Schlatter syndrome. Osgood-Schlatter syndrome. This is very important. Osgood-Schlatter syndrome. Right? Now, next important thing is that what are the muscles of the medial compartment? Very good, Dr. Benedict. Housemaid's knee is a different thing, Roy. I'll tell you what is a housemaid's knee. Monimala Naskar notes. I will send you this in the Telegram group. What are the muscles of the medial compartment? Now, what are the muscles of the medial compartment are? Remember by a mnemonic GAP. GAP. If you remember this, all the muscles of medial compartment are done. What does G stands for? G stands for gracilis. Okay. What does A stands for? A stands for adductor muscles. What are adductor? There is adductor longus. Whenever there is longus, there will be brevis. Adductor brevis. And there is very vast muscle that is called adductor magnus. Okay. And what does P stands for? that is pectineus. Pectineus. So very good, Simran. Simran, you're right. So these are the muscles: gracilis, adductor longus, adductor brevis, adductor magnus, and pectineus. And by the way, guys, from these I already told you that there is one muscle which is called hybrid muscle. What is that? Yeah. In the discussion there, I told you there is one muscle called hybrid muscle. Very good, very good. Prince Davis, perfect. Perfect. Very good. Adductor magnus, very good. Now, let us discuss about the femoral triangle, guys. And I am telling you from the lower limb, one question is regarding the quadriceps tendon, they will ask. One question is regarding the femoral triangle. They can definitely ask you about the femoral triangle as well. Now, what are the contents of femoral triangle? Now, look here very carefully. The lateral border of femoral triangle is formed by sartorius. Sartorius is laterally. Medial border of femoral triangle is formed by adductor longus. And the base of the femoral triangle is formed by inguinal ligament. So, inguinal ligament forms the base, sartorius forms the lateral border, adductor longus forms the medial border. Now the question is regarding the contents we'll discuss. Another question is the floor of this femoral triangle is formed by. What is the floor formed by? See, this muscle here we discussed already. This is your sartorius, and we have also discussed this muscle. And what is this muscle, guys? This one. This muscle is adductor longus. And after that, there are three more muscles inside. You see, this is one. Okay, this is one. This is the second muscle, and this is the third muscle. Now, what is that muscle here? This muscle is called as iliacus. Okay, so the first muscle is called as iliacus, which forms the floor. The second muscle is called as psoas major. Psoas major, even very good. All of you are answering right. That is also forming the floor. And the third muscle is your pectineus. Pectineus, that also forms the floor. So the floor of this inguinal femoral triangle is formed by iliacus, psoas major as well as pectineus. Borders, you know, floors, you know. Let us directly enter into the contents. Contents, what can be the contents, guys? Yes, anyone, any idea? What can be the contents? Obviously, all of you know that the contents are femoral nerve, femoral artery, femoral vein, right? So these are the contents which you know. But let me discuss little more depth here. Let me discuss little more depth. So this was your femoral nerve, isn't it? Next, you have got your femoral artery. This is your femoral artery. Okay. And again, you have got your femoral vein like this. But the important thing you need to know is that femoral artery and femoral vein, both of these are enclosed in a sheath. Femoral artery and femoral vein are enclosed in a sheath. This is called as femoral sheath. Where is this? This is the femoral sheath. Okay. This is the femoral sheath. Now, within this femoral sheath, there are three compartments. What are those three compartments? See, this one is called as the medial compartment. This one is called as the lateral compartment. And this is called as the middle compartment or the intermediate compartment. Okay. Now, look here very carefully. Femoral nerve lies outside the femoral sheath. Femoral nerve lies outside the femoral sheath. Femoral artery is lying in the lateral compartment. Keep this thing in mind. Femoral artery lies in the lateral compartment. Very, very, very important. And where is femoral vein lying? Femoral vein, it lies in the intermediate compartment. Okay. So, femoral vein lies in the intermediate compartment. Then what is in the medial compartment? In the medial compartment, you have got some lymph nodes. Okay. What are these lymph nodes in the medial compartment? Anyone? Very good. These are called as lymph nodes of Rosen-Muller. Rosen-Muller or lymph nodes of Cloquet. Lymph nodes of Cloquet or lymph nodes of Rosen-Muller. So I am expecting this question that it would come, guys, because they have asked about everything, but they haven't asked about this. I think this can come for you in the exam. Keep it in mind. Okay. Right. Next important thing is that you have got a nerve here. This nerve is called as genitofemoral nerve. Genitofemoral nerve, which divides into two branches. One is called as a genital branch. Another one is called as a femoral branch. Femoral branch. Okay. Now this femoral branch enters into the lateral compartment and passes along with the femoral artery. So in the lateral compartment, we have got two things: femoral artery and femoral branch of genitofemoral nerve. Clear? Now I'm not writing in detailed what is there in lateral, what is there in medial, because by looking at the picture itself, you should understand what is there here. Clear? Now, so yeah, it is already there. Contents of lateral compartment: femoral branch, femoral artery; intermediate compartment, femoral vein; medial compartment, lymph nodes of Rosen-Muller or lymph nodes of Cloquet. Everyone clear with this? Shall I go for the next? The next topic which you can see here is called as adductor canal or Hunter's canal or subsartorial canal. Now, wherever this sartorius and adductor longus is meeting, at that point we have got a small opening there. Okay, through this opening the femoral artery will enter, and through this opening the femoral artery will exit out on the back. So this opening which you see on the back, this is called as adductor hiatus. Adductor hiatus. So if you look from the lateral side here, femoral artery is coming like this. It is entering inside and it is coming out of the adductor hiatus. All of you know this, right? Very good. Simran Kaur, excellent Simran, your first year and you are answering it. Very good. It is called Hunter's canal, yes. Okay. Adductor hiatus. And this entire canal is called as adductor canal. See, this canal here is called as adductor canal. Okay. And this is called as adductor hiatus. Adductor hiatus. Okay. Now, so that same thing in a transverse section, when I make a transverse section here, and if I'm looking from the top, this is how the picture looks. So this is the femur bone in the center. Right? In the front, what muscle you have? Sartorius. So this is your sartorius. And medially, what muscles you have got? Adductor muscles. So one muscle was adductor longus. And this muscle which is attached to this is called as vastus medialis. So what are the borders? Adductor longus, sartorius and vastus medialis. Okay. So if I draw a line like this, this is the anterior, this will be the posterior, this is the medial, and this is the lateral. Clear? Now, in this adductor canal, the questions which they will ask you: what makes the floor, what makes the roof, okay, and what are the borders? And at the end, they will ask you the contents. So the roof of this canal is by sartorius muscle, right? Sartorius muscle makes the roof of this. Next important thing is that the floor is bounded by adductor longus muscle. Okay. And next, anterolaterally, all of you, Barad, hi Barad. Anterolaterally, nothing to confuse. This is anterior, this is lateral. So anterolaterally, what is this muscle which we have? Vastus medialis. Okay. So these are very, very, very important. Very, very, very important. Clear? Now, in the canal, what are the contents? What are the contents? Look here. This vein which I'm drawing, this is called as femoral vein. Femoral vein. Okay. Next important thing is that this artery which I am drawing here, this is called as femoral artery. And next, this nerve which I'm drawing here, this is called as saphenous nerve. Saphenous nerve. So what do we have? Femoral artery, femoral vein, femoral artery, as well as saphenous nerve. Along with that, there is one more content, guys. Just below the sartorius muscle, you have got a plexus like this. This plexus is called a subsartorial plexus. What is this plexus? Subsartorial plexus. Subsartorial plexus. So these are the contents. What are the contents? I'm numbering it. Femoral vein, femoral artery, saphenous nerve, subsartorial plexus. Okay. And also one more thing. There is a nerve that is supplying to vastus medialis, that is nerve to vastus medialis. So the fourth one will be nerve to vastus medialis. Okay, so these are the contents of the adductor canal. So I hope you understood about this. Sure, short question, definitely. Okay, right. Now let us enter into the posterior compartment. In the posterior compartment, you have got two things. Below you have got thigh, above you have got buttocks, that is the gluteal region. Okay, so gluteal region and the back of the thigh. So in the gluteal region, what are the muscles? Three gluteus muscles are there. One is called as gluteus maximus. Another one is called as gluteus medius. And the third one is called as gluteus minimus. Gluteus minimus. And what are the rest of the muscles? How to see gluteus muscles? It is very easy to remember: maximus, medius, and minimus. But the rest of the muscles are difficult to remember. How do you remember? Is that is a very top question. What is a top question? T stands for tensor fascia lata. O stands for, what does O stands for? Obturator internus. Very good, guys. Obturatus internus. P stands for piriformis. And finally, Q stands for quadratus femoris. Q stands for quadratus femoris. Okay. And there is one muscle. There are two muscles actually. These are called twin muscles. Okay. Superior gemmelli, inferior gemmelli. They are called twin muscles. So gemellus. Gemellus muscles are there. Superior gemelli and inferior gemelli. So this was asked as a question previously, that what are the twin muscles? These are called as twin muscles, superior gemelli as well as inferior gemelli. Clear, everyone? Right. Now, another important question that can be asked is, what muscles rotate the hip laterally? What muscles rotate the hip medially? Lateral rotators as well as the medial rotators of the hip. Can anyone tell any one lateral rotator? Very, very easy. I have already written the mnemonic here. Lops. Lops is lateral rotators. Whenever I tell lateral rotators of hip, one thing should strike in your mind: lops. What does lops stand for? L stands for lateral rotators. O stands for obturator internus. P stands for piriformis. And S stands for superior and inferior gemelli. Superior and inferior gemelli. Okay. Next, what are the medial rotators? Medial rotators are, look here keenly. MED. Okay. MED. Which muscle is with the letters MED, guys? Medius. Hello, Manoj. Good evening. Medius, right? What medius? gluteus medius, gluteus medius, and finally gluteus minimus. MED is gluteus medius, I is gluteus minimus. Okay, so these are your medial rotators. Clear so far? Right. Now, there was a question which was asked that what are triomuscles? Triomuscles are, these are the triomuscles which we have discussed just before. Gluteus medius, minimus, these are called as triomuscles, but three they are: gluteus medius, gluteus minimus, and what is the other one is tensor fascia lata, tensor fascia lata. Okay, so all these are your triomuscles. Right, I am fine, thank you Manoj, thank you so much. You understood so far? So this guys, this is very important, and even the lateral rotators as well as the medial rotators are also important, guys. So please keep that thing in mind. Okay. Now, now all of you look here. I'm going to discuss something very important. So I'm going to discuss the root values, guys. L2, L3, L4, guys. L2, L2, L3, and L4. From L2 and L3, L4, we have got two nerves. One which supplies the anterior compartment, all of you know, femoral nerve. That is the reason why in the starting itself, I have discussed femoral nerve root values L2, L3, L4. So next nerve that is going medial is obturator nerve. So even obturator nerve root value will also be L2, L3, L4. On the back, L4, L5, L4, L5, S1, S2, S3. So all these nerves together, they form a single bunch of nerve, that is your sciatic nerve. That is your sciatic nerve. Okay. Now sciatic nerve divides into two components. This is called as common peroneal nerve. One very important MCQ is going to come here. I'll tell you what is that. And next one is called as a tibial nerve. Tibial nerve. Okay. Now tibial nerve will continue downward as posterior tibial nerve. Posterior tibial nerve. Clear? And this common peroneal nerve, it is common for what? It is common to divide into two branches. So one branch is called as superficial common peroneal, another one is called as deep common peroneal. Now, all of you look here. The question that is asked is, these are the questions which were previously asked. What is the question? Root value of femoral and obturator nerve. You know the root value, we just discussed L2, L3, L4. L2, L3, L4. L4. Okay. Next important thing, most common nerve damaged in the lower limb. Anyone? What is the most common nerve that is damaged in the lower limb? The most common nerve that is damaged in the lower limb is common peroneal nerve. Common peroneal nerve. Right? Now, common peroneal nerve will divide into superficial, deep. Now, out of these two, which nerve is responsible for food drop? The nerve that is responsible for food drop is deep peroneal nerve. So in the exam, if they ask you, you will answer deep peroneal nerve is a branch of common peroneal nerve. Deep peroneal nerve is responsible for foot drop. Now, which muscle paralysis will cause foot drop? Which nerve palsy is deep peroneal? But which muscle palsy will cause foot drop? Yeah? Foot drop is caused by which muscle palsy? Any answer, guys? Very good. Very good. Dharamvir Prasad, perfect you are. So, anterior tibial muscle. Anterior tibial muscle. So, guys, this box is highly important. Very, very important box. Okay? Very, very important box. Another question that is asked is, Out of lateral meniscal injuries, medial meniscal, you know, lateral meniscus, medial meniscus. Why medial meniscal injuries are more common than lateral meniscus? The reason is in the lateral meniscus region, we have got popliteus muscle, but on the medial meniscal, we don't have any muscle. So that is the reason why medial meniscus is more prone to injuries. So this is your popliteus. Okay, fine. Now, another important question that is been asked again and again is greater sciatic notch. So this notch which you can see here in the pelvic bone over here, this is called as a greater sciatic notch, right? So what are the structures that are passing through this greater sciatic notch like this? So remember by the mnemonic pin, right? What are the pinpoint structures that are passing through this greater sciatic notch? Now P stands for pudendal nerve, pudendal nerve, and I stands for internal pudendal vessels. Internal pudendal vessels means internal pudendal artery, internal pudendal vein. Okay, these are internal pudendal veins. Next, N. What does N stands for? Nerve to obturator, obturator internus, internus. Okay, so this is the nerve that is passing all the way like this and comes out through obturator foramen. That is why it is called as nerve to obturator internus. Right? Now look here, look here, look here now. Back of the thigh. How do you remember the muscles of back of the thigh? Okay, so back of the thigh muscles, they are also called as hamstring muscles. Hamstring muscles. Now how do you remember? Remember it as my tab. What does M stands for? Yes, anyone? What does M stands for? Membranosus. Half membrane, that is semi membrane. Semi membranosus. Very good, Deepali. Very good. Next, A. What does A stands for? Anyone? A stands for, yeah. Very good. A stands for adductor magnus, but not the complete adductor, not the complete adductor magnus, guys. Not the complete adductor magnus. Only the posterior part of adductor magnus. And I already told you in the starting, again and again I'm repeating, adductor magnus is called as a hybrid muscle because of obturator nerve plus sciatic nerve innervation. It is called hybrid muscle. Dual nerve supply is there. Next, T is finished, A is finished, B. What does B stands for? B stands for biceps femoris, that is long head of biceps femoris, long head of biceps femoris. And when I tell semi-membranosus, there will also be semi-tendinosus. Semi-tendinosus. Very good, Atharva. Atharva, perfect. He has mentioned all the muscles here. Very good. Semi-membranosus, semi-tendinosus, adductor magnus posterior part, long head of biceps femoris. So all these muscles are the muscles of your back of your thigh. Okay. Now, one question, guys, from here, sure short question, definitely they will ask you regarding the hip actions. What is the key muscle for extension? What is the key muscle? I mean, main muscle for extension, main muscle for flexion, main muscle for lateral rotation and medial rotation. Okay. So lateral medial, I won't discuss it because I just now discussed. Lateral rotators are lops. Medial rotators is medius, minimus. Gluteus medius and gluteus minimus. Now, what is the main muscle for knee, hip extension? Gluteus maximus is the main muscle. So, gluteus maximus is the main chief extensor of the hip. When it comes to flexion, the chief flexor of the hip is iliopsoas. Iliopsoas muscle is the main or the chief muscle. Okay, so definitely you gonna get a question. Remember this. Clear, everyone? Very good. Very good, Jaggi. Very good, Deepali. Very good, right. Now, if you look at the leg region, guys, in the leg region, they will ask you one question, that which compartment of the leg is not having any kind of neurovascular bundle. So that was the question which was asked previously. So all of you should know that in the leg we have got three compartments: anterior compartment, posterior compartment, and we have got the lateral compartment. We don't have medial compartment, right? So in the anterior compartment, what is the nerve of anterior compartment? Okay, first tell me, what is the artery of anterior compartment? The artery of anterior compartment is anterior tibial artery, not femoral, Bentek. This is leg. We are discussing about leg. Okay, that will be anterior tibial artery. Next, when it comes to the vein, there will be anterior tibial vein. Okay, when it comes to the nerve, there will be deep peroneal nerve. Three things are very important: anterior tibial artery, because anterior to tibia, so anterior tibial vein, and deep peroneal nerve. So these are the three of the anterior compartment. Okay, now coming to the posterior compartment. In the posterior compartment, we have two. Posterior compartment, we have two: superficial and deep. Now look here. Here I have got a nerve in the deep posterior compartment. I have got a nerve that is called as tibial nerve. Artery which I have got is posterior tibial artery, and obviously nerve follows the same posterior tibial vein. I mean, the vein follows the same posterior tibial vein. Okay, then you might get a doubt, if superficial posterior compartment is not having any kind of nerve supply or arterial supply or venous drainage, then how these muscles gonna live? How they live is that posterior tibial artery gives a branch to the superficial compartment. The veins also, the nerve also innervates the superficial posterior compartment. That is how it is living. Okay. Next important thing is that we have got something called PA. PA means peroneal artery. Peroneal artery, and we have got something called PV, which means peroneal vein. So peroneal artery supplies your lateral compartment, peroneal vein also towards your lateral compartment. Then where is peroneal nerve? Peroneal nerve is already located in the lateral compartment, superficial peroneal nerve. Okay, so what did you understand by this? Anterior compartment has got all the neurovascular structures. In the posterior, the deep compartment has got all the neurovascular structures. Lateral compartment has got only nerve by itself, but artery and vein is coming from the deep side. Posterior superficial compartment is the only compartment which will lack neurovascular bundle by itself. Okay, so posterior, this is very, very important MCQ, guys. Which compartment lacks the neurovascular bundle? Posterior superficial compartment lacks the neurovascular bundle. It is getting a supply from the deep compartment. Understood, everyone? Yeah, right. Very good, Malar. You're right. So in the leg also, I told you, right? Anterior, lateral, and posterior. What is the function of anterior compartment? Dorsiflexion. What is the function of lateral compartment? Levation. So this is a foot, I am levating it, right? Levators. What is the function of posterior compartment? Plantar flexion. So this is dorsiflexion, this is plantar flexion. Okay, clear? Right. Coming to the arterial supply of lower limb, it is very, very simple, guys. Very, very simple. So this will be your external iliac artery. External iliac artery is continuing as femoral artery. I have already explained you, femoral artery will enter into the adductor canal, right? And it will come out of adductor hiatus. Clear? And finally, femoral artery will come down all the way. It will come down all the way, right? And once the femoral artery enters into the popliteal region, this is called as popliteal artery. Popliteal artery. Clear? All of you look, popliteal artery. popliteal artery will divide into two more branches, two branches. What are these two branches? See, this one is called as anterior tibial artery. That is why it is on the anterior side. Okay. This one is called as tibioperoneal trunk. This is called as tibioperoneal trunk. And tibioperoneal trunk has got two branches. One is called as the posterior tibial artery, and the other one is called as a fibular artery. Fibular artery. So this is the arterial supply, guys. Very, very simple. The complex thing will be in the posterior popliteal artery only. Very simple. Popliteal artery dividing into two. जो anterior की तरफ जाएगा वो anterior tibial artery, जो पीछे ही रह जाएगा उसका नाम tibioperoneal trunk. That will in turn divide into two, posterior tibial and fibular artery. That's it. Clear? Very good. Next important question. Next important question is that there is, like carpal tunnel syndrome, there is also tarsal tunnel syndrome. Can anyone tell me which nerve is responsible for tarsal tunnel syndrome? Yeah. Very good, Dr. Bentek. It is posterior tibial nerve. Posterior tibial nerve. Very, very important. Very important. Okay. Posterior tibial nerve. Very, 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 very important. Okay. Posterior tibial nerve will lead to tarsal tunnel syndrome. And this type of deformity which you can see here, this is called as claw foot deformity. Claw foot deformity. This is a question. And such type of toes like this, the toes are like this, right? Such type of toes, you also call it as hammered toes. You call it as hammered toes. This is another important MCQ. Hammered toes. Okay. Very good, Deepali. Yes, same as claw hand. Yeah. Right. Now coming to the muscles of the anterior compartment of leg. These are very, very easy, dead easy, right? Whatever is anterior to tibia, this is called as anterior tibial muscle or tibialis anterior muscle. Okay. This is called as tibialis anterior. Clear? Next, the next muscle goes all the way down like this, and it is inserted to your toe finger, right? So this muscle is called as extensor. As it is inserted to toe, you call it as hallucis, and it is long tendon longus. Extensor hallucis longus. Okay. Very good. Very good. Next, there is another muscle, the green color one, which is coming down all the way and supplying to all the digits here. This is called as extensor digitorum longus. Okay. And finally, there is the last muscle, which you also called as a third muscle. So tertius muscle. This is called as peroneus tertius. Peroneus tertius. Clear? Right. Now, in the posterior compartment of the leg, there are superficial deep. I told you, superficial compartment is lacking all the neurovascular structures, right? So that is the thing here. Superficial and deep we have. So what are the superficial muscles, guys? Anyone? Remember gossip. Yeah, calf muscles, Dipali. One is called as gastrocnemius. Gastrocnemius has got lateral head, medial head. Yeah. Another one is called as soleus. And next one is called as plantaris. Now, out of this, what is important? Plantaris. Because I have told you in the discussion of upper limb that what is the homologous muscle of plantaris in the upper limb? Very good, Dr. Bendik. Plantaris graft. Yeah. But what is the homologous muscle there? Palmaris longus, I told you. Both of them are useful for grafting surgery, tendon grafting surgery. You remember them, right? So what are the deep muscles? Deep muscles are exactly opposite of your anterior compartment muscles. Here it is tibialis anterior, right? Here it will be tibialis posterior. Tibialis posterior, right? Next, here it will be extensor hallucis longus, right? Extensor hallucis longus. Here it will be flexor hallucis longus. Exactly opposite, guys. Next, you have got extensor digitorum longus, guys. Here it will be flexor digitorum longus. Flexor digitorum longus. Okay, right. Next important thing, peripheral heart. Peripheral heart. Tell me, which muscle is called as peripheral heart? Be fast, guys. Which muscle is called as peripheral heart? Very good. Jiggy Chaudhary, perfect. Which muscle is called as peripheral heart? That is soleus. Very good. Soleus is called as peripheral heart. In tendon grafting surgery, what is the muscle we use? Palmaris longus. Not only that, we also use plantaris. Plantaris. Very, very important. Very, very important question. Next important thing. Homologous muscle of plantaris, palmaris longus discussed. Which muscle is called triceps suri? Right? Which muscle is called triceps suri? Anyone? There are two muscles, guys. Gastrocnemius as well as soleus. Triceps means three should be there. Yes, gastrocnemius is got lateral head. It is also got medial head. Right? It has got lateral head, medial head. So 1, 2, 3. So three muscles together are called as triceps suri. Clear, everyone? Very good. So what is the root value? What is the root value of ankle reflex? What is the root value of ankle reflex? The root value is S1. The root value is S1. Okay. Next important thing is that this tendon here is called as Achilles tendon. Right. So if you want to check for Achilles reflex or ankle reflex, you hit on the Achilles tendon. Okay. So what muscles, can anyone tell what muscles form the Achilles tendon? There are two muscles. Prince Davis, perfect. Prince Davis is telling gastrocnemius as well as soleus, they form Achilles tendon. Very good. I mean triceps surae form the Achilles tendon. Very good. Right. Now the most important point here, guys, look here. What is the most important point is that, guys, so this is the view from the lateral side. If you are looking at my leg from the lateral side, this is the femur, this is the tibia, and this will be the patella. Okay. In front of the patella, I have got an open space, a bursa. I call it as a bursa. This bursa is called as pre-patellar bursa. What do you call it as? Pre-patellar bursa. This is called as pre-patellar bursa. Now, above this, above the patella, also have got bursa. Look here. Above the patella also have got bursa. This is called as suprapatellar bursa. Suprapatellar bursa. And below, I have got infrapatellar bursa. Infrapatellar bursa. Okay. Now, when I'm kneeling down, for example, let us say, we have housemaids, right? So housemaids, they kneel down and mop the floor. So what is happening is that the patella, the prepatellar bursa, I think the contact has gone, guys. Don't worry. I'll join again. Yeah, air server. So what I'm telling is that, guys, when we are kneeling down, and when you are mopping the floor, the floor is in contact with the prepatellar bursa, right? So prepatellar bursa will be inflamed. That condition you call it as prepatellar bursitis. If there is inflammation of infrapatellar bursa, that you call it as infrapatellar bursitis. Before I can show you the screen, guys, you need to wait for a minute. Okay. Yeah, I hope you can look at the screen now in a second. So inflammation of prepatellar bursa is called prepatellar bursitis, or the other name is housemaid's knee. Housemaid's knee. Okay. And infrapatellar bursitis is also called as clergyman's knee. Clergyman's knee. Clergyman's knee. Claro? Right. Next important thing. Just behind your knee, you have got this fossa, and this fossa behind your knee is called as popliteal fossa. Okay. Now they will ask you, what are the muscles of popliteal fossa? What are the borders of popliteal fossa? Okay. So in the popliteal fossa, supralaterally, okay, superior and lateral side. Supralaterally, this muscle, whatever I have here, this muscle is called as biceps femoris. Supramedially, I have got this muscle called as semimembranosus. Okay. Next, infrolaterally and inframedially, I have got only one muscle, that is gastrocnemius. One is called as a lateral head and medial head. So this is called as a lateral head of gastrocnemius. This is called as the medial head of gastrocnemius. So lateral head of gastrocnemius, medial head of gastrocnemius, biceps femoris, semimembranosus, all of these form a border that is called as border for what? A fossa that is called as popliteal fossa. Popliteal fossa. What are the contents of this popliteal fossa? Look here. You have got an artery here. I'm talking from medial to lateral side. Medial to lateral side. We have got an artery called as popliteal artery, right? Next, we have got a vein called as popliteal vein. Okay. Next, we have got a nerve. Who will tell me what is the nerve? We have got this nerve like this. This is called as common peroneal nerve. Common peroneal nerve will give a branch like this. This is called as tibial nerve. Very good. This is called as tibial nerve. So let me write down the contents. We have got pop artery. We have got pop vein. We have got, let us say, tibial nerve. We have got common peroneal nerve. So if you get any question on popliteal fossa, will you able to answer it, guys? Will you able to answer it if you get a question on popliteal fossa, yes or no? Yeah? Very good. Very good. Now we have to discuss about the another important topic, that is cruciate ligaments. Cruciate ligaments. There are two cruciate ligaments, you know. There are two cruciate ligaments, you know. One is called as anterior cruciate ligament. Another one is called as posterior cruciate ligament, right? Now, how to remember these cruciate ligaments? From where are they coming? From where are they going? What is the insertion and what is the movement of this? Look here. Remember by a mnemonic called as LAMP. LAMP. What does LAMP stand for? Look here. This is called as lateral condyle, right? So now from lateral epicondyle to the anterior side, from lateral to the anterior side, whatever is coming, this is called as anterior cruciate ligament. Next, from the medial side to the posterior, from the medial, if anything goes onto the back here, I'm drawing it with dotted lines, goes to the back, this is called as posterior cruciate ligament. Okay, simple thing, LAMP. From lateral condyle, if it is coming anterior, anterior cruciate ligament. From medial condyle, it is going posterior. It is called posterior cruciate ligament. So this is the important thing which you need to remember. Okay. Here, all of you. Right. So they will ask you, what is the function of ACL? What is the function of PCL? And this is a very important question, guys. Origin insertion of this cruciate ligament is very, very important. Very, very important. Okay. So anterior cruciate, posterior cruciate. Anterior cruciate prevents anterior displacement. Posterior cruciate prevents posterior displacement. Okay. Anterior cruciate prevents anterior displacement of tibia. Posterior prevents posterior displacement of tibia. Clear? And next thing, anterior prevents anterior displacement of tibia and posterior displacement of femur. Here, PCL prevents posterior displacement of tibia and anterior displacement of femur. Vice versa. Everything is vice versa. But the main statement you should know is A for anterior, anterior displacement of tibia. P for posterior, posterior displacement of tibia. And everything will come into action here. Clear, guys? Yeah. And one last question which they can ask you here is that, guys. So let me show it in this picture only. Okay. You know, we have got menisci all over like this. We have got menisci. Okay. And we even have got disc. This is the what are these discs? One is the medial menisci, another one is the lateral menisci. Okay. And we have got this sheath, this dark green color sheath which I have drawn. This is called as the synovial sheath. Sometimes what will happen is that this synovial membrane, whatever is there, this will pop out. This will pop out like this. Because of excess amount of pressure, all the synovial fluid is pushed into this. So this is called as popliteal cyst, or you can call it as Baker's cyst. Baker's cyst. And you need not to do anything, and moreover the questions are also not asked from this, but I have to discuss it, so I discussed it. So questions are basically not asked on this. The important thing is that Baker's cyst, it will resolve by itself. Okay, it will basically resolve by itself. Thank you, Renexus. Thank you so much. So guys, now we shall start the discussion of the abdomen region. Okay, we shall start our discussion with the abdomen region. Now, in the abdomen region, the first question they'll ask you is porta hepatis. Structures related with porta hepatis. What are the structures? We have got hepatic artery, we have got bile duct, we have got portal vein. Hepatic artery, bile duct and portal vein, remember it as DAV, duct artery vein, right? Duct artery vein. Okay, so duct, artery and vein, three of them together are called as porta hepatis. Okay, so this is one question which they can ask you. Next important question is that look here, that Cantler's line. So what is Cantler's line? What is Cantler's line is that this is a imaginary line that is drawn all the way. This is your inferior vena cava and this is your gallbladder. There is a line that is drawn all the way from inferior vena cava to gallbladder, and this line is called as Cantler's line. So this is called as a surgical division of liver. In this way you can divide the liver into right surgical liver, left surgical liver. But anatomically, how do you divide the liver? Anatomically, you divide with the help of falciform ligament. Falciform ligament, you divide the liver into right and left. Okay, so this is a question Second important thing. Second important thing is that, as you can see here, as you can see in this picture, this is your inferior vena cava, and this is your portal vein. Portal vein, it has got two divisions: the right portal vein, and the left portal vein. Okay. Now, when you look at these three veins, this is called as the right hepatic vein, this is called as the left hepatic vein, and this is called as the middle hepatic vein. So, portal vein and hepatic vein are dividing the liver into 8 segments. They are dividing the liver into 8 different segments, like 1, 2, 3, 4, 5, 6, 7, 8. Okay, clockwise, yeah. Now, what will be the questions that are asked? Segments of right surgical liver are. Right surgical liver, what are the segments, guys? This was asked previously. 5, 6, 7, 8. These are the segments. Segments of the left surgical liver, 1, 2, 3, 4. These are the segments of the left surgical liver. Clear, everyone? And remember one thing, that 5, 6, 7, 8 segments, they drain all the bile. Look here, 5, 6, 7, 8 segments, they drain into separate veins, right? Like they drain into the hepatic veins. 1, 2, 3, 4, they drain into separate veins. But segment 1 will not drain into any vein here. You know what will happen? Segment 1. So this is the place for segment 1. This is the first segment. And here I have got inferior vena cava. Segment 1 will directly drain into inferior vena cava. Yes, it will directly drain into inferior vena cava. So that is the reason why it is called independent lobe segment 1. Yes, you are right. Why am I telling you this? Why am I telling you this is that there is a condition called as Budd-Chiari syndrome. In Budd-Chiari syndrome, what will happen is that there will be thrombosis of hepatic veins. So when there is thrombosis of hepatic veins, all the segments cannot drain into that, but only one segment can drain. That is the first segment. Why? Because first segment is directly draining into inferior vena cava. So the question that was asked previously is that which segment is paired in Budd-Chiari syndrome? That is, segment 1 is paired in Budd-Chiari syndrome. Clear, all you? Yeah. Next important question. Caudate lobe is sandwiched between. Where is caudate lobe? Wherever segment 1 is there, that is caudate lobe. That is sandwiched between inferior vena cava on one side, and you have got a ligament here. This is called as ligamentum venosum. So what will be the answer? Between the ligamentum venosum and inferior vena cava, I have got this caudate lobe. Next, another time they have asked you this question is that quadrate lobe is sandwiched between. Quadrate lobe is where? This is the quadrate lobe. Quadrate lobe is sandwiched between gallbladder and ligamentum teres. This is called ligamentum teres. Okay, ligamentum teres. Gallbladder and ligamentum teres. Another question, which lobe is called as third liver? Anyone, which lobe is called third liver? Caudate lobe is called as third liver. You know why? Because it has got 2 arteries, it has got 2 veins, it has got 2 ducts, right? So it has got 2 arteries, 2 veins, 2 ducts. That is the reason why it is completely independent. It drains into its inferior vena cava. So it is completely different. So it is called third liver. And next important question, remnant of umbilical vein. Remnant of umbilical vein. What is the remnant of umbilical vein? Ligamentum teres. Ligamentum teres is the remnant of umbilical vein. So these are the questions which can be asked from the liver, guys. Okay. Yeah, and one more question also is there. One more question is also there, which is very good, Prince. Very good, Osama Sheikh. Very good. One more question is there, that look at this question. We see a triangle here. I know all of you will answer. Definitely, I know you will answer it. Right? So what this triangle is that, guys? See, Prince Davis is already answered. Very good, Osama. Perfect. Perfect. Now, what is this triangle here? All of you look. Right. Now, here, this part is called as this is called as common hepatic duct. Common hepatic duct. And what is this called? Cystic duct. Okay. And what is this artery called as? What is this artery called? Common hepatic artery. Okay. And what is this artery called as? Cystic artery. Cystic artery. Now look. Very good, Athar. Paracetamol, Baba. Very good. Now, what is the triangle here? This triangle is called as Callot's triangle. Callot's triangle. What are the borders of Callot's triangle? What are the borders of Callot's triangle? Are medially, I have got common hepatic duct. Medially, I have got common hepatic duct. It means here, this is common hepatic duct medially. Okay. Next, inferiorly, I have got cystic duct. Cystic duct, yes. Inferiorly, I have got cystic duct. Next, superiorly, I have got cystic artery. Superiorly in the sense this one. Superiorly, I have got cystic artery. Okay. So, I have got a triangle and this is called as Callot's triangle. Clear all of you? This is, yes, Sainath Reddy, this lecture will be uploaded. This is called as Callot's triangle. Now, next important question they will ask you is, after the borders, what are the contents of Callot's triangle? Can anyone tell what are the contents of Callot's triangle? First content is, yeah, what is the first content? Right hepatic artery. Second content is cystic artery. Third content is the lymphatics. And fourth content is the lymph node. Very good, all of you. Lymph node of Lund, not that Lund. Okay, this is anatomical Lund, right? Fine. Right, all of you understood this? Yeah, right. Now, another important thing is the constrictions of esophagus. Constrictions of esophagus. What are the constrictions of esophagus? This is very important, guys. I think you will get a question from this. Very important. Okay, so how many constrictions we have are, we have got 1 2 3 4 4 constrictions. Okay, we have got four constrictions. Now look here. Yeah, 4 constrictions. Now look here. This constriction is present at the level of C6. This constriction is present at the level of C6. This is called as pharyngoesophageal constriction. This is pharynx, this is esophagus. So, pharyngoesophageal constriction. Esophageal constriction. Second constriction is this one. This is the second constriction at the region of arc of aorta. Arc of aorta. Next, this is the third constriction where it is present in the left bronchus. Near the left bronchus, you have got a third constriction, right? And next, this is the fourth constriction where it pierces the diaphragm. Okay, so remember it as pulp. Remember it as PULP. PULP. Okay, what is PULP? P for pharyngoesophageal constriction. U is called arch of aorta. How is the shape of the arch? Arch is U shaped. Next, L is called as the left bronchus. P is called as piercing the diaphragm. So remember this. Definitely you can get a mark from this. Clear? Yeah. Next important thing. What are the branches of abdominal aorta? Who will tell me? How many parts we can divide this abdominal aorta, guys? Yes. We can divide this abdominal aorta into T12. Yeah. T12, L1, L2, L3 and L4. Now, at the level of T12, this is very, very important because all the topographics I'm telling here itself, look here. At the level of T12, I will have celiac trunk. Where is celiac trunk located? At the level of T12. Next, at the level of L1, what do I have? I have superior mesenteric artery at the level of L1. Next, at the level of L2, what do I have? Look here. I have an artery like this. I have an other artery. So what are these arteries? So one artery is called as renal artery, Vishal Meghani, perfect. Another artery is called as gonadal artery. Very good, med student. Jaggi Chaudhary, Vishal, Prince, perfect. Gonadal artery at the level of L2. Next, at the level of L3, I have got a branch like this, and this is called as inferior mesenteric artery. So definitely they will, from topography, they will ask you a question, guys. So if it is in the abdomen region, they can ask you this question, particular question over here. Clear? Right. Now let us discuss the branches of celiac trunk. Now what do you think? What are the branches of celiac trunk? Just now I have explained you. Celiac trunk starts at the level of T12. Okay. Celiac trunk will supply three of your organs. So what are these three of your organs? Are it supplies your stomach, right? It supplies your liver. It even supplies your spleen. Three of them. It supplies your spleen. So if this is your celiac trunk over here, this is your celiac trunk over here. Very good. It gives out a branch which supplies to the stomach. Look here. This is a branch which is supplying to the stomach. This is called as left gastric artery. What is this called? What is the first branch of celiac trunk? Left gastric artery. What is the second branch? Look at the second branch. This second branch goes all the way like this, and it supplies to the spleen. So can I call it as splenic artery? Splenic artery. What is the third branch? What is the third branch is that it gives out a branch here. This is called as common hepatic artery. Common hepatic artery. Okay. Common hepatic artery will later on divide into hepatic artery proper and gastroduodenal artery, because it is between the stomach and the duodenum. So this is called as gastroduodenal artery. Perfect. Okay. Gastroduodenal artery. Very good. Now, this splenic artery, whatever is there, it gives out two branches. One branch goes on to the top, one branch comes all the way till the bottom. So, which goes on to the top, this is called a short gastric artery. Which comes all the way down is called as left gastro-omental artery. Left gastro-omental artery or left gastroepiploic artery. Okay. So left gastro-omental artery or left gastro-epiploic artery. Now, this gastroduodenal artery, I'm going to tell you a clinical point here. This gastroduodenal artery will in turn divide into two branches, guys. So what are these two branches are? What are these two branches are? Look here, one branch will go and attach with left gastro-omental artery. So I call it as right gastro-omental artery. Okay. And other branch that comes down all the way like this. This is called as, anyone, any idea? Superior pancreato duodenal artery. Superior pancreato duodenal artery. Okay, superior pancreato duodenal artery. And at the level of L1, there is another artery. I told you, what is that? Superior mesenteric artery. Let us say this is superior mesenteric artery. Look here, this is superior mesenteric artery. From superior mesenteric artery also one branch goes up and anastomoses with superior pancreato-duodenal artery. This is called as inferior pancreato-duodenal artery. Inferior pancreato-duodenal artery. Okay, so very simple, guys, very simple. Celiac trunk has given three branches. One is called as splenic artery, another one is called as the left gastric artery, another one is called as a common hepatic artery. Okay, common hepatic artery in turn divided into two. One is called as the hepatic artery proper. Hepatic artery proper will further divide into right hepatic artery. It will also divide into left hepatic artery. And the other branch is gastroduodenal artery. Okay, gastroduodenal artery will divide into two. What is that other branch? It is not needed, but important branch is superior pancreato-duodenal artery. Okay. Now, why am I telling you this detailed is that one important thing is that if there is a thrombus of celiac trunk, if there is a thrombus in the celiac trunk, then kidney, then the stomach, the spleen and the liver are not supplied. So what will happen? What will happen is that the blood comes down all the way. It enters into superior mesenteric artery. From there, it will go into inferior pancreato-duodenal. From there, it will go into superior pancreato-duodenal, and then it will supply to all the organs. So this is a, I can also say that it is taking a diversion. Okay. So this is a collateral connection. Clear, all of you? Very good. Very good. So look here, guys. Look here. Superior mesenteric artery, inferior mesenteric artery, celiac trunk. Remember this. Celiac trunk, that is T12. Superior, that is L1. Inferior, that is L2. So all these three branches are here. Clear, all of you? So this is the blood supply of the celiac trunk. Okay. Now let us fastly discuss the blood supply of the superior and inferior mesenteric artery. Very easy. Very easy. Look here. Right. All of you look here. Here, what is there here? What is the artery here? Yes. This artery which is coming out in this way, this artery which is coming out in this way, this is called as superior mesenteric artery at the level of L1. And here I have got an artery. This is called as inferior mesenteric artery at the level of L3. At the level of L2, sorry, at the level of L2, right? Is it at the level of L2? No, it is at the level of L3. It is at the level of L3. Okay, at the level of L3, I have got inferior mesenteric artery. Now look here very carefully. Where is ascending colon? See, I'll make you to get perfect with these branches in the class itself. Where is ascending colon? On the right. Descending colon on the left. Transverse colon in the middle. So I can call this as right colon, left colon, middle colon. right? Now look here. A branch that supplies to right side of the colon like this all the way. This is called as right colic artery. The first branch of superior mesenteric is right colic artery. Second one is that, look here, this is your cecum. This is your cecum. Now there is a second branch that comes all the way down and supplies to your cecal region like this. This is called as ileocolic artery. This is called as ileocolic artery. A branch of ileocolic artery will surround your appendix like this. So this is called as appendicular artery. This is called as appendicular artery. All of you are perfect. Appendicular artery. And the last artery, the fourth artery, look here very carefully. A branch that goes up and supplies to the middle part of the colon like this. So which is supplying to the middle part of the colon, I should call it as middle colic artery. So there will be middle colic artery. So right colic, ileocolic, appendicular artery, middle colic artery. Clear? These are the branches of the superior mesenteric artery. I will tell you, yes, Atharva, I will tell you what is Drummond's anastomosis and all. Now coming to inferior mesenteric artery, what are the branches? Now one branch directly supplies to your sigmoid colon. So can I call it as sigmoid artery? Sigmoid artery. One branch supplies to your left side of the colon. If a branch is supplying to your left side of the colon, this is called as left colic artery. Left colic artery. Another branch supplies onto the top of the rectum. So can I call it as superior rectal artery? Yes. I can call this as superior rectal artery. Superior rectal artery. Very good. Superior rectal artery. So these are the blood supplies of the inferior mesenteric artery. What is the important points now? What are the important points now? Look here. We have got a connection. We have got a connection between superior mesenteric artery and the inferior mesenteric artery. Both of them are connected here, right? So this connection, whatever is happening here, this is called as arc of Rollan. What is this called? This is called as arc of Rollan. Not only that, the superior inferior, they both of them join together and give blood supply to most part of the colon. I mean, in this picture I cannot show you, but it gives blood supply to most part of the colon. The superior mesenteric, inferior mesenteric. This is called as, what is this called? This is called as marginal artery of Drummond. This is called as marginal artery of Drummond or Drummond's anastomosis. Marginal artery of Drummond. Right? Whenever there is ischemia, this marginal artery of Drummond acts as a bypass and supplies to your colon. This is very important, guys. Okay. Next important thing, wherever this sigmoid artery and the left colic artery are meeting. See, this is the point where sigmoid artery and the left colic artery are meeting, right? So this point is called as Sudek's point. This point is called as Sudek's point. Clear? Prince David is telling it is a watershed area. Yes, very good, Prince. It is a watershed area. Yes, it supplies to the, yeah, it is nearer to the splenic flexure. Very good. Clear, all of you? Yeah. So guys, from celiac trunk, from the abdominal aorta branches, from the superior and inferior mesenteric artery, definitely a question can be expected, guys. Definitely and definitely you will get a question. Arterial supply is very, very, very important. Okay. Right. Now look at the inguinal region. We shall very fastly discuss inguinal region. The first question which they ask you is, where is the location of deep inguinal ring? Deep inguinal ring is located just above the midpoint of inguinal ligament. So just above this, you have got this ring. This is called as your deep inguinal ring. Okay. Where can the femoral pulsations be palpated? Femoral pulsations are palpated exactly in the center of the femoral, exactly in the center of that inguinal ligament. Okay. Persistent processes vaginalis will lead to. Can anyone answer what will happen when persistent process vaginalis is there? Yeah. Can anyone answer what happens when there is persistent process? Very good. Med student. Perfect. Very good. Very good and very good. Very good. Persistent processes vaginalis that would lead to indirect hernia. Indirect hernia in the females. In females, it is more common than in the males. Okay. Females, it is more common than in the males. Okay. What is meant by persistent process vaginalis is, see, this is processes vaginalis. This is processes vaginalis. Okay. Process vaginalis will come down like this and it will surround the testis. This green color thing is your testis. It will surround the testis. Once it is surrounding the testis, you call this as tunica vaginalis. What do you call it as? Tunica vaginalis. Okay. If there is no tunica vaginalis, if persistent process vaginalis is sitting there only, it is not coming down, that is called as persistent process vaginalis, and that would lead to indirect hernia. Indirect hernia. So, sir, what are the important things in the inguinal region? Important things are this one. When will your testis descend? Right? From the abdominal region, when will the testis descend down to the scrotum is the most important question, which is always asked. Okay. So this blue color one is your testis. In the abdominal region, your testis is there in the abdominal region at the 2nd month or the 7th week. Okay. Next, this is descending down to the inguinal region. It has not entered still. It is descending down to the inguinal region at the 3rd month. At the 3rd month. What will happen is that 3rd month it will stay there, 4th, 5th, 6th. In the 7th month, it will enter into this canal. That is the inguinal canal. It will enter into the inguinal canal at the 7th month. Okay. Now, it will travel in the inguinal canal for 3 to 4 days. For 3 to 4 days, it will travel in the inguinal canal, and finally by 9th month, your testis is in your scrotal sac. So anywhere the question can be asked here. Anywhere the question can be asked here. If I write it down and tell you, it would be a little bit difficult for you to understand. So this diagrammatic representation will help you. Yes, Vishal Megan is telling just before birth at the scrotum. You're right, Vishal. Yeah. Now, all of you know what are the abdominal wall layers, guys? What are the abdominal wall layers? Outermost layer, you have got skin. Then you have got superficial fascia. Not fascia, superficial layer. And this superficial layer is divided into two. One is called as the camphor fascia outside. Camphor fascia outside. Scarpa's fascia inside. Scarpa's fascia inside. After that, you have got external oblique muscle. After that, you have got internal oblique muscle. After that, you have got transverse abdominis. After that, you have got transverse fascia, and finally parietal peritoneum. Parietal peritoneum. So guys, this can be a image based question for you. This can be an image based question. They will give you layers of the abdomen and point at one layer and ask you what is this. So if you just know this thing which I have written here, that would be more than enough. Okay, that would be more than enough. Now, look here. The abdomen is in continuation with the scrotum. You know that thing. Abdomen is in continuation with the scrotum. Now look here very carefully. Skin of the abdomen is in continuation with the skin of the testis, that is the scrotum. This is not skin, this is scrotum. Clear? Next, the superficial layer, that is the camper fascia and scarpa's fascia, they both of them are in continuous with the dartus muscle of the testis. They are continuous with the dartus muscle of the testis. Next, external oblique muscle is continuous with external spermatic fascia. External oblique is in continuous with external spermatic fascia. Internal oblique is in continuous with cremasteric fascia. Okay. Next, transverse abdominis is not continuous with anything, but transverse fascia is continuous with internal spermatic fascia. That's it. Very important. All of you understood? Right? So that is continuous with the fascia here. So if you will understand this, that is more than enough, guys. That is more than enough. So one thing what they're going to ask you in the inguinal region is that, so there can be a question from here. There can be a question from here. There can be a question from the abdominal wall layers also. There can be a question, right? There can be a question from the testis also. They will give you layers of testis and name one. Okay. Next, there can be a question regarding the borders. Regarding the borders. Now keep this thing in mind. Keep this thing in mind. I told you there are two things: external oblique muscle and transverse fascia. Keep these two things in mind. I will come back to it later on. So what is this picture which you can see here, guys? What is this picture? This is external oblique muscle. Okay. External oblique muscle, down of the external oblique muscle here, exactly here, antero-inferiorly here, antero-inferiorly, there is a defect, right? There is a defect there. Now that defect you call it as superficial inguinal ring. Superficial inguinal ring. This is the very important question. Very important question. External oblique muscle defect is superficial inguinal ring. Very important. But if you go down here inferiorly, you can see a double layered line here. This double layered line is nothing but called as inguinal ligament. Inguinal ligament. Inferiorly it is inguinal ligament. Antero-inferiorly it is superficial inguinal ring. Superficial inguinal ring. Clear? Next, if I remove external oblique, what will be the next layer, guys? Anyone? What will be the next layer if I remove external oblique? Not transverse abdominis, Osama. It is internal oblique. I have removed external oblique. Now there is internal oblique. Okay, internal oblique. Now in the internal oblique muscle has got fibers like this. What are these fibers like? Arch. Internal oblique muscle has got arch like fibers. These are called as arcuate fibers. These are called arcuate fibers. Okay. Arcuate fibers are forming borders for inguinal canal. Look here. Arcuate fiber is forming anterior border of inguinal canal. It is forming the superior border of inguinal canal. It is also forming the posterior border of inguinal canal. Anterior, superior, posterior border of inguinal canal are formed by internal oblique. If I remove internal oblique, what will be the next muscle here? Transverse abdominis. Transverse abdominis. If I remove the transverse abdominis, what will be the last one after transverse fascia? So you can see that in the center of the transverse fascia, you can see a small hole. Through this small hole, the spermatic cord has come out. Now, what is this small hole called as? This is called as your deep inguinal ring. Deep inguinal ring. and this is your transversal fascia. Okay, very, very, very important thing. Superficial inguinal ring is formed by external oblique muscle. Deep inguinal ring is formed by transversal fascia. These 2 points fix in your mind. Okay. Right. Very good. Next important thing. Next important thing here is that you can see this bone called as pubic bone. This is the pubic bone. And you know what is this? This is called as your rectum. This is called as your rectum. And rectum is in continuous with anus, right? So this is called as your anal canal. Anal canal. Okay, this is continuous with anal canal. And what is this red color one which is holding the rectum and the anal canal and it is pulling back? Anyone? Very good. This is called as puborectal muscle. This is called puborectal muscle. Okay. Now, what was the question that was asked previously is that how much angle, what is the angle between the rectum and the anus? What is the anorectal angle? Anyone? Can anyone tell what is the anorectal angle? I think I should write it like this, right? What is the anorectal angle? No, Deep Sudhar, not 45. Anorectal angle. Prince Davis, Deep Sudhar, you're right. 90 degrees. Anorectal angle is 90 degrees. Anorectal angle is 90 degrees. Okay. That is the reason, guys, whenever you're sitting in the washroom, if you're sitting straight like this, right? If you're sitting straight like this, and if you're trying that you have to wash out everything, right? This anorectal angle, this anorectal region, whatever is there, it is compressed completely. So what will happen is that all the defecated metal cannot come out. It cannot come out. That is the reason why you should bend like this, right? Whenever you're sitting in the washroom, you know, the traditional washrooms, we have got 2-seaters there. So in the 2-seaters, we bend. So when you bend, what will happen is that this anorectal angle will become straight. This was the angle previously. It will become straight so that the feces will pass down. So stylishly, if you are sitting on the Western style and even if you are trying, you won't get it because it is compressed. Okay. So this is one of the important question. Clear? Next important thing is that they have asked a question about Denovillier's fascia and Valdeir's fascia. Denovillier's fascia as well as Valdeir's fascia. Where is this Denovillier's and Valdeir's? Anyone? Thank you, Mughal. Thank you so much. Sure. रॉबिन मैं ट्राई करूंगा माइक्रो भी ऐसे इजीली बताने के लिए, ठीक है? Denovillier's fascia and Valdeir's fascia. Okay, where is this located? First of all, what is this picture which I have drawn? So from front till back, what do I have, guys? In the front I have got pubic bone. Okay, and back of that I have got urinary bladder, and this is the urethra. On either side of the urethra here, near the neck of the urethra, I have got prostate gland. What is this? Prostate gland. And back side of that I have got rectum, and back of that I have got spine. Did you understood this picture, guys? Tell me first of all, you understood this picture or not? If I'm turning like this from front to back, what are the structures that are located here? Yeah, Very good. Now look here. Between the prostate and between the rectum, I have got a fascia, and that fascia is called as Denovilliers fascia. Simple. Between what? Rectum and prostate. Between rectum and prostate. Next important thing. Between the sacrum as well as the rectum, I have got another fascia that is called as Valdes fascia. Simple. Between the rectum and sacral vertebra. Sacral vertebra behind, I have got a fascia that is called Denovilliers fascia. So this is AB, right? This is AB. Very, very, very easy. Clear? Right. Another question that has been repeatedly asked is about the hemorrhoids, guys. About the hemorrhoids, they repeatedly asked the question. If you look at the anorectal region where the rectum meets with the anus, that region, okay? So this is the anorectal region, okay? In this anorectal region, I have got a line like this, teeth-like line. This is called dentate line. Teeth-like line is called dentate line. Next, I have got folds like this. What are these folds? These are called as folds of Morgagni. These are called as folds of Morgagni. What is the question? I will tell you. This is called folds of Morgagni. And I have also got a small line here. This is called as white line of Hilton. White line of Hilton. So above you have got rectum, below you have got anus. The anal canal. Anal canal. Okay, anal canal. Now look here, all of you. Whatever yellow color shading I'm doing here, this entire thing is called as pecten. This is called as pecten. Now listen carefully with both of your ears. Look here. Above the pecten is the rectum. From the rectum, sigmoid colon. From the sigmoid colon, descending colon. It means I'm going inside. So hemorrhoids are called as internal hemorrhoids. Below the pecten, that is rectum, right? Below the pecten, what is there? Anal canal, and then I will excrete it outside, anus, and then go out. This is called external hemorrhoids. This is first way to remember. So above pectineal line, I have got internal hemorrhoids. Right? And next, below pectineal line, I have got external hemorrhoids. So above I have got internal hemorrhoids, below I have got external hemorrhoids. Now, whenever there will be internal hemorrhoids, the patient will have painless bleeding. The patient will have painless bleeding. Wherever there will be external hemorrhoids, the patient will have very painful bleeding. Painful bleeding. While slaver, I'm sorry, but if you didn't understand anything, then I will clarify it. Is there anything that you didn't understand while slaver? I hope all of you are understanding, guys. You're understanding, right? Okay, fine. Okay, fine. So this is very, very, very important question, guys. Above the pectineal line, internal hemorrhoids. Below the pectineal line, external hemorrhoids. Painless, painful. I'm telling you guys, if they will ask you a question regarding the anorectal region, 100% they will ask you this question. 100%. Take a photo if you want. 100% they will ask you. Okay. Next important thing is that pudendal canal. This is another question. Pudendal canal. So what are the structures that are passing through this pudendal canal? So what will be the structures, guys? In my home, who will be there? My family. So in pudendal canal home, what it will be there? Pudendal canal's family. Artery, vein, nerve. So pudendal artery, pudendal vein, pudendal nerve. Okay, pudendal artery, pudendal vein, and pudendal nerve. Next important thing is that they will ask you about contents of ischiorectal fossa. Ischiorectal fossa. Ischiorectal fossa. Ischiorectal fossa contents are three. All of you. Ischiorectal fossa contents are three. What are those contents? Look here. Ischiorectal fossa started with which letter? I, right? So inferior rectal artery, inferior rectal vein, inferior rectal nerve. That's it. Inferior rectal artery, rectal vein, and rectal nerve. Your ischiorectal fossa is completed. And next important question which we forgot to discuss is that openings of diaphragm. Openings of diaphragm. Openings of diaphragm. Okay, so I will draw a picture, guys. Keep that thing in mind. I'm drawing the vertebra. This is T8 vertebra. After that, we have got T9, right? T9. Then we have got T10th vertebra. Okay, after that, we have got T11, right? Then I'm drawing T12th vertebra and some empty vertebra which are not needed. Where is diaphragm? Diaphragm is like this. You see, diaphragm is in this way, hemi-dome shaped. Right hemi-diaphragm, left hemi-diaphragm, like a dome like this, right? So I'm just drawing only one part of it. Let us say this is how the diaphragm is located. Okay, this is how the diaphragm is located. At the level of T8, at the level of T10, at the level of T12, we have got openings within this diaphragm. Okay, T8 opening, T10 opening, T12 opening. Okay, now this T8 opening, from this inferior vena cava will pass. That is why this is called as vena caval opening. Okay, so look here. Here we have got a inferior vena cava. Inferior vena cava. Okay, so that is the reason why you call this opening as venal canal, vena cava opening. Vena cava opening. And actually, what are the structures along with the vena cava? What are the structures? Inferior vena cava, one I told you. Another one is right phrenic nerve. Right phrenic nerve. Okay, and one more point I forgot, guys, that when I was discussing the neck region, I told you posterior triangle, the contents of posterior triangle, I told you to remember biceps. In that biceps, what is the P? P is phrenic nerve, right? I'm telling you, I told you all the blocks, but never ever give a block onto the posterior triangle, because if phrenic nerve is damaged, if phrenic nerve is blocked, then the main respiration muscle, the diaphragm, is gone. Okay, never ever block that phrenic nerve. Right. Next important thing. Here also at the level of T10 also, I have got an opening. Now through this opening, this comes all the way, and you know what am I drawing. So T10 is called as esophageal opening, because I have got esophagus, I have got esophageal branch of left gastric artery. Next, I have also got gastric or vagus nerve. So these are the three things. Esophageal opening. And very good. And finally, here we have got the aorta. Here we have got the aorta at the level of T12. That is the reason why it is called as aortic opening at the level of T12. But not only aorta, guys, you know what all structures which pass along with the aorta? Aorta will pass, thoracic duct will pass, and azygous vein will pass. Azygous vein also will pass from this. Okay. Right. Another important thing. Another important thing. We are about to finish. Yes. Another important thing is that this is your right lung. This is your left lung. Okay. Now don't ask me why right lung is bigger than left lung. The picture is like that now. Now all of you know that right lung has got 3 lobes. Left lung has got 2 lobes. Okay. Each lobe will have segments. How many bronchopulmonary segments are located in the right lung? 10. How many in the left lung? 10. How do you name them? How do you name them? Yes. The apex, the tip of the lung is always the apical part. So, apical. After apical, there is anterior. When I tell anterior, you should tell posterior. And there is a small, and there is a very good, all of you. Very good. Your answers are right. Dr. Benedict, it is not 55 or 523. Right? And there is a small tongue-like lobe, that is tongue-like segment, that is called as superior lingular, inferior lingular. Okay? Simple. So this is all you have to remember, and the remaining everything will flow automatically. Remember SMALP. S stands for superior, M stands for medial, A stands for anterior, L stands for lateral, P stands for posterior. So superior basal, medial basal, anterior basal, lateral basal, and posterior basal. Posterior basal. The same, how many? 1, 2, 3, 4, 5. Put all the 5 segments here. SMALP. Okay. Then what are the top 3? Top 3 always I told you. The first one will always be apical. After that it will be anterior. After that it will be posterior. What will be the next two? What will be the next two in the right side, guys? Very good. Very good. I thought you would tell superior lingular, inferior lingular. On the right side, it is only one difference, that is medial lateral. Medial lateral. So how many bronchopulmonary segments? 3, 2, 5. Yes, I'm sorry, Benedict. Here we have got 5 and 5. So totally 10. 10 bronchopulmonary segments. Simple. Right. Another important point is that what artery supplies your SA node? SA node is supplied by right coronary artery. 65% of the blood supply is by right coronary artery, whereas 35% of the blood supply is by left coronary artery. Why am I writing the percentages? Because if they give you both options, then you should choose right coronary artery. Okay. Next important question. AV node. AV node is supplied by which artery, guys? Very good. AV node is also supplied by right coronary artery. Then bundle of His. Bundle of His. That is also very good. Supplied by right coronary artery. Then what about right bundle branch and left bundle branch? Right and left bundle branch are supplied by left coronary artery. Yunus, it is left coronary artery. Left coronary artery. Now let us discuss about the topography. At which level the pancreas are located? Yeah. At which level the pancreas are located? They are located at the level of L1, L2. At which level the left renal vein is located? I have already told you. They are located at the level of L2. Next, celiac trunk. Very good. Very good. Superior mesenteric artery, inferior mesenteric artery. Very good, and very good. Celiac trunk is T12, very good. Yashwant, very good, Yashwant. Superior mesenteric artery is L1 and inferior mesenteric artery is L3. Okay. Next, when it comes to arch of aorta, arch of aorta starts anteriorly, it will make a turn posteriorly, and arch of aorta will end. It means it is starting anteriorly like this, it is going posteriorly, and it is ending at T4. It ends at T4 posteriorly. Next important thing, tracheal bifurcation. At which level does the tracheal bifurcation happens? Yeah. Very good. Med student, perfect. Perfect. T4, T5. You guys are really pros. Bakwar Sharaf, very good. Excellent, excellent, and excellent. Very good, and very good. Right? Right, guys? So you understood this? So you understood these topics here? You understood about the hemorrhoids? You understood about the vena cava openings? All of you? You have any doubt, guys? Yeah, Jaggi. Right. So, guys, I have again, I'm telling you, we cannot complete all the topics because you need not to complete all the topics, guys, because most of the questions, they are just, they increase a lot of tension in your brain. I'm telling you, non-clinical subjects are anticipated subjects, which means questions they keep on repeating, right? And today I'm telling you, I have covered lots and lots of questions. I think this will be more than enough for you, but whatever it is, but still, no matter how much you discuss, there is something always left. So what I'll be doing, so all what I'll be doing is that, guys, I'll whatever important topics or important points, whatever are there, important charts or whatever are there, daily I'll be posting them onto the Telegram group. Okay, daily I will post 2 or 3 charts or 2 or 3 questions. Okay, so if you keep on doing those, that would be more than enough. I think you will cover all of them. And one more important thing I'm telling you guys, whatever I have taught today, right, whatever I've taught today, read it again and again and again and again, because honestly, I'm telling you, many questions will be covered from the topic so far, whatever we have discussed. Okay, physiology revision is there. Yeah, we have given that chart over there in the YouTube community. So physiology revision will be there. Tomorrow there will be PSM revision. Okay, PSM revision. PSM, how many marks? At least 30 marks. Anatomy 17 marks you will get, but PSM 30 marks. So attend the PSM session. Okay. So guys, whatever is there, I'll be posting, and these notes within half an hour. I'll post after the dinner. I'll post all these notes onto the Telegram group. If you are not on Telegram group, so the link of the Telegram will be posted below. Jonas, what you do is that look in the channel, okay, in the community post and all, you will find the link of the Telegram group. So please join there. Okay, I'll post all the notes. I'll post all the important questions. I'll post whatever I feel that is important for this December FMG. Okay, guys. Link is not working, then I will repost the link. Okay, I will repost the link, and I'm really happy that 88, 89 members are watching this patiently, and honestly, I'm telling you guys, you work hard, definitely you will excel. Okay, definitely you'll excel. Thank you so much. Goodbye and love you all.